morning, everyone. Thank you for joining us even on a Sunday. Hope everyone is having fun watching these sessions. I am Sushma Patil and my co-moderator is Ms. Reena Trivedi. We'll be moderating this session. It has been a great pleasure to witness the growth of BGCI from 40 genetic counselors to more than 160 certified genetic counselors now. This feat wouldn't have been possible without a strong backbone of advisory committee. It is an honor to be introducing one of them today, Professor Shirley. She'll be talking about her experience in genetic counseling and genetics and way forward. So she is Emeritus Professor of Cancer Genetics, St. George University of London, UK, part-time consultant in Leicester, and advisory committee BGCI. Her main research interest is cancer genetics, and she has co-authored several books, including Inherited Susceptibility to Cancer and A Practical Guide to Human Cancer Genetics. She has contributed to several seminars, including clinical cancer genetics, medical genetics, and therapeutic implications of muscular dystrophy genomics. She's been a clinical geneticist at Addenbrooke's Hospital, later on at Guy's Hospital. She's specialized in cancer genetics from 1989, so she comes with a vast experience in cancer genetics, and she's been instrumental in setting up cancer genetic services at Guy's Hospital, St. Mark's Hospital, and St. George Hospital. I'm sure it would be an insightful talk. Over to you, Professor Shirley.
Well, hello. It's an enormous pleasure for me to speak at your conference, and I think it's a very exciting time for genetic counseling at the moment. I noticed that you've had a great increase in the numbers of your genetic counselors, and I congratulate you. I want to show you a little bit about what we feel in the UK and elsewhere about the role of cancer geneticists, clinical geneticists. And I wanted to start with a story about a European study that we did on cancer genetic services in the good old days when England was part of the European Union. So we did a study of cancer genetic services in all different European countries. And we found very clearly that the countries with the best clinical cancer genetic services were those that had a significant role of genetic counselors. It was interesting that at that time, genetic counselors were not part of the team in many countries, but certainly was in England. So currently, the role of genetic counselors is mainly based in regional genetic centers and genomic medicine hubs, where it involves genetic testing, test interpretation, and cascade testing, so testing of relatives when you found an alteration in a gene, which is important, and management of the family. Increasingly, though, the genetic counselors are going to become involved with multidisciplinary teams in mainstream medicine, and I want to talk a bit more about that later. Also, an important role is in professional training for up-and-coming genetic counselors, and research and health policy is something where there is a contribution. So I wanted to start by talking about some common dilemmas in counseling, which have been present really since it all started, but are even more important now with genomic medicine. So interpreting genetic tests can be quite difficult, and sometimes it's not quite as clear-cut as one would wish. So explaining the implications of a genetic test to an affected person, sometimes explaining uncertainty in the fact that we don't always know everything about the result of a genetic test. Cascade screening, then interactions with the family, so you may wish to offer the test to other relatives, such as the children of this person, which of course brings into the next thing, which is what age do you offer these tests to children? And do you offer such tests in pregnancy? So genetic testing in children has generally been thought only to be relevant if the condition is manifest in childhood, where you can do things which will ameliorate the situation for the child. Otherwise, it's considered that probably it's best to leave genetic testing until the person is an adult, because otherwise they may feel that their parent has coerced them into some kind of test that they may not have wished. So that's the general rule, but certainly in cancer genetics, we often test children because you may need to start screening and management before they are adult. Testing in pregnancy is another difficult area. The first important question is, for which conditions should this be offered? And obviously this is going to differ in different countries with different cultures. And is prenatal testing or prenatal genetic diagnosis the most appropriate thing? There are lots of dilemmas with this kind of counselling, such that implications, for instance, that if a couple have a test and then the unborn baby is affected and they decide not to terminate the pregnancy, then of course this baby will have been tested already by the time it's born, and will so that's a sort of way of testing a child before it's even a child. Also, it's making decisions at a time of high emotional tension and under a time limit, so that makes things even more bit difficult. And couples can have different views and experiences of the condition, so it may cause some discord between them. Now, one of the big issues in genetics all the way through is the issue of confidentiality. And there is this concept that perhaps in genetics, it's not just the individual who owns the result, the genetic test result, it's the whole family. And there are a lot of people who favor this second idea, but this may not be very easy to explain to someone who's feeling that their privacy has been violated. Genetics, rather different from other disciplines, involves families, and genetic information about one person often has implications for their relatives. But at the other side of it, patient confidentiality and autonomy are cornerstones of our genetic counselling. So there are tensions between maintaining a duty of confidentiality and disseminating genetic information. And I must say, it is very rare that I feel that I've had to go against the wishes of somebody in a family. Usually you can persuade and cajole people to give information as appropriate to their relatives, but it's sometimes quite difficult. So you could ask, why do some people not wish to disclose the result of their test? It may be partly denial on their own part. They may not wish to be the messenger of bad news to their relatives, or they may have a desire to protect their relatives. We often find perhaps that the family has conflict between different branches of the family, or difficult family relationships. And often perhaps they don't feel that it's the right time, or they don't know how to give this information. So genetic counsellors have a huge role in this. They can help identify what barriers there are to disclosure of the result. They can help to develop strategies to overcome these barriers. And they can discuss also when and how to communicate with their child or relative the information that they have. And the genetic counsellor can provide written information and also support contact details, and also help them recognise the implications of non-disclosure, which of course could involve some harm to their relatives. So those are all very important issues which have been part of genetic counselling since it all started. We've all had with the pandemic is that many of us, including myself, have been doing remote counselling, mostly by telephone in my case, although Skype can be arranged as well, but it's a bit complicated. There are places, for instance, in Australia, where there are huge areas to cover, where this is already being done. But certainly where I'm working, we are finding that it's really quite good, although there are some difficulties because sometimes you don't feel that you communicate so well. There's not the body language. that is easily to come through. But I find actually women are more easy to counsel than men. I don't know why. And our experience is mostly good, but we do find that the administrative burden back in the department is high, because there's a lot of sort of finding of things and sending off of forms and stuff, which is difficult to do remotely. And one particular difficulty I've been experiencing is that if a patient is offered an appointment and they don't want it, they could just sort of not turn up. But if you just ring them, then you may find that it's a problem, because then they tell you lots of things that are bothering them, and it takes a lot of time, and they didn't really want the appointment. So that's a possible disadvantage. More important, though, I wanted to talk about contemporary changes in practice in terms of the new advances in genetic testing. Now, genetic panel tests are often used nowadays, where you use a panel of, say, 10 or 20 relevant genes, of which only one is likely to prove positive, if any, or whole genome sequencing, or whole exome sequencing, which, of course, tests an enormous number of genes. But the issues, in a way, are the same, because you have to explain to patients that you're looking at a number of different genes, most of which will be fine, and you can't really tell them all about the different genes that you're testing, because that would take forever. But you do know that they may detect unexpected variants, and this may be difficult to explain. And it's important really to try and explain to the patient what information is going to be available, and what do they actually want to know about. Do they perhaps not want to know, for instance, if they've got the Alzheimer gene? And of course, it's also important to tell them about variants of unknown significance, which may be difficult to interpret. And it's important, I think, to tell people before the test that this may be an outcome. So with whole genome or exome sequencing, there's a greatly increased chance of identifying pathogenic variants, but also there's an increased risk of developing many variants of unknown significance. And these may be difficult to interpret. And the other main issue is that there may be a variant in an off-target gene not associated with the phenotype, which you may detect. And if you find, for instance, in cancer genetics, if you find an alteration in the CDH1 gene, which very much increases the risk of gastric cancer, if you find it in a sporadic case, it may be much less likely to occur, much less penetrant than if you find it in the familial situation. And so it's often quite difficult to know what kind of screening to offer in this sort of situation, because current management guidelines are based on studies of variants which segregate in families. Other specific issues in genomic medicine is, for instance, that genomic information is complex, and much genomic variation has very limited or uncertain significance, and may cause great anxiety when it's probably not very important. Some genetic variants may only predict disease in the context of disease in the family, as I just mentioned. But the other issue is, of course, information on one person may still have implications for their relatives. And of course, you may reveal unexpected information, for instance, with paternity, maybe not what it was expected to be. So the utility of genomic medicine at the moment depends on the ease of interpretation of the variants detected, the size of the risk from the variants detected, whether it's actionable, so can you actually reduce the problems related to the variant when you know that the variant is present by, for instance, screening in cancer genetics, and of course, importantly, whether the patient wants to know about it. And preserving confidentiality may still be in conflict with providing healthcare to their relatives, which was, of course, the old chestnut we talked about before. Then you say, well, we've got this magnificent tool becoming cheaper and cheaper to be able to do whole genome sequencing or testing with a number of different genes. Should we be testing more people more widely? well, of course, you could, but then we need to make lots of decisions like what genes should be tested, who will counsel the patients, and importantly, what are the cost benefits? Because if you look for variants that don't alter risk very much, then maybe it's not cost benefit. There's not much cost benefit to doing the test. And this all leads again to this business of mainstreaming of genetic testing. And I'll say a little bit more about that, because genetic tests are now becoming more and more available to non-geneticists, so pediatricians, endocrinologists, surgeons, and so on. And they may, so far, have limited understanding of the relevance of genetic tests, but it sort of leaves the role of genetic counseling much less clear, and it's important possibly to try and get genetic counselors involved in the multidisciplinary team meetings as much as possible, and possibly even in the clinics, where they can have a role in interpreting difficult genetic data for people who are not so familiar with how to do this. So at the moment, I think many people feel that the best approach for the population in terms of applying genomic medicine is to ascertain individuals carrying mutations in high-risk genes, not those with mutations or variants in lower-risk genes, and improve the risk estimates for mutation carriers, do cascade testing as in the traditional genetics, and avoid the low-risk SNPs at the moment. So we know that some companies have been offering these tests direct to the consumer. And these are certainly available if people have got the money and inclination to do it. Unfortunately, it's quite difficult to understand some of these test results. And I've certainly had people turn up in the clinic who've done this and say, oh my God, I'm going to die of colon cancer because I've got this variant. And then you look at the variant, which causes an increased relative risk of perhaps 0.5 or something, which is really not actionable, but has caused a great deal of anxiety and needs a lot of explanation. So it's a bit of a difficult tool, although they may also uncover a high-risk gene alteration. And then, of course, you need to counsel them about the implications of the high-risk gene mutation so that they can access the relevant management and risk-reducing options. So the expectation in the public may be a little bit over-egged. So lastly, I just wanted to mention genome editing. This isn't with us yet, but my goodness, it's coming fast. And I'm sure you've heard about this. The ability to alter the genetic code is round the corner. Well, it's here, but it's a matter of how can we apply it in cancer, in clinical genetics. So what is possible? What are the risks? What do people want? And what regulations are needed? So just as a little example, this is a picture of Angelina Jolie, a well-known actress, who has got an alteration in the BRCA1 gene, so she got an increased risk of breast and ovarian cancer. Now, we could offer her genome editing of her eggs or embryos, which could correct the BRCA1 mutation, in theory. This would not help Angelina, but it could allow her to have children without the mutation. But of course, this could also be achieved by pre-implantation genetic diagnosis or prenatal diagnosis by identifying the embryos that don't have the mutation and only re-implanting the ones that don't. Of course, this is all very complicated and expensive, but those are all things that are possible. So the technology to correct single gene genetic disorders is already here. But most diseases we know are multifactorial, are caused by several or many genes and environmental factors as well. So genome editing isn't going to really be able to have much of an impact on those conditions. And of course, then these awful things about eugenics starts to raise its head. You know, are we going to engineer babies that are better and more splendid than the ones before. And of course, the other thing is these things are very expensive, so they would only be available to people who got lots of money at the moment. So the regulations, anyway, till last year for genome editing in Europe, as far as I know, is that you get the green light for genome editing for basic research, including embryos, and somatic gene editing to treat diseases. So that would be just in the tissue which is affected. That might be possible. The yellow light, sort of amber warning, is for genome editing to treat serious diseases, which might be possible where no treatment is available and the safety has been evaluated. But at the moment, there's an embargo on somatic or genome editing for enhancement purposes. And of course, this is all up for development and thinking about, but we've got to think about it really carefully before it's all upon us. So that was what I really wanted to say. I just put this up as a nice reference from the European Journal of Human Genetics, which is a viewpoint of the role of genetic counselors in genomic healthcare in the UK in this situation, but it's quite a nice, fairly recent reference, which is quite helpful. And I'd like to finish there, but I think it's a very, very exciting time, lots happening, and the role of genetic counselors is becoming more and more exciting and important as we transition in a way from genetic counseling only being done in the genetic centers to being done all over the place. So thank you very much.
Sushma, ma'am, please continue, ma'am.
Yes. Thank you, Professor Shirley, for sharing your experience with us and such insightful things into what are the dilemmas that we can face with the new era of genome sequencing, and also what kind of challenges that we can face when it comes to genetic counseling. We will not, unfortunately, will not be able to take questions at this time, but please do email across your questions. We'll forward it to Professor Shirley and she will send across the answers to you. Now we'll be starting with another interesting session on mainstreaming genetic counseling into healthcare. We have come a long way from people not knowing what was genetic counseling to now an increasing demand of having genetic counselors in a clinical settings. That is all thanks to clinicians as well. Without their support, we wouldn't have been possible to make this. Today, we have 3 clinicians and 2 genetic counselors who have made this ecosystem work. We would like to learn from their experiences. How did they make this possible? This session is chaired by none other than Dr. Davendra Kumar, who has been a pioneer in creating awareness of genetics and genetic counseling across the globe. He's a clinical geneticist working at NHS Wales. He's one of them who has established a postgraduate certificate and diploma course in genomic medicine and healthcare of the University of South Wales. He's founded and leads the Indo-UK Genetic Education Forum and the UK-India Genomic Medicine Alliance. He's initiated major collaborative works with India's leading medical scientific academic institutions and also King George Medical University, Lucknow, UP, followed by many other institutes in India and Sri Lanka. He is the chief serial editor for Advances in Genetics and serves on editorial board of many biomedical journals. His interests mainly lie in pediatric genetic diseases, inherited conditions of heart and blood vessels, and also genomic medicine, genomic applications in global healthcare. He has edited many textbooks and monograms in the field of clinical geneticists, cardiovascular genetics, and genomic medicine and healthcare. He started various projects of huge impact to all of us, which is GC4GE, which actively engages with different organizations, which engages with Human Genome Organization International, Human Variome Project, and many others. Over to you, Dr. Davendra Kumar, to take it over. Thank you.
Thank you, Sushma, for a very kind introduction, rather humbling and bit embarrassing, actually. So I must say good morning from UK. Say 5 to 7 in my on my TV, on my computer screen. So let me begin the session. I just by screen share my own presentation. I think the previous one is still on, so that could be removed, stopped, I mean. No, this is the old one. So, can you see my presentation? Is it visible?
Yes.
Put it on slideshow mode.
Okay. So I will start, I think, the slideshow. So we are here for the sixth annual conference of the Board of Genetic Counseling in India, one of the leading forum for training, education, and promoting genetic counseling across. It is started as a very small initiative by Dr. Annie Hassan and her colleagues in Hyderabad. And fortunately, I have been associated from the start, and we are actively trying to get official recognition of genetic counseling. And we have been successful to get some within the Government of India skills program, genetic counseling as a recognizable occupation. So future is getting a bit better. So apart from me, we have got a very important and a strong panel, which I will introduce one by one. And as Sushma introduced, the main theme of the session is a mainstreaming genetic counseling and the way forward. And I think this will tie up very nicely with the Professor Shirley Horson's talk on genomic medicine and genomic counseling. I think that's a good background. So let me just take one by one. The first panelist is Dr. Shailja Tribhuwal. She is an ophthalmologist with interest in genetics. Just to mention briefly, there are many genetic conditions of the eye, especially in children and including adults, which are often missed, and they're mixed up with some nutritional conditions, some other metabolic acquired infections. So they remain undiagnosed till there is a recurrence in the family. So there's a very important field of medical genetics. In its own right, it is a separate branch now. So that is very important to include Dr. Shailja in the panel. My colleague, Dr. Jayama Chandra Pilike from Cambridge, and also the chair-elect of the British Society of Genetic Medicine. She's one of the academic, I would say, genetic counselor who is pushing forward very strongly the role of genetic counseling in genomic medicine, and very actively involved with the Sanger Genome Center and other high-level academic projects. Ms. Tamam is a trained genetic counselor, and she's promoting this field in the Arab world, mainly from her base in Dubai, UAE, and I think that is very important sector of the developing countries where there's a need for genetic counseling in a specialized and classified manner. So she's welcome on the panel. Then we got Ms. Nibi, who's a genetic counselor in Bangalore, fully trained, and got many other avenues of working, and tremendous, very impressive career highlights, as you can see from this slide. And her interest is mainly in pediatric genetic diseases and prenatal genetics. So with this introduction of panel, I would just like to share some information as a background. Let me just remind ourselves what is a conventional clinical genetics service model. So if you look at the UK model or the USA model or model within India as we are developing, so generally traditionally it is hosted by the large tertiary teaching hospital, maybe a super specialty hospital in the private sector, and manpower includes clinical geneticist, genetic counselor, or maybe a genetic nurse with a special medical interest, and may or may not have the in-house diagnostic or research genetic genomic lab. And there are some other clinicians who might be indirectly involved. And in most cases, the referrals are indirect, so there's not much direct patient families and access. And we set out very specific outcome measures. Sometimes these outcome measures are difficult for the family or even for our clinical colleagues to appreciate. And sadly, in most cases, it is expensive, inaccessible, and inequitable. So that is the present situation, and that requires a lot of improvement.
Dr. Davender, sorry to interrupt you. We have one more panelist, Dr. Rajiv Sareen.
Oh, I'm sorry. He's my friend and colleague, so I think I was going to... Rajiv, sorry. Good morning.
Hi.
Rajiv, I think he does not require introduction. He's one of the most eminent cancer geneticists of India, and he supported my Indo-UK genetic education program from the start. We have had many high-profile or baseline cancer genetic seminars and courses, and every year we get together to organize Indian cancer genetics. So welcome, Rajiv, on the panel. Yes. So just to remind ourselves that as we stand, we have now expanded the field into many different branches, what we call the sub-special interest or special interest. Prenatal diagnosis, fetal medicine is, of course, the most prominent, very popular in India. And given the inherited metabolic diseases, the spectrum, especially the lysosomal storage disease in India and other Arabic countries and other developing countries. So fortunately, there is a bit of awareness for this group of conditions, which is very good. Clinical dysmorphology or birth defects or malformation syndrome is a very important area in pediatric genetics, and which is now gaining momentum. And we have, right from this month, actually, we have introduced the Sanger project here in India called the Decipher India Consortium. That is a very important addition. And other branches include neurogenetics, for example, in NIMHANS in Bangalore, cancer genetics, I just mentioned Rajiv Sareen. Cardiovascular genetics is under development by PGI, AIMS, and CMC Vellore. Ophthalmic genetics in Hyderabad, Dr. Shalja knows about it. Endocrine genetics is not organized, but there is a lot of scope because there are many children with growth problems and other endocrine conditions, especially in adults, like infertility. And genetic dermatology is a very important field. I'm not aware there's a special interest group within India, and other small groups are also emerging. So, so there are two approaches where we can expand to the mainstream. One model is called the interdisciplinary approach. I will highlight is cancer genetics as a main example, which Rajiv can comment on that. So if you look at cancer genetics, say in the main Tata Memorial Hospital in Mumbai, which has got its own genomic lab. And Dr. Rajiv Sarin is a medical oncologist. There are many pediatric oncologists also. They are in Tata Memorial. They have a world-class histopathology service. They have got world-class radiology service, and oncology surgeons are famous throughout the country. So that is a very good model, and I hope that this model is replicated across India without significant changes. Naturally, when you talk about the cancer genetics manpower, we will need clinical geneticists who have got a special understanding of cancer genetics, like Professor Shirley Hodgson you met earlier, and then genetic counselors. We have a special genetic counseling team for cancer genetics in the UK, and all part of the NHS system. So that is one model which we need to really think about and look at the possibilities of developing. Wherever, especially we can start from the large cancer hospitals, because I'm aware that India is going to have about 9 or 10 Tata Memorial-like hospitals in different parts of the country. The second model is very important, and I think this is much more practical model, which is a multidisciplinary approach. So each branch in its own right can function independently with overlap with the genetic and the genetic counselor input. So take, for example, of cardiovascular genetics, which happen to be my own area of interest. And then we have got general cardiology. We work them very actively. And we also use the genomic lab. And within that, we have got clinical geneticists like myself. We have got dedicated genetic counselors. We have got a general cardiologists, and they are special interest cardiologists, like for heart muscle disease, like heart failure, cardiomyopathy, and arrhythmia like long QT Brugada syndrome. And we have got specialized cardiac genetic nurses working for each special interest. And naturally, we need a very powerful cardioimaging unit, a highly sophisticated echo, and then, and of course, the cardiac MRI, very important. And this is a shortage. Very few people around the world are trained, qualified cardiac pathologists. When somebody dies, sadly, because sudden death, we need to know what was the status of the heart, what was the pathology in the heart. That's a very important starting point. Did the person have evidence of cardiomyopathy? If there was no evidence, then that person most likely had the electrical condition. And then, of course, we need a very good metabolic lab, chemical pathology lab. In most of the hospitals, they do have a good chemical pathology lab because lipid and serology and all those important bits are tested. But that requires a bit of more metabolic input. For example, you need to have the state-of-the-art proteomic element also added, which is not often present. And of course, we need to have the most up-to-date genomic lab, because increasingly we are moving very fast with exome sequencing in most cases, or targeted clinical exome sequencing for, say, heart muscle disease or arrhythmias or metabolic conditions. So this is a model which, again, I think, so we can have both interdisciplinary model and the multidisciplinary model being developed at the same time. If you want to expand our clinical genetics, medical genetics, or genomic medicine into the mainstream, that we have to work together with our colleagues in different branches of medicine. So coming to the other good example, which is already happening to some extent in different countries, it is the community medicine and the clinical genetics input. So take, for example, we talk about a newborn screening, we talk about the beta thalassemia, sickle cell, and G6PD diagnosis as early as possible in the child, so that we can manage the child accordingly. We don't want to miss hypercholesterolemia if it is present in the family, and the age-related breast cancer extreme mammography is in place. Coming to the pregnancy, as you know very well, the antenatal maternal serum screening is very popular. Anomaly scan is done by most fetal medicine units. Now we also got the NIPT in that respect. Then this is the one whereby the primary care team, a doctor on the street, a GP or practice nurse there can approach directly to that, and public health lab is involved. We come into scene later as a clinical genetics input. If there was real need, we don't come initially, but we come later on in a very selective manner. Similarly, other specialists would also be required to step in. So this is the model. I think if India has to start genetic in the mainstream, I think that's a way to start. We have to select, for example, there's no doubt the beta thal sickle cell, there's no excuse for any state not to have this kind of a screening at population level. A newborn screening is a must, and the breast cancer, I think Dr. Rajesh can comment on that, how far this could be offered within the Indian setting. I have got some reservations on antenatal because it leads to a lot of unnecessary expense, unnecessary anxiety, a lot of time is wasted, and a lot of intervention take place, and that needs to be properly regulated. I think I'm very bit cautious about that. So this is the role of genetic counselor in India, because most of the time they will be independent genomic counselor practitioner. And of course, they have to start with family history, then they have to look at the plan targeted testing, they have to offer pre and post counseling, and they will they'll come across many worried healthy person, especially through this genome card, which is not my favorite. Especially, I just came across about 2 months ago this genome patri. I was really horrified. It's a 20-page report, and this unnecessary information, and they're just going to make the person unnecessarily ill, and they will leave the job, may just go home, and I think we'll have a lot of problem, and the person may go into other things like taking alcohol and all those things to calm down the anxiety. This is a very difficult area, and I think society needs to be very careful, and we have a role to play in this one. Then of course we need to be equipped to promote clinical trials. We need to engage in data collection, especially for to sort out the variants in our population, for the Indian population, different population groups within India. And we need to be teaching and training our colleagues and public and media at the same time. As you've seen from the COVID scare, people had a lot of misinformation and a lot of fake news is spreading around. And I think, COVID-19 is a good example of how genomic medicine came rapidly into our community and society. So this one, thank you very much. I think I will stop here. And I think we start from, I'll bring the panel now. So what I will do now, I've got some questions which I will put to panel. And so the question for Dr. Shailja. Dr. Shailja?
Yes, sir. Yeah.
Let me put my camera.
Yes. Can you hear me?
Yeah.
Am I audible?
Yes.
Yeah,
yes.
hi.
Yeah. So two questions which you might know already. What inspired you to promote genetic counseling in your niche branch of ophthalmology? And what are your suggestions to promote genetic counseling in other eye hospitals? It's a very challenging question. I think maybe I think you can focus on the second one, which is the main theme of our session. What what did promote you for genetic counseling? That's, I think, very personal question. I think main theme of today, because given the time, limited time, let's listen. What are your views? How a practicing ophthalmologist on the street, in a district hospital, in ordinary district of Madhya Pradesh or Maharashtra, would expect how to educate that ophthalmologist awareness of the genetic eye disease.
Yeah, first of all, thank you, BCGI, for having me here. And thank you, Dr. Davendra, for that introduction and that excellent talk. Of course, both of them are very tough questions. I would like to begin with and tell a little bit experience of how I did it. In fact, I would say the first question, answer the first question, that what inspired me is actually the patients. Because these patients who have genetic disorders, they are like kind of put aside, saying that, no cure is there for them, and nothing more can be done. That is what most of the ophthalmologists, they perceive about it, that nothing more can be done because there's no treatment for it. So better to just take out the surgical cases where we can do something about them, and these which do not have any cure, just put them aside. So that is the thing which actually troubled me the most. And I'm being a pediatric ophthalmologist. 50% of my patients belong to this inherited retinal disorders. And some of them we can cure with surgery, some of them with some medicines, but most of them, of course, we cannot cure. But that does not end and always mean by heart by saying that no cure doesn't mean no hope. So that is what inspired to give them. The next step is actually genetic counseling, which I felt that if we cannot stop the disease in them, at least we can stop in the future generations. The second thing is to what else can be done to help these children, either with low vision or pertaining to their disease, if there is any systemic problem associated with it. In India, mainly most of the eye hospitals, they are standalone eye hospitals. So their contact with the rest of the specialities is mostly by referrals and not in the same building. So that is another challenge that comes to us. And otherwise, private practitioners also, to refer to a person outside, it is quite difficult. So I think first and foremost, how to mainstream it is to increase awareness towards it, increase awareness of what genetic counselors can do. You wouldn't believe, when I started it in my hospital itself, I put out a questionnaire to everybody asking, what do you think a genetic counselor can do? And I got very few responses because people are not even aware of their role. That is what is important in mainstreaming them, is to make their role, understand that it is important and what is all their scope. They feel it is only genetic testing. It is not just genetic testing, it is a holistic care towards the patient, linking them to support forums, following them up through their subsequent pregnancies, and giving them the best possible, linking them to even trials for where they can seek treatment for them or their future generation. So these are the additional advantages. I think first and foremost would be to increase the awareness, and that we can probably do by, in my own bit, what I did is, along with my counselors, that keeping lectures for our hospital, taking out snippets and for the genetic disorder and how genetic counseling helps, and circulating it amongst our peers. So maybe the next step would be to, integrate with the ophthalmology societies, the national and international societies, and, their through them to, give the importance of genetic counseling. These are some of the future steps which I feel we can do.
Yes, I think I entirely agree with you. As you know, we've got a very strong ophthalmic genetics unit in the UK. We are very lucky. I mean, I remember on one round of our Indo-UK program, I brought a team to Sri Lanka and to Bangalore. In Bangalore, we had a 2-day symposium on ophthalmic genetics, and Narayan Detrale, I think that's the name of the hospital. That was very successful, and we've got there's a lot of interest. I think the way I look at it, there are many missed diagnoses of rare eye of genetic conditions, and these families go around in circles. I mean, they go around and around, and unnecessary investigations, unnecessary medications. I mean, they are given unnecessary investigation in drops of different types of, They think everybody will think, oh, there is an infection or something. And the other question, which I think very important, which I may ask to you, what is your view on this expensive intraocular therapy for age-related macular degeneration? What is your view on pre-therapeutic genetic testing being mandatory? Let me put it this way.
Sir, being mandatory again, in my setup and my scenario, I think the cost is the most important hurdle. In fact, I wanted to discuss this with the panel also. Like, how do you afford for testing? As you mentioned, the injections or the treatment per se are so expensive. And then if you add the genetic testing to it, the option with the clinician is that, and most of the patients have to pay from their pockets. There's no insurance in India. So if they are given an option to test and confirm first and then go ahead with the treatment, they would rather shell out the money for the treatment.
Yeah, but my point, which I think also comes in Rajiv would add examples of very expensive cancer treatment. I mean, coming back to this condition, if suppose patient was not going to respond to expensive treatment for age-related macular degeneration because didn't have the right kind of genotype, so that would be waste. So would that not be cost effective to have the testing first, select your patient, counsel them properly, and then go for treatment, and you know what the response to expect. To have a clear plan. That is precisely what pharmacogenetics and pharmacogenetics approach is all about. I mean, you may look at in the literature many examples. You're prescribing anticoagulant, for example. If the anticoagulant will have you need to titrate the dose, whether to give a high dose or low dose based on the genotype. If you give very high dose, patient may bleed to death, or vice versa. You need to have that information. It is a question I think you need to discuss with ophthalmologists and what is their view, and then I think that's a learning thing.
Yes, so that's the way forward. Precision medicine and personalized medicine to every patient.
I think this is basically example of precision medicine.
Yeah.
You have a precise diagnosis by genotyping, and then you've got precise therapy for that condition. And you can expect what will be the outcome, isn't it? So you can set all the scene step by step, and otherwise you'll be all going in the dark. So I think we can stop here, given the time. I think Reena and Sushma are getting a bit anxious about the time factor. So the next one, my friend, Professor Rajiv Sareen. Again, Rajiv, the question selected here is, what inspired you to start genetic counseling unit at Tata Memorial Hospital? More importantly, right, I think that's, Rajiv is going to really have a small presentation. Yes, okay.
Yeah, thank you. So Davendra and BGCI, Annie, and all for inviting me. So I'll just tell you my journey. And why I tell my journey is because my journey was painfully slow. No one should have taken such a long time that as I have taken, and I see that others don't sort of go here and there as I did during my course. So my journey, so now we have 10,000 families registered in the cancer genetics clinic that I run. But that's over a period of 25 years. Tata Hospital should have registered more than 100,000 families because every year 30, 40 new cancer patients are 30,000. So I started in 96 as a registry, familial cancer registry. And it was both for familial cancers as well as for multiple primary cancers. And how it started, I'll just share that. I was a hardcore clinician. I did not care about genetics, because I did not know the importance of genetics in cancer at that point of time. And I happened to work for 5 years in the UK, Royal Marsden.
Recording in progress.
So I happened to work at the Royal Marsden Hospital for 4 or 5 years, got my fellowship in clinical oncology, FRCR, came back, And there used to be a genetics clinic there. Ross Eels, who was my senior, she used to do something. I mean, I don't know. But, and I came back to India, Bombay, joined as a consultant radiation oncologist in '96. Very soon I realized that I'm getting almost every week a patient with a significant family history. Earlier, I used to get one patient in maybe few months. And then I realized the way, being in England for so many years, the way I was taking history had changed. And that's why I was getting these families. And unlike many other syndromes in cancer, the phenotypic features generally are absent except for significant family history. And then there are other pointers, but you don't see classical, skin or other changes or the in the habitus or the facial features. So we were missing, and that's how we started the familial cancer registry. And then I realized that it is becoming too much. Then I had two MD students because there was no one in genetics. So I started helping. I requested them to help me and gave them, okay, we'll look at what happens in those who have familial breast cancer, what happens to their manifestation, bilateral difficulties and challenges and all those things. But then I realized it is too difficult. There was no lab doing BRCA testing in those days. And I used to tell them we will do that. And all the scientists were not really interested other than more as a scientific project. And I didn't have the wherewithal to write a scientific project, get it funded. So I tried to get away from this. But these families, they were the first time there was a medical doctor who was actually listening to their story. They just latched on to me and they said, no doctor, you said you will tell me something about my sister, about my daughter. And then I went into it as a doctor. I said, well, these families need help. And I sort of got into it. And then, but as a doctor in India and the oncologist, we're so busy. Tata Hospital is a mad place, so busy. So then I had some volunteers, Nina Bhatnagar, some of you know. One day she just walked in. I said, well, are you interested? And I trained her, and then some others. So just to, when I'm busy doing other things, at least they could enroll the families and do provide preliminary counseling. And then we started a weekly cancer genetics clinic at that time. Mostly with Nina and volunteers. And then from 2007 onwards, we had a daily cancer genetics clinic. We had a full-time genetic counselor along with Nina, Payal Mane, Gauri Pandit, Ariba, Vandana Kembavi, Ravindra Reddy, and of course many trainees. So so I trained all of them one by one. I myself, I'm not a trained genetic counselor, but whatever I had learned, I told them what is important, what to ask, what not to ask, how to be sensitive, how to take into account the cultural sensitivity, those aspects. And then we got funding from the ICMR. We set up a lab because, as I said, the labs those days, Myriad Genetics used to charge $3,000 or $4,000 for BRCA1, 2. Reliance was the only lab in India which was doing, they were charging 55,000, 50,000 for BRCA1 and 2. Majority of our patients couldn't afford. So we set up a lab, Pradnya Kautal and others. And then we started Sanger-based testing, initially 2 genes, then 4 genes, then up to 18 genes over a period of 5 years. Then we got it registered under the PNDT Act. We got into prenatal testing. And then through a large funding, ICGC. So through that, we got many other equipment and manpower and money we could do. And then from 13 onwards, we have been holding annual cancer genetics conference and workshop. And Davendra and his team from the UK, and some of you have been coming, and they're very useful. And the workshops are highly in demand. Last year, we could not hold the workshop, and we come out with handbooks. And we got the EUMQN, European Molecular Genetics Network, EQUAS, with them. And then recently this year, we started doing as a service, paid service, multi-gene hereditary cancer panel. So it has taken me 25 years. I do not want someone who starts now should take that long, but still it may take them few years. It will not happen in 6 months. It will not happen in 1 year. It will not happen in 2 years. Of course, that was in '96. BRCA1 was just found, BRCA1 and BRCA2. So this is, I think, in the cancer hospital, all cancer hospitals are busy. Most importantly, people are very territorial. And why I did not leave my original department of radiation oncology, because all my privileges came from that department, whether it's a secretarial assistant, whether it's an office, whether it is a PC, everything came because I was affiliated to an established department. To establish a new department, to get a room and all those things is very difficult. So I think that's a challenge. So whenever someone asks me, I tell them, first you find a place, you say at least even for half a day, even for 2 or 3 days in a week, you get that, so that you don't have to take family history outside of the So this is the number of families. If you see that now, in 2019, we had close to 1,500 families. We get 5 new families with hereditary cancers every day. A lot of them come for follow-up. You look what happened after the pandemic hit us in April and May and June. We had very few families registered our genetics clinic. First time in last 25 years, there was nothing happening really, and it just came to a stand still because it was not considered as an essential service. The treatment of cancer patient was considered essential, and then it has picked up. Still, we haven't got back to the original numbers because of the second wave, but hopefully we will come. I'll just briefly tell about what is the estimated annual requirement for just BRCA testing and counseling in India. So my estimated is this 75,000 need genetic testing, even if we use the modified NCCN criteria. So 25,000 ovarian cancer probands, so which is 60% of 40,000 incident cases with either a family history or high-grade serous ovarian cancer. Actually, this number would be higher because just a multicentric study has just been published, which shows that even those who don't have a high-grade serous ovarian cancer or those who don't have a family history, 15 to 20% of them have germline mutation in BRCA1 and 2. So that number could be much higher. So for breast cancer also, if we use a modified criteria that just 20% will still need those who have family history, bilateral or triple negative under 40. I'm not using under 60. And the relatives of BRCA carriers who would be found to have a mutation. So all of them would require pre-test counseling. Now, who will do that pre-test counseling? I think if you put all the genetic counselors of the country together, then also it will take them 10 years to do so many genetic counselings, pre-test. Then the issue comes when you have a mutation carrier. So we expect about 12,500 probands, which is 1/4 of the 50% probands tested. That's what we get in our country, and about 12,500 relatives. And there'll be VUS carriers. Our VUS rates is now close to around 15%. So these many people, so you would require, I'm talking, of course, every patient who had testing needs a post-test counseling, but these patients would need more detailed and, elaborate post-test genetic counseling. And so these mutation carriers, VUS carriers. So who will do it? Where will it be done? Do we have the wherewithal? Do we have trained people? Forget trained people. Even if you have trained people, do we have rooms, genetics clinic, where you would need 1 hour for each post-test counseling? So we did a little survey. One of my colleagues, she's a consultant radiation oncologist, but also pursuing a PhD with me for mainstreaming, and her main thesis is mainstreaming of genetic, counseling. And in the survey of the clinicians, oncologists, not just any clinician, oncologists, the reasons for not referring patients for genetic testing or counseling. So half of them said it is because of lack of physician awareness, and a third of them said it's lack of patient awareness. Then very important, paucity of time, lack of infrastructure, prohibitive cost, long turnaround time, patient denial, laziness or callous attitude, apprehension, and several other factors. And 1 in 5 did not really answer. They didn't know the reason, but they knew that it is an issue. So with this, I will end. It has taken me so many years to develop a team, the lab, the clinic, and support from various agencies, especially the ICMR and ICGC and intramural also. So it's not an easy journey, but I think once you see that this is a clinical issue, your patients and their families need help. As clinicians, we always figure out where to get the resources. It's not easy because the people who are the administrators and all, they sometimes do not value the importance of it. But I think the sensitization is happening at a very rapid rate, much faster than I had actually expected. And I think the market forces has really helped. All these companies which have come up, the NGS cost has come down, the turnaround time has, is much less. I think these companies, they are pushing, and now the therapeutics, because olaparib is there and other, immunotherapies there, checkpoint inhibitors. So I think that's recently we had the Olympia trial in ASCO, that patients who have a BRCA1 and 2 germline mutations, even giving adjuvant olaparib increases their disease-free and metastasis-free survival. And of course, we knew that data in ovarian cancer and metastatic and relapsed platinum, after platinum agents, ovarian cancer. So, and for checkpoint inhibitors, those who have a germline mismatch repair deficiency. So I think the changes would happen at a very rapid rate. There's no other way than practicing oncologists to understand the issues, mainstream. What I foresee, I will stop sharing the screen now. What I foresee the problem is that oncologists have to develop, like an orthopedic surgeon, they know the value of a physiotherapist. They would not dare do a big knee replacement or a hip replacement if they don't have a very good rehab team. Same way, no one would do a transplant if they know they don't have a good pulmonary rehab team, a lung or a heart transplant. Many practicing oncologists have not really understood the importance of a trained genetic counselor, how they can contribute. And because right now they are dealing with different things, the more and more they will do genetic testing, more and more viewers will come. And I believe 1 out of 10 families, I shouldn't say them, they are difficult families, but they are the families which will really challenge you. They will challenge you. They will pose so many questions. A practicing oncologist would be really, found wanting in so many aspects. So I think, and then so the mutual respect has to happen. And my only thing I need to say is for genetic counselor. Many genetic counselors are not really reading that much. I mean, just basic principles of genetic counseling is one thing. It's very important. But I think when you get, 100 gene panels, so many genes come. If your oncologist doesn't know, you have to know that. And that pathway. So you should not be sort of, looking, I don't know about this gene, about this pathway. So I think the task of genetic counselor not only to gain the confidence of the practicing clinicians, but also to keep up with the reading, and the literature is coming at such a fast rate. More and more data is coming, clinical data is coming, therapeutic data is coming. So I think it's going to be quite challenging, but I think there's no other way but to get over the situation. Thank you.
Thank you, Rajiv. You've really painted the journey, which is very similar to many other people's experience. I think other countries, even though we might have looked a bit advanced, but there was a time around in 1980s when I started joined medical genetics in Sheffield. It was more or less same situation around that time. I think it was not easy, but given the NHS infrastructure, I think we have been very lucky in the UK, which takes me to the next panelist, Gemma. I think, Gemma, you have a presentation?
Yeah, I have a few slides.
Please, I think you can start. I think you can, your questions. First of all, the USA-UK model of genetic counseling landscape, and then what are your views for mainstreaming in the in the Indian or developing countries context? Thank you.
Absolutely, thank you so much. Thank you very much, Dr. Kumar, and thank you very much, BGCI, for inviting me today as well. It's really nice to be here again. My personal background is I was a molecular geneticist, PhD trained molecular geneticist by background, and then I retrained in the US as a genetic counselor. But I moved back to the UK in 2014. So I'm just going to give a little bit of perspective around the different healthcare systems in the US and the UK. And it's been an exciting time to sort of make the transition between countries as genomics has kind of come on the scene, if you like. So the US and the UK have got very different healthcare systems. In the US, there isn't really a system. There's sort of lots of different types and lots of different models of provision. So it's quite fragmented, and it's often driven by insurance. And sometimes the insurance company is the same entity that provides the care for the patient. It's an all-in-one system, but sometimes they are completely separate. So there will be an insurance company that pays, and there will be providers that provide healthcare, and they can be very different. They can be completely different entities. There's lots of, the genetic testing laboratories also operate independently. They operate as independent businesses, with the healthcare professionals ordering tests from them and being reimbursed by the other independent entities that are insurance companies. So in the US, there's lots and lots of genomic medicine research and lots of research around how to implement genomic testing, large-scale panels, genomes, exomes, cell-free DNA testing into healthcare. So you can look at some of the really amazing studies that have come out of the CSER consortium. They've done lots of research with how more difficult to reach communities as well. So tons and tons of information, tons and tons of research. Genetic counsellors have been really, really involved in all of this. But there's not sort of the same top-down implementation as a country to say, we're going to do it this way. And there's not no sort of infrastructure to do that. So there's lots of things happening, lots of things being researched, lots of things being tried, lots of opportunity to innovate, and lots of businesses springing up in the space, all types of businesses, be them testing companies, be them counselling companies. But those innovators need to understand the different stakeholders that play in the ecosystem. And it's a very fast-moving system where there's lots of sort of opportunities to do things differently, to try things out. It's quite a different sort of contrast, I would say, to the UK. So in the UK, we have a National Health Service, and that's funded by taxes. It's a comprehensive service, and the principles of the service are that healthcare is available to all at the point of care, free at the point of care. So we all pay for the healthcare system through our taxes, and then we don't pay for healthcare when we need it. We just get the healthcare that we need based on our clinical need, not on an individual's ability to pay. So it's a very different way of providing healthcare in the country. And having said that, though, the health service is quite fragmented in different regions of the country. Not all care is provided the same. The payments are controlled more at a more regional level. But what has happened in the UK is that the promise of genetics and genomics has been really embraced by the government. It's an area of science that the UK is strong in, and so the government has a lot of interest in us doing genomics in the UK. So there has been a vision set out, and we are implementing at this time a national genomic medicine service. And what that means is that we have a centrally commissioned a service. So all the genetic tests are sort of paid for at the national level in England. And all the genomic testing laboratories have been somewhat consolidated into 7 regions of the country. So each of those regions cover quite a large number of people, sort of 10 million in population size. And this is a national service, which means you've got opportunities to be able to measure uptake of service. You've got opportunities to measure equity of service, so making sure you can reach all the different areas of the country and different demographics of the country as well. So there's different opportunities in those 2 different healthcare systems. Lots of opportunities in both, but different. So when we think about how the roles of genetic counsellors have emerged in the 2 countries, I think in the US, because you have this fragmented system where there's a lot of innovation, genetic counsellors, there's a lot of genetic counsellors as well, not enough to serve their population, but per person in the population, they have a reasonably good number of genetic counsellors. And the genetic counselling community in the US has really seized on the emergence of genomics and realised that it's really important for them to be involved. So they've really tried to ramp up the numbers of genetic counsellors in the US by having more training programs. And in the US, what you've seen is genetic counsellors working anywhere in their system where their skills are valued. So they have these traditional roles. I would say the traditional roles are working, in those clinics, like, but in prenatal clinics, in pediatric clinics with clinical geneticists, in hereditary cancer clinics. And, following that model, genetic counsellors have had clinical roles expanding into other specialties. So things like, within cardiology, etc. Genetic counsellors have also been very involved in sort of academic research, really driving the emergence of genomics and increased levels of genetic testing into healthcare. They also are often employed in genetic testing laboratories. The testing laboratories have found genetic counsellors to be very valuable, not directly counseling patients per se, but in understanding the test, how to present the test to clinicians, how to answer clinicians' questions, making patient materials, making clinician materials, all sorts of things, thinking about what tests should be developed, sort of interfacing with the healthcare ecosystem. There are lots of genomic technology companies springing up. So these are sort of newer styles of genetic testing laboratories, if you like. And that includes, direct-to-consumer testing offerings. You can have a genetic test for anything you want in the US. You can have a genetic test to see if your child's going to be good at football. You can have a genetic test to see what kind of wine you would like to drink. I mean, so there's lots of problematic areas sort of coming up as well, where so it's a very, very rapidly moving ecosystem, and genetic counselors are scattered through it all. Genetic counselors work in insurance companies. The insurance companies have found that if they have genetic counselors checking the tests for their whether or not the test is a reasonable test to be ordered, whether it's being correctly ordered by the clinician, they can actually make sure that they are not paying for tests that are incorrectly ordered. So there's that very much that role of sort of checking that things are being done well within the system. And there are, companies springing up to provide telecounseling services, online counseling services, et cetera, et cetera. So anything really you can think of in the genomic space is available or being tried somewhere, and genetic counselors are very much sort of in that mix. In the UK, the vast majority of genetic counsellors work in clinical genetics departments. So they work with clinical geneticists doing these more, I guess you would say a traditional role, but that patient-facing role where you're seeing individual patients and counselling them. So there are a small number of genetic counsellors that are starting to work in more mainstream specialisms, so starting to support colleagues in cardiology, ophthalmology, etc. And then there are a small number of us, like myself, where we have more of a systems role. So there are quite a few genetic counsellors now really involved in large-scale educational projects and programs, and involved in communication efforts. And I think when I moved back from the US to the UK, with the rollout of the National Genomic Medicine Service, that's the kind of role that I wanted to be involved in, because I really wanted to be involved in the development of the Genomic Medicine Service. It's really exciting. It's kind of unique in the world that we can do this at a national level. And so I felt that would be with the experience of coming from the US and seeing all the different types of things that could exist, I thought that would be an interesting place to practice. And so I'm actually employed in one of the genomic laboratory hubs. Now, each of these hubs cover a population of about 10 million people. And the reason that it's an interesting place to be working is because that's the point at which you can measure the effectiveness of your work. So you can see which tests are coming in from which clinicians, from where in your region. So you can measure whether, if you're doing any kind of intervention, you can measure the effectiveness of it. So you can see what works, and you can identify gaps and try and innovate around those gaps and think about what you could do. So, I mean, just thinking about the scale of the region, if we have about 10 million people, I think, I'm not quite sure, I've just did a back of the envelope calculation just before this talk. I was thinking, I think there's probably between 70 and 100,000 healthcare professionals, clinical healthcare professionals in the region that I serve. And my role is to educate and train them in genomics in order that the tests that patients are eligible to receive are ordered for them. So when we're thinking about mainstreaming genetic testing or genetic counselling into healthcare, I think when we think about the US, the number of genetic counsellors has been increased. So they can play a direct embedded role as a profession in this process. In the UK, we just don't have enough. So we only have sort of 200 to 300 genetic counsellors for a population of 70 million people. So we have to stare that reality in the eye, and we are not going to be able to provide pre and post test counselling to all the patients who are eligible for genetic testing and genomic testing through the National Genomic Medicine Service. So the reality is that other healthcare professionals need to be upskilled to be able to provide these sort of lightweight, at least, genetic counselling services, order the tests for the patients, have good discussions around testing so that patients are appropriately informed around the tests that they are receiving, and providing follow-up as well for cascade testing through families. So we have to train other healthcare professionals in genomics, and I see that this is a really important role for genetic counsellors. It provides an opportunity really to provide some leadership in service development as well. So when I think about even just thinking about training healthcare professionals with a limited number of genetic counsellors that we have to think about things that are scalable. So we can't necessarily do this always on a one-on-one, in a one-on-one way. So there are some things that are being done where genetic counsellors will go and be embedded in a service. So in my region, for example, we have a genetic counsellor who is embedded with nephrologists and she's going and spending a few weeks in each hospital in the region in the nephrology department. So she herself is becoming a real expert in renal genomics, and she is training the teams of doctors and nurses around providing the genomic medicine service for their patients within their area of practice. One of the things I've been sort of developing recently is a regional pediatric genomics forum. So we cover 30 hospitals, and we have, so each of those hospitals will have a pediatrics team, and we also have all the community pediatricians as well. And what we've done is we've gone round, and actually the pandemic's really helped with a lot of this work, because now our healthcare professionals are much more able to receive training via Zoom or via Microsoft Teams. And so we're able to virtually visit each of the teams in their hospitals during their training sessions. I just ask them when their session is, and then I just go and give them some training. And then what we've done is established a regional forum. So we have all of those healthcare professionals meeting once a month for an hour, and we can tell them about the service. We can sort of pick an area of pediatric genomics and give some training on that. So we can train them in how to have a good consent conversations with their families and patients. And we also record the sessions, and we've established a platform, and we put a lot of resources on that platform for those pediatricians, so they can see talks about the service, talks that are relevant to their practice, lots of resources, lots of where patient handouts can be found, etc., all in one place for them. And we sort of see this as a scalable way of training a lot of people at once, and we're hoping that as those clinicians sort of start using the service, that they will come to that forum and they will start presenting their own cases, and it will be led by the pediatricians as the service develops. So actually, it was really nice to see Professor Shelley Henderson reference this paper at the end of her talk. So this was a paper that came out from the Association of Genetic Counsellors and Nurses in the UK, sort of talking about the different roles for genetic counsellors in the UK in the genomic medicine service. So of course, we still obviously have this clinical role for genetic counsellors, talking about the test with patients, participating in multidisciplinary teams, counselling regarding the results. We're starting to move to a model where we're doing less pre-test counselling, and we really have to be upskilling other professionals to be able to order tests and then support those professionals when the results come through. So I think, in a lot of ways, that's a sort of a difficult thing for genetic counsellors, because they haven't been able to hold the family or hold the patient through the whole process, and they're picking it up afterwards. But it's, at the same time, it means that the service is accessible to more patients. We have genetic counsellors who are doing a lot of work in communication with the public around genetics and genomics, and a sort of key individual here in the UK is Anna Middleton, working in the Society and Ethics group with the Wellcome Trust. There are genetic counsellors who are involved in the education of other healthcare professionals, such as myself. So, but people can participate in multidisciplinary team meetings. There are actually individuals in genomics educational posts, which is like what I hold. People are involved in the development of genomic medicine curricula, teaching on the various university programs that have been established, developing resources for other clinicians, developing resources for patients. there's a whole slew of options here, providing talks, taping yourself providing talks so that they can be scaled. There's also roles for genetic counsellors in the establishment of policy and regulation, patient advocacy work. Genetic counsellors are really great, can be really great patient advocates, working with patient groups. More and more patient groups are looking to employ genetic counsellors so that when the patients come to them for support, they have somebody who's genetically trained within their charities to be able to support their the people who come to them for help. I think one thing that I'd really like to see more involvement with is in research. I saw a lot of this in the US. It's not quite as established in the UK. So, I mean, there are people who are doing research in communication, etc. But I think things like service improvement, actually researching a service, actually trying to develop the service and see what works and what doesn't work, and do that work as well. So there's just a ton of opportunity, both in the US and the UK. I think it's they're very different ecosystems to work in. I think it's great. It's been really helpful for me to work between them because it gives you a lot of ideas of things that you can try out that might not be quite as obvious if you've grown up within one particular system. But yeah, it's just really exciting times. And I think that the role of genetic counsellors is so important, having people who really know what they're doing with this area of medicine as we roll it out.
Okay, thank you very much. Thank you, Gemma. It's very, very useful thing and quite detailed. I think these models are very important as a top-notch models for other countries which have got limited resources or just developing. So large country like India would have different approaches because the health service delivery is not a central federal control. It is a state responsibility. And each state has its own budget, own limitations. So so that's why I think I also put a couple of ideas. And things are improving. I think the private sector is very keen to roll it out, which is, I think, not very helpful because of the cost factor. But nevertheless, it's a good start. So I think given the time factor, we need to move on. The next, I would like to invite Nibi, again, the same kind of theme, your experience from abroad. And then, of course, what do you think of mainstream genetic counseling in India within the healthcare, diverse healthcare system? So do you have slides, presentation?
No, Professor Davendra, I don't. I would just be talking about it.
I think just give us your, I think,
sure.
As the main focus, of course, the mainstreaming. You can give some examples from your experience abroad.
Sure, I'll try my best. I will try my best to be brief and to the point. Sushma, may I request you to please let me know when it's 5 minutes. I'd like to stick to 5 minutes, and so that there's enough time for questions if people have the question later, right? So just to some of you who don't know about me or who haven't heard of my experiences in India already so far, this is my 11th year of practicing as a genetic counselor. I trained in Australia and did my clinical placements in clinics in Australia and New Zealand, and returned to India to set up genetic counseling services and training programs. So in terms of challenges that I face as a genetic counselor who was trained abroad and came back to India to practice, I'd like to categorize it as two different sections. One is professional and the second is as a genetic counseling service provider. As a genetic counseling professional, like all of you mentioned, the challenge was, this was back in the year 2010. There were maybe 3 of us non-medical students who had gone abroad, trained as genetic counselors and come back to India. And there was zero recognition or awareness about what is genetic counseling, what does a genetic counselor do, and how to utilize a genetic counselor within the clinic and within the hospital system. The second was in terms of support. Being a genetic counseling student in Australia, all of the clinics, I think we had once a week, we would catch up to talk and discuss about difficult cases. So it translated as peer supervision and support, and that prevented burnout. And over here, I was seeing about 15 to 20 cases in a day. And needless to say, within a year, I was just completely burnt out. And what I hear from a lot of genetic counselors, even now, is that after a year of practice or after 2 years of practice, they've had enough and they don't want to go back to genetic counseling. They'd rather take up another role, and we're losing genetic counselors like that. And the third, and I think the most important, what a lot of genetic counselors will agree with me, is the remuneration, which bordered on the lines of almost exploitation. So here's the thing. If you hire a lawyer, for example, if the lawyer quotes a certain amount, you're just going to pay the lawyer. You're not going to say, hey, but you have only X years of experience, you've trained in so-and-so place, but this is India, and so you should settle for a certain amount. And I don't think that is really fair. So on the professional front, I think these were the challenges that I was faced with. In terms of my role as a genetic counseling service provider, it was navigating the healthcare systems and understanding where the referrals came in from. There was no straightforward referral systems. It's we connect and we network at a conference, and then the doctor knows, okay, you practice at so-and-so hospital at a clinic. And so because they know you, they send the patients across. But in my first role as a clinical genetic counselor, I worked in the same hospital in the clinical genetics unit, and the oncology department didn't even know that a genetic counselor existed in the same building, right? So that's how bad the awareness was. Second is the availability of supervision. Because there were just about 2 or 3 of us in the country, we were so held up in our own respective clinical roles that there was not enough time to really connect with each other and get to know or even talk about cases and discuss cases. And growth, that in terms of in your role as a genetic counselor, where is the growth, or where do you see yourself, or where does a company or hospital see you, and what's the plan for a genetic counselor, say, for the next 2 or 3 years? So these were some of the challenges, but I don't want to focus on that. I want to focus on what worked for me, and perhaps that will help a lot of genetic counselors who plan on returning to India and starting practice here. First, very important, find supervisors and mentors. We are trained in different programs. It is impossible to be experts and know everything that there is to know. So find supervisors, find your mentors to help you and to guide you with developing and building your competencies. It's really important that we don't become complacent and settle for, oh, this is what I've been trained in and this is all that I'll stick to. Especially when there's dearth of roles in India, I think it's important to focus on developing your own competencies, looking for untapped opportunities. You just need to look around, and opportunities are everywhere in the country, to be it to collaborate with a clinic, collaborate with a hospital, or for starting off even supervision groups and supervision programs. At this point, I really have to mention that I was extremely lucky to have a clinical geneticist who knew all about genetic counseling. She had traveled to the US and she had observed genetic counseling sessions and how clinical genetics units worked. And so this is Dr. Sridevi Hegde, and she supported me through and through in my role as a genetic counselor, no questions asked. And of course, my professor from Griffith University, Dr. Magdalene Peterson, she continued to support. We would connect over email and over Skype once a month to talk about difficult cases or difficult scenarios within the workplace itself and how to navigate it and what's the best way to go forward. So it's very important to identify supervisors and mentors early on in your role. The third is, each and every healthcare system and your workplace is going to be different. So don't expect to change or modify the system that you're embedded in. utilize the theories that were taught to you in your program and use those theories to work around the system where you're at. And I think that would definitely help. Go beyond the scope and look at projects that you're really interested in and that you're really passionate about. I think connect with other genetic counselors, with other clinical geneticists. And these are some of the things that will help you in your role as a genetic counselor, especially when you're coming back to India and settling in. In terms of strategies to mainstream genetic counseling into healthcare, I honestly think it's inevitable. And the real question we should be asking is, how can we innovate service delivery models, and how do we improve access to genetic counseling? I think that's the important question. So the classical geneticist model we know doesn't work in India just because of the disparity in the number of genetic counselors, clinical geneticists available versus the need in the field. So it's important to then utilize and look at the available resources and the healthcare model in place. These two actually shapes the delivery services. So just to highlight, I think in my years of working in India, there are 4 or 5 models that I've just observed. I don't think these are formally called these models, but there is genetic services or genetic counseling services led by geneticists. A very good example is in the field of rare diseases. Then we have the primary healthcare model. We have medical specialist models, so things like onco clinic, prenatal clinics, as well as ophthalmology clinics, population screening and newborn screening models, as well as direct to consumer right now. So if we look at a combination of these 4 or 5 models and we try to look at what works in those models and at what point can we really integrate genetic counseling services and utilize that, it could even be maybe cross-training genetic counselors, cross-training other healthcare providers, for example, nurses in the UK. Looking at the population, the sheer population that we have in the country, it's impossible to produce enough genetic counselors and clinical geneticists. So to me, I think we should think about satellite or outreach clinics that they've been doing in Australia for the last 15, 20 years or so. Look at training non-genetic staff in triaging cases and doing the initial risk assessment and making those referrals. Utilize telegenetics. COVID has come to the rescue for telemedicine and telegenetics. And I've seen that a lot of patients, families, doctors, hospitals are open to the idea of utilizing telegenetics and, of course, develop resources for policy and practice guidelines, involve community healthcare providers, hold community events, make sure that there's enough supervision available. And through all of this, I think it's the combination of integration, collaboration, and redistribution of professional roles that will really help in helping us mainstream genetic counseling. And at the same time, while we are looking at this, it is very important for us as a professional body, as a professional society, to really ask the question, are we setting our genetic counselors up for success? Yes, we have these training programs, but it is an area where there's new updates every other day or every other week. So how are we making sure that our genetic counselors feel very comfortable? They feel there's continuing education and opportunities for supervision. So yes, that's just in brief.
Yeah.
Great. I made it in 5 minutes. Thank you.
Thank you very much, Libby. Very helpful. As I said earlier about the Government of India Skills Department, and myself and Dr. Annie Hassan and a few other people, in fact, input from my colleague in Cambridge, Anna Middleton, who was chair of the AGNC at that time. And we put forward, I think the most important thing is that we need to have a core uniform training structure, and that requires skills and competencies expected from genetic counselor, you know very well. We have got now a lot of experience now coming from different quarters of the world to India, and we need to really put them together. Once we have got skills and competencies recognized and listed in the skills directory. And then, of course, it is also linked to, as you raised the question of remuneration. So once somebody is registered after proper training as a genetic counselor in the state health council, so the person would be expected to be remunerated accordingly. Then there will be no question, okay, fine, this is salary scale. If you're employed in a government hospital, that is a salary scale. And in the private sector, you'll be paid according to more or less that level, maybe a bit better level. So that is very important. Then we need to have widespread training programs all over the country. I give one example, you know very well, in terms of medical genetics, we have got DNB program now, medical genetics, only 4 centers in India approved. Then on 3 or 4 centers approved for DM in medical genetics training program. But the idea is that those are regulated by the National Medical Commission. Similarly, we need to have a genetic counseling skills and competencies as a core sort of this thing. Any listening, I think, and then yourself and all of you are most welcome to put your ideas, and so that we develop this thing and then we have a approved syllabus of training, and that syllabus should echo in all different MSc in Amritsar, MSc in Pune, MSc whatever, you know, and so that they are not different. So when they go for registration, the council body can see, okay, this person is like MBBS, you know, this person went through the MBBS curriculum, and then it should be given the degree MBBS and should be registered as a doctor. So we have to focus at that level. Otherwise, you are doing in your own small area, somebody is doing a small area. It's all very fragmented. We need to, time is right now, we to put together. Okay.
Absolutely agree, Dr. Davendra. Thank
you very much. You're listening, I think. So let's move on to the last speaker, Mr. Mam from UAE, from Dubai. Yes, hi, hello.
Hi, thank you so much, Dr. Kumar, and thank you all for inviting me. It's been a pleasure listening to everyone and their insights on mainstreaming genetic counseling.
Do you have your slide presentation?
No, I'll just be talking, and also I won't be taking too much time.
You know, I think first of all, you have to give us some idea about what is the pattern or status of genetic counseling in the UAE as a model of the Arab world, and secondly, what is the scope and what are your views for mainstreaming?
Definitely. So just to start a little bit about myself and where I'm currently working, because I feel like this is important to what I'll be saying. I'm currently working in iGenomics. We're a genetics lab. And the reason I mention this is because I cover genetic counseling for the entirety of the Middle East, excluding Saudi Arabia. So I am able to access patients in different countries in the Middle East, though I am physically based in Dubai. I'm also part of the Arab Association of Genetic Counselors, and we're a new association, but we're trying to raise as much awareness as possible to genetic counseling in the Arab world. So in the Middle East and in the UAE specifically, genetic counseling is new-ish. So generally, there hasn't been actual genetic counselors until very recently. And even so, there's only about 6 licensed genetic counselors all over the UAE, and less so in the general Middle East, not that many more. So here, right now, genetic counseling provided by genetic counselors is mostly done through the labs, private labs, rather than, it's not really integrated into general hospitals, whether it's specialties or just in general having a genetics department in a hospital. There are several genetics departments, but genetic counselors aren't available. So there's clinical geneticists, there's doctors who can explain genetics and talk about genetics, but no genetic counselors. There is one center in the UAE that's integrating a genetic counselor in the cancer department. So there is progress, but it's very, very slow and it's very, very difficult. Regarding how patients are referred, it would quite differ between a public hospital and a private hospital. For public hospitals, we have genetic departments, in which case we know that the patient is under the care of a clinical geneticist that can support the patient very similarly to how a genetic counselor can. Whereas in the private sector, it becomes more difficult because in the private sector, we're talking about the separate specialties everyone's mentioned: ophthalmology, cancer, cardiology, nephrology, etc. So in these cases, when a doctor wants to refer a patient, if they refer them to our lab offers free genetic counseling pre and post test because we know the importance of genetic counseling. And we do this either with the doctor present in the session, so we'd come to the clinic, or the doctors would send the patients to us, and then we would counsel the patients and send the doctor a clinical note and have a discussion with the doctor about how that conversation went. So as I mentioned, the mode of referral is variable, and it's very, very difficult to kind of get a one-size-fits-all answer here. The other thing that we need to take into account is that the cost of genetic counseling, genetic testing is very, very high. And I think this is the same all over. And over here, insurance mostly doesn't cover genetic counseling or testing. So as the fact that insurance doesn't cover genetic testing, it does become, there is a little bit of a disparity in the service because not everyone can afford it at times. Though there are several organizations that try to help patients who are in this situation that have a clinical need for the genetic test. Regarding mainstreaming, as I mentioned, mainstreaming of genetic services, like everyone else said, especially like Mimi said, I really loved your insights on this, is absolutely essential. We really should have genetic counseling in all the different areas of healthcare and all the different specialties. We should be able to not just have genetic counselors, but also upskill doctors to be able to provide pre-test counseling at least, and even post-test counseling in terms of understanding the results, explaining what the condition could mean and how we can move forward from this, and then be able to refer to a genetic counselor if needed. The one thing that we struggle with here in the Middle East is that the majority of the research and the data done regarding genetic testing and the different variants present is on white populations or Caucasian populations. And that becomes difficult to interpret genetic results found in the Middle East because of the amount of VUSs present, the insane amount of variants of uncertain significance, and the fact that there's very high consanguinity in the region. So that adds an extra added layer of difficulty because even physicians or clinicians who do know how to explain genetic testing kind of freeze when they reach a VUS, because at that point, what do we do with this variant of uncertain significance? And that's why educating clinicians, educating physicians about what genetic counseling is, how we approach these issues, the ethical issues in genetic counseling, who to test and when to test is absolutely important, and it's absolutely essential. And it's something that we're hoping slowly starts becoming routine here in the Middle East, with the support of the Arab Association of Genetic Counselors, with the support of physicians and clinicians who are interested in genetics, and really interested in pushing the genetic counseling position forward in several different aspects of healthcare. Like Gemma mentioned in the paper that you referenced, this is essential to have genetic counselors in many different fields, and we all work together within this healthcare system.
Thank you. It's very, very helpful. I think just one question. I think just might be it's very important. I think given the socio-cultural setting in different parts of the Arab world, and I think needs to be tailored, or should it be left to the person who's going to deliver the service?
Sorry, can you repeat that last bit?
I meant because of the variation in the social cultural beliefs and practices within the Arab world, some people might not like the idea of genetic counseling, especially in the context of consanguinity. So how does it really impact on the pattern or practice?
To be honest, not much. I feel like if you counsel the patient or the physician from the start and explain why you're asking the questions you're asking, why you need to have these answers, and you approach it in a very empathetic way, in a non-judgmental, non-directive, giving the patient all the information and really just being clear of, I'm asking this because 1, 2, and 3, I think it's a regular counseling session from that end. The consanguinity in the region is quite high, but also the education level has significantly increased since I started in the field of genetics in the Middle East. Because I get patients coming to me saying, we understand that there's a risk because we're consanguineous. So there is that increase in level of education, whether it's from patients themselves or physicians. Also, the countries in the Middle East, specifically the Gulf countries, are all starting to really work on a premarital screening program with widespread genetic testing, especially for consanguineous couples. So there is awareness in the region for this type of issue.
Good. That's good. Thank you very much. I think in view of time, we need to stop here. It's been a very interesting session, and I'm really grateful for organizers to really give me this opportunity and also to listen to different ideas. It was very helpful for us to take it forward. And I think I will certainly put across some of the views to people in the skills, government skills committee, the chairperson. I think the chairperson happens to be a famous heart surgeon in India, and he has been asking me these questions. And as I believe, unless we organize ourselves at that level, things will not improve. It took 5 years for me and other people, including Rajiv, to convince DNB, which is a body in India, who offers special qualifications. Now DNB in medical genetics is there, only 4 centers, and 4 centers are also in the pipeline, along with the DM. So we have got some trained, qualified medical geneticists who are registered recognized by the country as medical geneticists. So things are changing. So I'm pretty certain that in 5 years' time we'll have genetic counseling as a recognized specialty in India. So I will hand over to the organizers, Reena and Sushma, to close the session, please.
Thank you very much, Dr. Dhavendra Kumar. You have been a great source of inspiration, and you've chaired the whole panel discussion in an excellent manner. Thank you for sparing your time, sir. I'm extremely grateful to Dr. Rajiv Sareen, to Dr. Shailaja, Dr. Gemma, Ms. Tamam, and Ms. Nibi for having cooperated with us and willingly participated in this panel discussion. All your insights have been very interesting to listen to, and I'm sure the audience has found it a treat, just as we have. Thank you very much again.
Thank you.
Now we have the next session, Gene How, the know-how about current trends in medical genetics. It is from 1 to 2:30, we have Alone Yet Aloud, Voice in Unison, which is being moderated by Dr. B.R. Lakshmi. Please hang on and enjoy the next session. Thank you.
Hello, Dr. Annie.
Yes.
Madam, we'll start in next 5 minutes.
Yeah. So we are ready.
Yeah.
Aren't we? So we can. Hello, Dr. Kumar.
Hello, Annie. How are you? Good morning.
Good. Thank you. Good morning. Thank you for being on the panel and helping out.
I think we got a very nice spectrum of panelists with a lot of experience.
Hello, can everybody hear me?
Yes, yes, Annie.
Yeah. So we just finished a very interesting panel discussion about mainstreaming genetic counselors, and we are moving on to another very interesting panel discussion with voice in unison. Dr. B.R. Lakshmi is the moderator. Dr. Lakshmi's
recording stopped.
Dr. Lakshmi's profile is on the left side for all of you to see. All of us are aware of her academic excellence and her career highlights. But what I want to introduce while you read that, I want to introduce Lakshmi as the way I know her. Just one word flashes in my mind, and that is motivation, motivation, motivation. If you look at her, you get motivated. If you see her whole career, she has been motivated. Lakshmi is an extremely passionate person. And this I noticed when, for the first time I met her in 2009, when I had invited her to give a talk about Duchenne muscular dystrophy. Our friendship is not long in the terms of that I don't know her from childhood, but it looks as if I've known her from, various past generations, because things she says are the words which I would have used myself. She always says, together we'll make a difference. And those are words which I think all of us need to echo. She has done a lot of background work, and in certain things we are very similar. We want to take the knowledge of genetics out there to help people and families who are suffering with genetic disorders. And what's the meaning of this knowledge if it can't help our patients and our families? So there we are, we are just aligned. But there's something which we are not so aligned in. And that is Lakshmi's ability to work with the government and with the system. I am more of a freelancer. So Lakshmi is more focused, more motivated, and you will see that. And she's all encompassing. She gets the government, she gets the stakeholders, and to the same platform. And that's what we are going to see here. Over to you, Lakshmi, for you to carry on.
Thank you, Annie. No, they were present. Good morning, all. And I feel it a great privilege to be moderating this session, which is very close to my heart, alone yet aloud, a voice in unison. So this is on the patient advocacy or support groups. And of course, the advocacy group doesn't stand alone. So there are so many stakeholders, and we have tried to bring as many as possible. And so we will start with introducing the panelists, and then we would run through. So today, the way we have organized is, we have patient leaders, and to start with, we have Dr. Ritesh. Actually, he is a PhD from CFTRI, and currently
He is manager State Bank of India. Of course, he has been one of our very old patients. I know him for more than a decade. Wonderful, happy, bubbly person with all the challenges he has. He's currently a manager State Bank of India, and he's a institution. He's a member of our MDCRC's IRB, that is Institution Ethics Board. And of course, he, apart from the banking thing which he has been doing, he also is very sort of focuses on patient empowerment and contributes quite a bit on disability challenges which people face and how he contribute towards that. He's part of a good project under IIT Madras, which we are working again together. And so his highlights could be patient advocacy and rights and patient support leadership. I welcome Ritesh. It's wonderful having you. And the next is again one other patient leader. She's Shambhavi Ravishankar. Again, she's a Felix scholar and lawyer and Masters in Human Rights Law from University of Reading. And Shambhavi works in a law firm, and it's wonderful to have somebody from the legal side who understands what the patient goes through. And she works in a law firm in India on health and health tech. Her areas of practice include public policy, legislative research, human rights, health laws, and environmental laws. She also supports various rare disease organizations, mainly to mention the ORDI in advocacy, outreach, and awareness, and legal and policy support. She is on Global Genes Rare Global Advocacy Leadership Council. Finally, she serves as the director on board of the Alagille Syndrome Alliance, which is an international not-for-profit organization that is pushing for cure for Alagille syndrome as well as rendering patient support services. Welcome, Shambhavi. It's wonderful having you here. And next we have a parent representative. He is Mr. Baninder Singh. He's an entrepreneur by himself. He's a parent and a caregiver of a child with Niemann-Pick syndrome. Early diagnosis made it possible for him to go for a bone marrow transplant, BMT, for his child through crowdfunding platforms. Welcome, Baninder Singh, sir. And next, so we have patient leaders and parent of a patient. Then we thought we should have support groups led by clinician and support group led by researchers, because all of us form a nice network as such, and we need to get together. And here from the clinical side, I'm very happy to introduce Dr. Shruti Bajaj, and she is from SRCC Children's Hospital, Mumbai. Dr. Shruti has completed a MBBS, MD Pediatrics, and a year of University Accredited Fellowship in Clinical Genetics from the prestigious Surendas Medical College and King Edward VII Memorial Hospital, Mumbai. She has worked as faculty assistant professor in the Department of Pediatrics and Genetic Clinics at the same institution. She has also acquired training through an observership program in clinical and laboratory genetics from Kasturiba Medical College, Manipal University. She has to her credit a number of publications in national and international journals, a chapter book in the textbook of pediatrics on inborn errors of metabolism, and many awards, national and international CMEs. She is a founder and scientific advisor of the support group for Down syndrome known as PEHED, an initiative for Down syndrome. So here we have a clinician representing a disorder by itself, the Down syndrome. Next, I would like to introduce our lead scientist, Dr. Shalini Kumar. She's part of my team, MDCRC. Here we introduce ourselves as a scientist-led patient advocacy group. As a scientist, we have been working. So Shalini again has been with us for more than 5 years. From the start of our State Planning Commission project, she has a PhD in biotechnology, and she has over 15 research publications, both in national and international. And her interest, of course, now has been more on human genetics, data analytics, and public health. She has participated in research projects covering the entire state of Tamil Nadu in screening and preventing Duchenne muscular dystrophy. And she is also a part of the ICMR and Ayush project. Welcome, Shalini, to this team. And next, I am so happy and proud to introduce Mr. Prasanna Kumar Shirol, sir. And of course, I heard a lot of him. And recently, for one of our Duchenne, during the September 7th, we celebrate our World Duchenne Awareness Day. And in 2019, I'm just happy because it's just before the pandemic. He could come and see our work and he participated. It was lovely interacting with him. And he's a co-founder and executive director of ORDI, Organization of Rare Diseases India. And his career highlights are Prasanna sir serves as a co-founder in ORDI, an umbrella organization that represents more than 7,000 plus rare diseases. He has been instrumental in bringing rare disease issues at the national level, advocating for more than 15 years. His significant contribution has won him several laurels, including in 2018 when he won the Ashoka Fellow and the Rare Champions of Hope in 2019 from Global Genes USA. Twice nominated for the Hindu Business Line Changemaker Award in 2019 and in 2020. He is also a member and layperson of Central Ethics Committee of Human Research at ICMR, New Delhi, and member of the panel of expert WHO Collaborative Global Network for Rare Disorders. He serves as an advisor for many not-profit organizations. It's wonderful to have you, sir, and I'm sure making all of us come together here, we are going to take something very valuable to the decision makers of this country.
Thank you, Dr.
Thank you, Doctor. Thank you, Prasanna, sir. And next, I'm very proud, privileged, and happy to introduce Dr. Elizabeth Vroom. I've known her more than a decade. She's a mother of a Duchenne boy, wonderful boy. He's now 30 plus, Justice. And Elizabeth Vroom has been, as Annie said, if I think of Elizabeth Vroom, I can just imagine energy and really to fight out of what is really needed. And she has been the founder of UPPMD, United Parent Project Muscular Dystrophy, and she is also a board member of Eurodis, executive member of Treat NMD. So these are all great organizations in the West where she represents. And again, she is MD and orthodontist by training. She has lots of publications regarding care, drug development for Duchenne muscular dystrophy, and papers on outcome measures, patient preferences, newborn screening, and again, a paper on role of biomarkers. She's a co-author of a handbook on psychosocial aspects of Duchenne. She participates in several EU-funded projects such as Vision DMD, Share for Rare, Bind, and Trial Set. Her career highlights, as I have said again, she is a founder and president of Parent Project Netherlands and the co-founder of World Duchenne Organization. And again, she serves as several advisory boards regarding care and ethics and development of new medicines and regulatory issues in Netherlands as well as international ones. She is a patient expert and member of Patient Consumer Working Party at the European Medicine Agency. She's a strong advocate of optimal reuse of health data and took the initiative for projects and workshops regarding health data and prompts. So I welcome you, Dr. Vroom, and I'm so happy that you are here with us. And I'm sure you will share your experiences so that we can imbibe a lot and then work together in future again.
Thank you so much for this kind introduction. Thank you.
Thank you, Dr. Vroom. And now we have Dr. Roli Mathur. And now we have got, we introduced Mr. Prasanna and Dr. Elizabeth Vroom, representing both national and international patient advocacy groups. And now we wanted something from the government, the stakeholding from the government. And I would really thank Dr. Roli Mathur for accepting. She is a head of bioethics unit, ICMR Bangalore, for accepting our invitation. And Roli Mathur received the Young Scientist Award for her research in molecular genetics while she was at All India Institute of Medical Sciences, New Delhi, before joining the ICMR apex body for promotion of biomedical research in India. She pursued a fellowship in bioethics and ethics committee administration in the US and was trained by a surveyor of ethics committee in a WHO initiative. Currently, she heads the ICMR bioethics unit and involved in developing national ethics policy related to conduct and review biomedical research. I strongly felt the bioethics part is very crucial for something which we are trying to bring together. Of course, I had a nice chat and I really wanted her to explain to people how the general ethics and biomedical research ethics and what would be the differences. So it will be wonderful to have her inputs. Again, since 2017, she's been a member of the Executive Committee, Council for International Organization of Medical Sciences, Geneva, and is also a member of working group to develop guideline for clinical research in resource-limited countries. Since 2015, she is a special invite to WHO Zero Advisory Committee on Health Research for Ethics. She is an ICMR nominee to represent India at the WHO UNESCO Global Summit of National Ethics Committee. Again, she has recently joined the WHO headquarters expert committee again. And welcome, Dr. Rowley. It's wonderful to have you here. And finally, I have to introduce Mr. Sudarshan. He's a legal representative, and he has been working close with ORDR. And thank you very much, Mr. Sudarshan, for accepting to come and share your views on the legal challenges which we have while presenting up a policy to the government, and for bringing something which is so vast under the legal perspective. Welcome you all to this wonderful panel. Thank you. And I'm sure we are going to take really things forward, which the patients really look forward to.
Thank you, madam. Nice to be here.
Thank you. Thank you. And we're all here. And I just share the screen to make a little start for whatever we are doing. So, I start to say, Ano Bhatra Kratavo Yantu Vishwatah. Let holistic, noble, sustainable inputs flow from all sides. That is a prayer, because we are all we need to get together. And it needs to be holistic, noble, and it needs to be sustainable. With that prayer, I start.
Hello, Dr. Lakshmi.
I hope you're able to see the screen.
Dr. Lakshmi, we can see the screen. Just click on the hide. Can you hear me? Neerav, hear me. Hello. Dr. Lakshmi, can you hear me?
So the whole thing looks dark.
Dr.
We can
Lakshmi?
see light lit by us here and there. But the dawn is coming, and we need to get together. And today it is on patient advocacy. So today we are on the patient advocacy and support groups, and where we are working together on genetic disorders, where we know patients are scattered, numbers are not big, but there are so many varieties of it, and the stakeholders are unfamiliar with it. And in the underprivileged category, there's a huge number, because our country is huge, the population is huge. Though we say rare, I always say when I go to the government, it is just neglected or orphaned, because the numbers are huge and we need efforts to identify it. So we are going to get together through this platform. So what is advocacy? To change what is to what should be. So we know where we are to a certain extent. We are going to discuss it out. And we need to put things together to understand what should be or where we should go. So for that, what should be done? So advocating for what you believe in is crucial. If you don't ask for it, people assume you don't need it. So we have to ask for it. And more, we are small and called rare. We need to really make ourselves present. So the way the session is going to go today is, of course, we have completed the introduction. We are going to share the experiences of the patient leaders, the parent, the support groups, the national and international leaders, the government representative, the legal person. So we are going to share their experiences. And then we are going to tell people one big challenge of each of the panel member here. And after that, we have a few general questions, and we need to take questions from the audience to understand what their perspectives are. And of course, I thought we should end by contributing and having a focus, a pointers towards sensitizing our decision makers to take things forward in this line. So this is generally going to be the flow of our session. So I would start with the questions to Ritesh. And again, here panel members, if you have slides to present, you can just go to screen share and then share it. or if you just want to extempo share your views, you can do it again. So we are going to start with Ritesh, our patient leader. So Ritesh, I have known you, but still, I would like to hear from you again. What were the experience in fighting a rare condition like Becker since childhood? And how did you manage to secure good education amongst all this? You have done your PhD. So can you share your experiences?
Yes, very good afternoon to everybody, to all the
No,
panelists and
you're
all
on
the
mute,
people.
Ritesh.
Cannot hear me? Can you hear me now?
Yes, you're audible.
Can you hear me?
Yes, Ritesh, we can hear you.
You are audible. Please go ahead.
Yeah. A warm good afternoon to all the people who joined here. Can you hear me?
Yes, Mr.
Yes, please
Ritesh,
go
you're
ahead.
audible to everyone.
Yeah, a warm welcome to everybody who's joined here on the panel today. I feel very privileged and honored to be here. I would like to thank Dr. Lakshmi for giving me this opportunity. She has been the driving force behind MCRC for a long period, and I'm fortunate to be associated with her, as well as being a member of the Institutional Ethics Committee. See, the basic thing is, as Dr. Lakshmi put it, it was my childhood which shaped my experiences and the current status where I am in. So only thing is, I was fortunate to be in a very open area where normally you stay in a city, you don't get open areas for playing and all. So I had a very active and happy childhood, and with lots of outdoor activities, both at home as well as at the school level. And I used to participate in as many sporting activities as possible, in spite of all the limitations which I had. And of course, it was my parents and my father and my mother both who used to tell me about the value of hard work and studies in my life. They were like very keen that I should have a good academic career, because they could sense that there is something which he needs to do. Physically, he may not be able to do, but at least in academics, you can achieve a lot of things. So they had imbibed these values in me. So I would say that they have a major role to play there in my education. And of course, the support and the encouragement I received from everybody around me, my friends, or even people in my family. So nobody was in any way not supportive of my decisions. And I actually wanted to be a regular doctor, like do MBBS and stuff. But it so happened that, okay, they said it will be very taxing. So I went into the other domain, that is, did my master's and then did my PhD in biotechnology. And all these things which happen in the childhood, the activity portion of it, as well as being like inclined towards academics, it shaped my personality as well as gave me a different view on my own condition, which I could take it in my stride and then do the only thing which I knew best, that is exercise and being physically active. And that's what has kept me active till now. And fortunately for that, I have to thank everybody around me. I mean, I cannot even name them here on this platform. So that's what is keeping me in my job, and that's what helped me to do my PhD. And of course, I had to leave research at a point when I got married, and it was very taxing to continue research. So I went into the banking career, and then finally I got married. I have to say thanks to my wife also. She was very supportive of my decision, and we both together took the decision to have children, and we have two wonderful daughters. And like life has been like almost complete. Everything whatever I thought of doing in my life, I have achieved it. And I think there are a lot of things I'm looking forward to. Patient advocacy, of course, I have not been involved a great deal, but I do contribute whatever little I could. I was associated with IIT Madras for development of their standing wheelchair, which doesn't directly help muscular dystrophy patients, but it does help spinal cord injury patients. So to maintain like a standing position and all. And right now there are a couple of groups that I'm associated with. We are like taking forward whatever they can. I mean, I'm helping them in whatever way I can. So patient advocacy, yes, I have to work a little bit on that. But as you can see, since it is my childhood from where I imbibed this thing to fight the disease, the will is there in everybody. Once you face that condition from a very young age, it's a little easier to get on to the like being active physically and mentally. So that's where I stand right now, and I hope to be associated with more with this advocacy part in future. Thank you, ma'am.
Ma'am, please unmute yourself, ma'am. Ma'am, unmute yourself.
Yes, I've known Ritesh, his parents, very supportive parents, his wife, the two little daughters, and it has been a wonderful journey with Ritesh again, and to see him face the challenges. And he's got lots of research ideas again because he's a patient and he is also has done research. So when it comes to research projects, Ritesh's inputs are wonderful. Thank you, Ritesh. Thank you for being with us. And next we go over to, thank you, Ritesh. Go over to Shambhavi. And Shambhavi, again, thank you so much for being here. And as an adult patient and an independent individual, what do you feel are the challenges in having a career? Do you feel people in work really understand your challenges?
So, firstly, I'd like to thank you, Dr. Lakshmi and Dr. Dipanjana, for giving me this opportunity. And of course, to Prasanna sir for really finding me and scooping me out of the dark and kind of beginning my journey in patient advocacy. I'm fairly new to it. I'm fairly young in my journey personally and professionally. So just wanted to thank all three of you. You've been instrumental in that. Regarding my condition, my condition is quite invisible in the sense that unless I'm telling you that I am not okay, you will never be able to tell. I do have some deformities in my fingers and my toes, but those are not the kind that will really reveal the exact extent of the condition that I have, which is Allergen syndrome. And so for me, the challenge lies in how much to share and how little to share. How much will not sound like I'm making excuses at work or at school, and how much is enough for them to understand that yes, I might need an hour, like a break, in between the day or whatever. But the thing that I have found is that communication is key. So law is a fairly intense profession, irrespective of whether you are advocating in court or you're working in public policy or you're working in a law firm, like a corporate setting. It is a fairly intense profession mentally and physically. And so I have always found that communication is key. So even if it is a little too much information, it's better to share it than to suffer in silence and to shoulder all the burden alone. And the other thing that I found is talking to people. So like Dr. Ritesh, one thing I have in common with him is parents that never believed that I was sick or that I was unwell or that I could not do XYZ. And like Dr. Ritesh, they were of the opinion, like Dr. Ritesh's parents, they were of the opinion that education is what will bring me, to a level of security and a level of peace in my life, irrespective of what the government does, what policymakers do, what society does. Irrespective of who says what, I will be secure for my future. And that was the mindset that they kind of imbibed in me. And I was fortunate to also have a younger brother who at every stage would be there, with snacks and with small little encouragement to keep me going through the studying and through my heavy work days and stuff. So I think it's important to have a support system also. Otherwise you can't face your challenges either as a child or as an adult. And as an adult, your challenges are very different to what you have as a child. So that support system and talking to other people. Like I loved the prayer that you started off with, Dr. Lakshmi, that we have to come together to find solutions. So there are a lot of us adult patients all around the world. We speak on Facebook, we speak on WhatsApp. We're always exchanging ideas. See, I had fatigue today. Or I had a fall today because I was so stressed out. How do I prevent that? And one really big learning that's come out from that for me is mental health. And so I have started getting the support I need mentally to deal with all the things that I've gone through as a child. Lot of bullying, lot of intense, lot of intense negativity coming my way. So to deal with all of that, you should not deal with it alone, and that is where I come from in managing the challenges of my adult life and my when I was growing up as a child. And just finally, in terms of my workplace, whatever I have done in terms of communicating has always worked. And I think that has to do a lot with how much awareness patients have raised, patient advocacy leaders have raised over the last 15, 20 years. You hear it more now, disability rights. You hear people saying things like, we want an inclusive environment. And I feel that has trickled into like the workplaces that I have worked in, for sure. Also because legal field, I mean, we are all constantly fighting for some cause or some positive development. So I think that is also plays a role in it, that I have a good set of people around me, and I totally echo Dr. Ritesh on that having that good people around you. You're on mute, ma'am.
Sorry. I'm sure you're going to manage your career and your time with the patient advocacy group. So do you have any plans to say, I'm going to give so much of time to the other legal part and something really solid when it goes to the patient advocacy group work?
So I do that right now as best as I can. Usually weekends or evenings after work, I'm doing something or the other, either sometimes with Prasanna sir and Dipanjana, or sometimes with other people within the patient advocacy space here in India. And then of course, so my condition is called Alagille syndrome, and so I'm the only India director on the board of directors of the Alagille Syndrome Alliance. So we are trying to make sure our focus goes international. And so now we have things like Spanish working groups. We have groups setting up now in Netherlands. Like that, bit by bit, we're going, and we work with pharmaceutical companies to make them see the patient side of things, to make them understand, whatever they're looking at in the microscope ultimately is a human being that's going to be impacted by it. So I do dedicate that amount of time. So every Friday is usually related to Alagille Syndrome Alliance. Weekends, sometimes, I'm doing stuff with other organizations. So yeah, that will never, as long as I have health, that will never stop. Yeah.
Wonderful, wonderful, Shambhavi. Thank you so much. And having heard two adult patient leaders speak on their challenges and how they have really come out, and where both of them have said the family plays a very important role. And now we have Baninder Singh sir, who is a parent of a Niemann-Pick child, as such, syndrome child, and he is going to share with us his challenges and what he would like to tell parents.
A very
Welcome.
good, thank you, ma'am. A very good afternoon to all, and a very big thank you to Dr. Dipanjana, ma'am, for making me a part of this platform. Talking about challenges, firstly, I would like to say that it is said that there is no greater a pain than childbirth. But I must disagree on this. The greatest pain on earth is carrying and delivering a child which you never get to raise. I have lost 3 childs at birth, and trust me, it is not easy to take in that pain. And when the 4th child was born and being diagnosed with such a rare disorder like Niemann-Pick type C, life has not been the same till now. A rare disease journey is always supposed to be rare, and mine one is no different. A big challenge indeed, especially very few people are there who actually know that what the child is going through. It was for us, it was like we are in the midst of a sea surrounded by deep neck water all around us, and with no help there. And we were simply lost what to do, where to go, whom to talk. I mean, these things we did never think about will come our way. And the day we received the diagnosis of Niemann-Pick, it was 26th of February 2019 in Surya Hospital. The three words that still resonate on my mind till date, the doctor's words were, go make memories with your child. That is what is going to remain with you. And every day is going to be a challenge for you. We have slept in hospital chairs, skipped meals, cried from fear and joy. And ultimately, we have ourselves become experts on our child's medical condition. We are strong advocates having to make life changing decisions. And we are caregivers to medically complex warriors. I would like to term them warriors, because only what I feel is only a child knows what he is going through from inside, unable to express it. I mean, I have seen my child, he was on 24/7 oxygen support for 6 long months. For 6 long months, my wife and me, we did not sleep. We had sleepless nights. We used to sleep turn by turn. 2 hours she sleeps, 2 hours me sleeps. As because if by any chance the oxygen pipe comes off, he used to turn blue in within seconds. So, but that was not the way his life was supposed to be. So challenges were there. I ultimately took the hard decision of going for a bone marrow transplant for my child. Now, bone marrow transplant did reverse all the reversible damages which had already been done, because the diagnosis was late. His lungs, his liver, his spleen were already partially, I would say, not working. But yes, after the transplant, the damages have been reversed. But life is still uncertain for him, because the actual problem is not the liver, the lungs. The actual problem is on the brain, is the neurological thing, to which there is no cure. And I am, and till date, I have lost everything in reaching this stage. And because of this pandemic, I seriously don't know what the future holds for him and for us, mom and father. Thank you.
I understand, sir, as such. The It's a huge trauma, and to go through it. And yes, we all understand having a child go through the pain. It is a bigger pain for the parents to see the child go through that. And since you mentioned that you did a BMT and you did it through crowdfunding, what was your experience in getting a crowdfunding done? Because now lots of it is coming into place in India, crowdfunding, and you see WhatsApp messages every other day. So, what has been your experiences in doing a crowdfunding to collect money towards
Ma'am,
the transplant?
yes, ma'am. Ma'am, I am coming from a business background, and trust me, going for a crowdfunding coming from this background is not easy. You face trust issues. And I had already spent a fortune in reaching a stage to know that what my child is suffering from. And after that, taking the decision of going for a transplant, and to come to know the cost involved in it, that forced me to go for a crowdfunding platform. Because after the diagnosis stage, I was not left with much of the savings with me. Before the diagnosis stage, he had already been hospitalized in PICU 6 times. And you know what, and there was no insurance cover also for him. And what we businessmen face as on a crowdfunding platform is the trust issues. Now, I was told about the crowdfunding platform in Bangalore, and I even did not have a second thought of going for that funding thing. Now, that saw closest of friends and relatives come together to help me, but it also saw some friends turning enemies. They said, why do you need to crowdfund? I mean, I have spent days and days in explaining them what I have been going through since past 1 year. Businessmen don't have unlimited cash flowing in their way, and there is no help for our class. Now it is very difficult for us. It was a fight with me to opt for a crowdfunding platform. But at the back of the mind, I knew that if my child had even a 1-inch chance of surviving, I had to choose this platform.
I understand, and thank you, Mr. Baninder Singh, for sharing, because there are lots of parents with a child with various disorders handling, and now today crowdfunding has been a buzzword, but then there are lots of challenges to it. As you rightly said, when it comes to dear ones, even the trust part is there, and it really hurts.
Ma'am, I would also like to state that crowdfunding only helped me accumulate 25% of what actually was required of going in for the transplant.
Okay.
So, and rest, I have given it all. It's like right now, I have started my life from zero financially. It's at this stage, and this pandemic has been a catalyst to my situation.
I understand. Yes, Baninder Singh sir. And one important point I think we should take from this is there is no insurance for any of the disorders. And of course, we will bring it up during the overall session. Like, I definitely want to put it up to Prasanna sir again. Insurance for these children, again, there is no clue of how things are going to happen on the insurance angle. So let's take it up during the session after each one share the experience. And next, I call upon Dr. Shruti Bajaj. Again, as I told you, these are representatives. She represents the clinical background. She has a clinical background and she has started this support group. And she's been very passionately working on it. And I request Dr. Shruti Bajaj to share her experiences with Pehel.
At the outset, good afternoon, everyone. And I would like to sincerely thank BGCI, Dr. B.R. Lakshmi, Dr. Prochi Madan for really giving me this platform to try and collate my thoughts, because as I'm listening to all of you all, it's really completing the fabric, what we see in the clinic and what lies beyond. And although we are always aware of the story, to have everything collated on one canvas is really commendable. So thank you for giving me this opportunity. With your permission, I would like to share a little 3 to 4 slided PowerPoint show to drive home what we are all about. So although I do have with the blessings and well wishes We have set up a support group for Down syndrome called as PEHEL. But I would want to say that as a clinical geneticist, I feel very strongly for all rare diseases. It's just that Down syndrome being the commonest of them all, I somehow feel that if I can cut through the message for Down syndrome, the rest of the message for rare diseases and the awareness may be easy to piggyback on that, given the fact that even medical professionals and even the lay person today would be relatively more sensitized to a child with Down syndrome as to what are the conditions, what are the challenges they face. And often I try to tell them, look here, Down syndrome is just one drop in the ocean. We have so many other rare diseases which actually need attention to the same level that we're trying to do. So it was 3 years back where like-minded people got together, and I was fortunate to have the thing to anchor and steer this thing. We founded the support group, which we fondly named as PEHEL. I often say PEHEL is my third daughter. I have 2 other beautiful daughters, and PEHEL stands for Parent and Expert Forum for Health and Excellence in Life. Of course, along with this, steering all along has been Dr. Anjali Gokarna, a very senior pediatrician from Vasai. And while they often say that, I always say it can never be done single-handedly. These are all the wonderful parents. These are just some of them who are the core committee members at PEHEL, but they have been with us for the last 3 years, helping us to know what is it that the parents need. Today as a doctor, I may feel that I want my patient to know A, B, Z about Down syndrome, but it is these parents who tell us what is it that they need, what is it that their children need about knowing more and getting empowered. And really the need for this was felt because, as I said, Down syndrome is one of the commonest genetic causes of intellectual disability globally. And every year in India itself, we have around 22,000 individuals being born with Down syndrome. And despite being so common, despite there being awareness, we can imagine even for Down syndrome, there is not enough sensitization to pick them all up in time, to refer them all for comprehensive care. We still are heartbroken when sometimes parents come to us telling that someone, it could be a neighbor or relative, or often even a physician who has given them a full stop by telling, really don't work on your child. There may not really be any ray of hope, which is quite contrary to what Down syndrome individuals are capable of. So this really spurred the need that we really need to have a one-stop care where individuals with Down syndrome can come together, address their medical and non-medical needs, have a platform with authentic information, not just Google and Yahoo, but something which can answer their queries, their fears, their apprehensions, and also at the same time empower them in understanding what their rights are, understanding the laws which are now coming up. And it's really heartening to see that there are voices like platforms like these which can unite together to make their lives simpler and more fruitful. So eventually we all collated together, and we have branches from different experts in our group, from medicine, law, finances, career counseling, social support, psychology, and of course the parents themselves, who I feel are the brain and heart of the group at the end of the day. And we at PEHEL aim to create more awareness, dispelling the myths. And as I say, Down syndrome is the tip of the iceberg. I am surprised every time when I come across with a parent of Down syndrome of the amount of myths they have. Either it is ingrained externally or their innate fears. So we really want to create a forum which can create awareness, dispel the myths, help also those who cannot maybe help themselves socially and financially. And of course, through the COVID era, and even before that, we try to have various platforms, various discussions, and digitally outreach to those families with Down syndrome who may not be privileged enough to live in a tier 1, tier 2 city and have all the experts, within accessible distance. So what we really do can be broadly divided into three things. We do hold regular health camps, which is of course taken a setback in the current times, where we try and get experts across different branches which cater to Down syndrome. For those who may not be aware of what Down syndrome is, it is a condition that is caused due to 3 copies of chromosome 21. And beautiful though these children are, they may have multisystemic concerns. So through my health camps, we try to get these various experts, cardiologists, neurologists, growth parameters, vaccinations. The last camp that we had held in October, we catered to 41 individuals with Down syndrome, did free 2D echoes, free sonographies, free genetic counseling session, pediatric checkups. Of course, the last camp was generously funded by a Rotary Club of Caduceus and Rotary Club of Peanut. Other than this, at the core, the USP of PEHL is we hold parent expert talks. So we bring in career counselors, legal advocacy groups, pediatricians, neurologists, every expert that a parent with Down syndrome ever wanted to talk to. So we had an interesting session of career options in Down syndrome where, fantastic speakers came and addressed to how can they make their children financially and psychologically independent and responsible citizens. So parent expert groups across medical and non-medical talks. And of course, last but not the least, we often keep these various bonding activities where various families mingle with each other, get to know each other, because that is what a support group is at the end of the day. What even the most well-meaning doctor may not be able to address a parent's anxieties and fears in the 1 hour, 1.5 hour session. Often these support groups can cater to. So we hold picnics, we try to hold play activities, storytelling activities, and as a very small fallout, I can give an example that 4 children with Down syndrome living in Virar now together go to a common swimming coach and they're learning swimming. And they all met through the PEHL platform, and I can tell you how boosted their families feel, and I just feel privileged and blessed to, be a mean and a nimit, as they would tell in Hindi, to be able to facilitate this journey for themselves as well as for me, because I feel that whatever medical training does, I feel life per se is so vast that we really cannot dip deep and get a flavor of every emotion unless we do something like this. And I think the last 3 years at PEHL have really made me even more sensitive and empathetic as a medical professional. And I'm really thankful to everyone at PEHL, and once again to BGCI to give me this platform to share, as I tell, experiences with my third daughter, PEHL.
Thank you. Thank you. It's wonderful, Dr. Shruti, and when it is led by a clinician, and you rightly said, bringing together the parents and emotions and giving them the strength. And now we have Dr. Shalini represent MDCRC, again, a patient support group where we are scientists and we are leading it. So I just wanted to bring both together. And on to Dr. Shalini to share her experiences at MDCRC and what we do here.
Thank you, ma'am. Greeting one and all present here. Firstly, I would like to thank you for investing your time here on a Sunday afternoon for this wonderful conference. And I would like to thank the organizers, BGCI, and everyone for having given me the opportunity to talk about what we do at MDCRC here. I'm Dr. Shalini, a scientist working in MDCRC. We are a group of scientists who get together, who have got together, and we work for a pediatric disorder called Duchenne muscular dystrophy. And I would like to share a few slides with your permission. So a researcher who is generally known to, known as basic science research to clinical application doer. And it is always, the face of a researcher is known such, basic science research to clinical application is the only possible way that as a researcher could contribute. But we believe basic science research should reach the community, and the community application is really important, for a researcher. And these are two polar opposites which are generally not discussed about. And I believe personally that the science of today is just not the technology for tomorrow, but it is for the community tomorrow that we are to work, and researcher play a role here. And here, I would like to emphasize here, because being a genetic disorder, once when the clinician suspects it to be a clinical, a genetic disorder, then comes the role of a researcher, wherein he identifies the genetic component, he maps the gene, identifies the gene, diagnoses, molecularly confirms it, and then prevents the disorder. And the role of a genetic or a researcher as such, is very crucial in all these steps. And what common do we have here at the forum as such here that we have gathered? And it is for the patients that we are here. And the most common thing that we have amongst us is the patient, wherein a parent also have a role, clinicians have a role, a therapist has a role, and so do a researcher. And we are clinically oriented scientists back here at MDCRC who work for the disorder. And we strongly believe it is the concerted effort that is required, as Dr. Shruti said, in the previous talk. It is. And I believe the concerted efforts is very much important for effectively delivering the services to a patient. And I can strongly say that our strength is the community health. We deliver all the services door to door, and we, especially for the rural public, and we pick each and every child at the grassroots level itself. And these are the holistic services that we offer back here at MDCRC. And we initially started off as a diagnostic facility, molecular diagnostic facility. And then we thought just offering them a diagnosis would not, we will not do justice to them. And then the counseling came into play, wherein we offer them genetic counseling. Then came the clinical care for our children, and then the rehabilitation. It was a step-by-step process, where we evolved every time. And we are still evolving. And the biggest support that, or the biggest happiness that we found was the family support events that we had conducted. And it is always the parents who bring the child here to us, to our center, and we always feel this family support events that we offer to them that caters their needs. And we're so happy, we cannot see that happiness in any other services. When we do a family support event, we can find happiness in those little faces, and we're really happy about it. And holistically, now at MDCRC, our strength would be field and outreach, wherein we go to the rural, especially door to door, and have them screened. And then we bring back the sample here, and then we do molecular analysis, offer them genetic counseling, and because we have certified genetic counselors here, and then multidisciplinary clinical care, wherein all the clinicians come into play. The clinicians look at the child and understand where this child is and offer him proper intervention. And rehabilitation, because it is a disorder which has got no cure, maintaining the quality of life is the only option that is available for us. And rehabilitation plays a role there. And finally, the family support events. So we are working on a vision 2022, stating that Tamil Nadu will be a state where there is no kid with Duchenne muscular dystrophy who will go unidentified. Because once identified, we can prevent the disorder. And I'm happy, to share in this platform saying I'm not a scientist who would who is sitting in the lab and doing the experiments alone. I'm here doing the experiment and also serving the community. And I would really like to thank everyone out here, especially Dr. Lakshmi, Dr. B.R. Lakshmi ma'am. And we are working on a vision and of covering the entire state of Tamil Nadu. So path for success, I always say, it was neither linear nor easy, but the path we have chosen, it was worth the travel. Yes, it is not a road not taken. It is the path less traveled, but the road less traveled is usually, is traveled for a reason, and that makes the difference. Together, we can make a difference. Thank you so much for the opportunity.
Thank you, Shalini. And I think with all the enthusiasm, I don't know if you followed, all the work we do is for Duchenne muscular dystrophy. Of course, it came towards the end, and it has been more than a decade that we are working for this. And we have close to around 4,000 plus children whom we have identified. And so this is and we have brought in a working model where we identify to prevent it in the next generation. So we have a complete work done and database where every proband in Tamil Nadu with Duchenne has been identified, the mutation confirmed, the family counseled, and the carrier samples taken, the carrier testing done, and all on the reproductive and prenatal, preconception, prenatal work is done. For all, name it, district by district, we have completed. And at this point of time, I think I should thank State Planning Commission and the government of Tamil Nadu for supporting us to do such mammoth project. And as Shalini rightly said, by 2022, Tamil Nadu will be a state where there is no kid with Duchenne who will go unidentified. So at least at familiar words, those who have identified, we can prevent it in the next generation. Not having a cure, I think it is a responsibility of researchers and scientists like us who know there is a technology, and now more with NGS and other technology, we are able to prevent it. And of course, we have the care, family support, and it is under one umbrella, we have all of it. And at this juncture, I'm very happy to invite you all at some point of time to come into Coimbatore to see our center. And all of us, the team, we really relish and really feel the science is reaching community and there is a purpose for which we do. And again, I thank my team and thank the organizers for giving us this opportunity to put across that scientist-led patient advocacy group. And now going to the next part of it, now we have people working at the national and international level on policy making. And I call upon Prasanna Kumar Shirol sir. And I would like to ask him, like in India, what has changed in the rare disease scenario? Because lots of it is happening in the last 5 to 7 years. What is a change you have really felt when you really came into the field and where we are now? So how would you describe it, sir?
Okay. Thank you, Dr. Lakshmi and BGCI organizing committee for giving this opportunity to us. Talk about the rare disease community in a whole. I'll share a presentation. Okay. Yeah, once again, thank you so much. ORDA is an umbrella organization which represents various rare diseases, and we do various activities on a 360-degree approach, supporting all the rare disease patients and families in India. Okay, in India. So you're talking about the change. So in India, if you look at it, today, the discussion itself is a change. Today we are listening the success stories of the patient. Today we are talking about crowdfunding. Today we are talking about a whole lot of issues, supports, and what is being done in the industry. That is a change. And the biggest change in India in the last 10 years, it is the hope which has evolved among the parents, evolved among the medical fraternity about the rare diseases. Earlier, rare disease was not being talked openly or publicly the way today we are talking. And that is the biggest change which I see. And you will see before 2009, 2008, there were a lot of support groups which were functioning at a state level or a local level. but there was no common voice for rare disease in India. And then when we started LSDSS, which is one of the first national level parent support group for rare disease, and when we started observing for the first time Rare Disease Day on February, I think that is the voice of rare disease which has started evolving across the country nationally. And then LSDSS took over to different cities, and that's how it started. Then in 2013-14, when WARDA came, and the voice of rare disease has amplified with various special programs of rare diseases, and especially the Race for 7, which is a mass awareness in India. And accordingly, within the next 4 or 5 years, a lot of discussion happened among the rare diseases, especially on the the rare disease definition part of it. And the discussion and debate started happening at every opportunity among the stakeholders. And then there are a lot of PAG groups which were earlier there. They also started joining and increasing their advocacy level, awareness level, and as a result of a court case also based on rickshaw pullers in Delhi, in 2017 we had the first national policy for rare disease. I think that is the first big change, which recognition has started on rare diseases nationally by the government, and then followed by various initiatives of thanks to doctors, parents, media, and patient group. We had ICMR patient registry in 2018, which is announced by a group of doctors and ICMR together. Then there is orphan drug policy, which focused on certain support system to the orphan drug policy as a whole in terms of accessible or bringing the new drug or developing a new drug in India. Then we also had clinical trials, and by the time we had some definition clarity under the clinical trials rules and also ICMR patient registry. Although they did not match each other, but at least there is a recognition, there is a talk about it. Then there was a public consultation on the rare disease policy by central government, and the rare disease policy was kept on hold. And then Race for 7, which we took over to more than 20 cities in 2016, 17, and 18 and 19. And there is one more big change which has happened in SMA treatment, which is one of the costliest. And today you see a lot of crowdfunding. When we heard from Baninder Singh and myself, who have exposed to the problem and challenges of crowdfunding, today that is a buzzword. Even the government policy is talking about it. Although it is not a solution for us, but at least there is a change, there is a hope which has come to them. And with all these things, there is a lot of global focus which has shifted to India. Earlier, connecting with any global company, pharmaceutical industry was, they were all neglected India. But various initiatives brought global focus, both from pharmaceutical industry and clinical trial industry. And we saw a lot of activity in that direction. Finally, recently in the March 2021, the rare disease policy, which is officially announced by central government, is the recognition. I think this is the major change in terms of getting recognition, talking about rare disease officially by government. While in Karnataka, there is certain improvement, certain development happened where the treatment also started. Karnataka is the only state where treatment for LSD started, but that is not the case in other states. Although we have a policy, still long away, but I see that this is the starting point of rare disease journey after a decade. But looking at the development, and next few years is going to be very fast, and we can expect a lot of changes. Then the other exact or tangible changes was in the diagnostic industry. 10 years back, doing a genetic test, the newborns, genetic test was very, very costly and difficult and not available in India. We had to send outside, and it would cost more than ₹1 lakh. Today, with just 15,000-20,000 rupees, when we can do genetic test or a whole exome sequencing, which is one of the lowest in the country, in the world, but still it is not affordable to our patients. But diagnostic has improved. We can diagnose in case if there is a resources available. Then the treatment and supportive care. There is always a negativity among the doctors and also parents. Oh, rare diseases and genetics are not treatable. But there is a lot of supportive care needed, which was absent earlier. Today, we saw a lot of doctors, a lot of hospitals focusing on the treatment and supportive care, and a lot of support groups are being formed, both officially or on offline, like WhatsApp group. You see, there is a WhatsApp group or a Facebook group for most of the diseases. They are not in the public domain, but they are supporting each other with the help of medical fraternity. I think that is another big change. And awareness, and as I told you, global and crowdfunding, rare disease. I think these are the big change which we have seen in India. Now coming back to scenario, what exactly the past was. Earlier, the discussion was within the four walls of the doctors or a cabin or restricted to home. But today, it is in public forum. Many patients and families have come out and ready to discuss the challenges and ready to fight. Early and accurate diagnosis, while even today it is 7 years average diagnostic period, but I can proudly say that diagnosis has very improved in India and to the tune of 70, 80% or even 100%. The only thing what is missing is the support for diagnosis. If we have the money and if it's affordable, if the cost can be borne by either the parent or the government, then definitely diagnosis is not an issue, which is still an issue worldwide. And stakeholder awareness was not much. Today, every stakeholder, be it media, everybody is with the rare diseases in terms of support, and everybody is doing their bit to create a high level awareness. And the counseling, which BGCI is doing a wonderful work. Earlier, counseling was definitely absence. One simple example: when we go to the doctor, he says 50% chances of next pregnancy. As a parent, we all think, okay, first child is over, next child can be correct, but which is not so. So this kind of a thing, wrong notions among the parents has led, and genetic counseling has now increased, and there is an awareness among the doctors and pediatricians who are referring to genetic counselor. I don't say it's a great change, but yes, the change has begun. People have recognized genetic counseling, and which is very, very crucial. Then the rare disease center hospital, it was not there. Even today, parents travel from part of India, 500 kilometers, 1,000 kilometers in search of a good hospital, doctor to get cure diagnosis for their child. But I don't see that problem now. Every state has one genetic, at least one center who are focused on rare diseases. In some states, in fact, it's much, much more. I think we don't have to travel. It is only the lack of information where people are traveling, but I'm sure we have everything. Then parents and families are always at a crossroad. Thanks to technology and a lot of focus on the medical, at least they have some information who makes an effort. People who cannot make effort, we cannot do anything. But at least who makes an effort, there is a solution available. There is a information available. And coming to the biggest thing is the government. There was absolutely zero discussion at the government level, be it central or state. I think today, with a lot of court cases, rare disease policy, every state in the health department knows about at least the rare diseases. While there are no action, but they know rare diseases. Earlier, when we used to visit the government, they would ask, even including the health secretary, what is this rare disease? Why should I treat? Why it is so costly? Kind of a question. Today, I don't think we face that question. Is all that the support and initiative from the government. And last but not the least is research and development in clinical trials, which was absolutely, I can say, zero in India. But today, a lot of focus has been increased both for pharmaceutical company, and the good development is a lot of patient support groups, especially in the DMD space, have invested and started research, which is definitely a big change, which is currently when compared to the past. So future, yes, there are a lot of things which we require, and rare disease policy is the first step. And newborn screening, genetic counseling, which is a must, and it has to extend to the nook and corner of the country, especially in the rural areas, because we see a lot of families with multiple children, the same thing. If you can, at least the prevention is important, and genetic counseling definitely makes an important change in somebody's family's lifetime. And patient registry, yes, while we have a patient registry from ICMR, we have not seen much progress, although we keep hearing a lot of advancement, but we have to still see the impact of it and the data being generated, which is ultimately useful and practical in nature. And hospital center of excellence is definitely required so that the patient don't have to travel. And since all these illness conditions are lifelong, they need a local physician, local treating center. I think that is the future we should look at it. And coming to the advocacy, yes, while there are a lot of advocacy in some states, business spaces, and national level by selective groups, it has to amplify, and everyone has to join irrespective of what their condition and what their requirement. We need to have one voice, and that is the future. And most importantly, the state level advocacy has to increase, because health is a state subject, and very important. Even if you have a policy, good policy implementation, we have to increase the state level, and we need to have a single voice in the future, so that it is short. We should have contain both short-term and long-term approach from the patient group, which we can definitely make change. And focus on R&D, local drug development definitely are the things which we should work and look for in future. Now, finally, coming from the rare disease policy, I would like to touch upon this. As I told you, yes, rare disease policy is one thing which has given recognition. Earlier, no one knew where do we stand. I'm not saying that this is solved all our problem. It is just the first step where. Suppose if I have to compare, the first policy which is announced in 2017 and 21, while having a policy is good, at least now we can start talking and there is a platform which is ready and we have to build upon it. But there is a lot of shortcomings when compared to 2017 and 21. Earlier, there was a clear short-term and long-term approach in the policy, clear center-state relationship, responsibility, fund allocation, financial commitment of 60-40, definitive direction, state and central technical committee, etc. But we see there is no such mention in this policy, and definitely we need to work on that. There is no definitive action, practical in nature, and most of our questions are not yet answered. I can only say that it is still a policy for IWASH to satisfy the court deadlines, but not which definitely helps the patient act. And coming to the rare disease definition, yes, having a definition like any other country will definitely clear a lot of doubts and clarity for many decision taking, be it pharma or patient. Today, still we don't know whether our condition belongs to rare disease or not. So because one is ICMR website talks about 1 in 2,500 as a rare disease definition, while the clinical trial rules talks about less than 5 lakh patients in a country for a particular disease. So how do you arrive at 5 lakh patients are there or not? Who will do it? Who will calculate? I think this is the biggest question which we need to answer, and the rare disease policy has failed to answer this. While we have 70 million patients as estimated figure, but it is still not a public priority. I think we continue to be on the crossroad, and this is another area which we need to still work aggressively. And coming back to the policy support, what exactly talks about it? Yes, it is good that the policy has categorized the disease into 3 groups. Group 1, talking about one-time curative therapies or a transplantation kind of a thing, where they are announced 25 lakhs, but it is only for the BPL families, that is below poverty line. But the question is, how can a BPL families reach to a lung transplantation or a bone marrow transplantation while going to the government smaller hospital or a primary healthcare center? And also, even if somebody fortunately reached that stage, who will take care of the lifelong supportive care? I think this is one which has come very small percentage of the community, but still failed to address many of us. Then the group 2, which is there is a therapy, but long-term therapy, but lower cost, like could be PIDs, could be hemophilia, thalassemia kind of thing, left to the state. But unfortunately, there are no guidelines. I mean, there is no funding. While health is a state subject from the day one, but there are no much initiatives from the state government in India on taking care of this specialty diseases, while some states have taken some steps. So I think this is where important state level activity come into funding. Whatever diseases categorized into group 2, even if you have to implement it and get it from the state government and finally reach the patient, it is a long way. So we have to amplify our efforts in the state level in terms of advocacy with the government. Then group 3, crowdfunding. They have left completely this section, which is a crowdfunding. This is where our first initiative in advocacy started, because the treatment of all the rare diseases most of the rare diseases are very costly, costing 50 lakhs to a crore of rupees. Today, government has told us to do crowdfunding. See, crowdfunding is something new, which we all know that we are all using it for small some of our thing. But can you imagine if somebody is serious and somebody is need lifelong crores together, lakhs together? How can you go and raise funds? How can government raise such funds from publicly? How long should we wait till fund is raised in my child's name? I think this itself is poses a serious ethical issue in terms of policy which has failed. While still there are court cases going on and discussion going on, we are, as our nature, we have still hope that something will happen. Otherwise, we still need to work very aggressively on this. And very important in terms of prevention, when it comes to prevention, newborn screening, absolutely no clear strategy. Still, it is no plan. There are no actionables. because who will bear the cost, whether it's the state or central government? Nothing. While policy talks about center of excellences, there are 8 centers for 29 states. Is it enough? I don't think so. We require at least minimum 1 per state to start with. And even these 8 centers which are allocated or identified are very skewed. It says 4 centers in north and 2 in Delhi, south 2, west 1 and east 1, which is very discriminative. How can country like India will have 8 and very skewed towards particular geography? And also there are issues like Indira Gandhi Institute of Child Health is a pediatric hospital. How are they going to handle adult patient will be an issue. I think these are the small nitty-gritties which need to be addressed. And also the funds allocated to Center of Excellence is only 5 crore and only for purchasing the diagnostic. Today, why do we require to invest on so much diagnostic? Because we have so many diagnostic facilities available outside. All that government can sit and negotiate with them and bring the cost down so that everybody gets, instead of investing on diagnostics unnecessarily. Then there are Nidan Kendras. Again, there is a skewed north 3, south 1 and east 1, mostly on a training mode. I mean, if you have taken a steps today on a training mode, definitely is a good for a long term. But what happens immediately? What happens to our existing patients, existing families who are undergoing problems? So sorry? Hello? Can you hear me? Can you hear me?
Yes, we can hear you. If you can make it a little more, because we have more panelists to address. So
Sure. This is the last one. And finally, there are a lot of schemes like RBSK and District Early Intervention Center. This policy has not taken into consideration because District Early Intervention Center would have solved a lot of problems or help in faster, speedy implementation. So we talked about ICMR patient registry and R&D. So I think these are the issues which we have challenges. Yes, it always says kuch khatta meeta. We have something, but not completely, which will satisfy and which will help us to save our children. And there are a lot of community expectation. I think all that we need is a 360-degree approach to manage rare disease and a robust policy. Thank you so much.
Thank you, Mr. Prasanna. And I understand because it's a huge subject, and just to put it in 15 minutes is really, really hard. I know the amount of work that has gone into it, and there are lots of key factors. Of course, we should sit to have a real good panel discussion separately only on the policy and how to really make it happen. And now I would like to call upon Dr. Elizabeth Vroom, who has been all through it and experiences in setting in policies in Europe and in newborn screening and in rare disorders. And I would request Dr. Elizabeth to share her inputs to make things easier, or your tips to make things happen in India. So on to Dr. Vroom.
Thank you for inviting me, and I'm impressed by all the speakers who have already had their time slot. And I was just thinking, it's 12 years ago now that I organized the first Asian conference in Bangalore, right, in 2009, and how far you have come since then, So I think you can all applaud yourself, because then it was really very, let's say, in a premature stage, what happened in the rare disease field. So this is amazing. And I think one of your questions was what are the tips? And if I now listen to all the discussions before, all the speakers, I think to achieve something, you should go beyond your own child, your own area, and even your own region. And I think in a huge country like India, that might be difficult. And we see people pop up in all different parts of India, because we get in the World Duchenne Organization a lot of requests from people from India, but most are in silos. So you really wonder how you could manage in India to get more people together. And that was the challenge how we started. We started, the US and the Netherlands started 26 years ago in the same months with an organization. And in fact, that was to raise money. And I think having money to guide research as a patient group, to have some money to guide research is super important, because with that, you can have let's say, a place at the table. Also with the companies, if you can say, if you don't do it, we do it, that really makes you in a better position than just begging, because begging doesn't always work. And when I also listen to these stories today, what I think it's amazing, and there's a lot of patient centricity. However, how do you really make sure that the patient voice is the voice of the community, not of an individual patient who might have the best intention? That we know all these parents who fight for their own child, and that's nature, you know. If you have an animal, they fight for their own child, and we even more fight for our own children. However, if you want to change policies, if you want to change the world, you have to go far beyond that. You can't fight only for your own child if you want to change the world. And I think what we did is, for example, I'm an expert at the European Medicines Agency, so often I'm invited for you. The European Medicines Agency is, let's say, the European FDA, where the decisions are taken on which drugs to approve or not. And what we learned there is, the first time I entered there and gave somebody, introduced myself, they said, "Oh, you're from the patient. By the way, drugs are approved on data, not on emotions." And first I was a little bit like offended, like, come on, I'm not that emotional type. But then I realized that data is their language. So what we have to do as patients, if we want to go to governments, if we want to go to regulators, if we want to go to bodies that pay for drugs, we have to come with solid and professionally collected data. So we should do research on patient preferences. We should do research on outcome measures, because what we see is, for example, that clinicians or companies use outcome measures they are already familiar with. But that does not mean that it's the best outcome measure for Duchenne. So what we did, and I think that might be for other rare diseases here as well, an action to take, is that we first went back, like qualitative research. We went back to boys themselves with Duchenne and said, what is the most important to you? What for you would be important to keep or improve when there would be a new drug? While all the companies were doing tests with the 6-minute walk test, the boys said, walking is highly overrated. What is the most important to us is being able to use our arms. With our arms, we can still use our computer, we can still eat ourselves, we can come to the table. So with that first interviews, what we did is we set up really a program to develop an outcome measure, which is called the POOL, the Performance of the Upper Limb outcome measure for Duchenne. So trials could also be done, even executed, in boys who are already wheelchair bound, because before that, the trials were only in boys who could walk because of this outcome measure. So with that, we try to really have the patient voice in drug development, and there's also a patient-reported outcome, which goes hand in hand with this pool. So to make sure that we really, if we develop drugs, that these drugs need, how do you say that? Answer the needs of the patients. And it's not because biomarkers, and as Lakshmi said, I've been one of the authors on a paper on biomarkers, but the risk is that scientists love their biomarkers so much. But at the end, it's not the biomarker that helps the patient. It is the physically outcome measure, what they can do in life they couldn't do before, or what they could keep. So we've been working a lot on that. The other thing we have been, we realized is that the data collected in hospitals and elsewhere are kept in silo. You know, data of patients are everywhere, they're in silo, they're not used properly. So we really have worked with the best team in the world on verification of data, and that is that data are findable, accessible, interoperable, and reusable. And as we know, the brightest IT people are in India, so it must be feasible for you as well, as long as you are able to agree on a data set and fair data points to collect data. And then, I mean, then India should be heaven. You know, if I hear that you already have more than 4,000 patients, and then there's so many other patients. I mean, you can do so many things, but then again, collaboration with other parts of the world are important as well. And I think for other diseases, that's the same. We've built a data platform where patients have in their WhatsApp their own medical data. They have access to that, but they also are able to put there also the prompts, how they feel, what they do, the things which are not typically medical things, and also the educational things, because a lot of Duchenne boys have some mental issues as well. So with that, patients are not the subject of the data, but they are in charge of the data. So that is really a nice development, which I think should be spread out. And I mean, India could join, Indian families could join. So, but the idea that you really, every time as a patient organization, have to realize you're not a follower, you have to see the problems yourself. You need a radar of what's going wrong and what do we need in the future. You know, like when there's now a drug for SMA, you need newborn screening in order to treat very young ones, which I have the best results. But that should have started long ago already, before you have newborn screening in place, you know? So it's really, and I said, we were not good in that. Just don't think we were good in that. But in other diseases, you might try to work on newborn screening when there are drugs on the horizon and in the pipeline. And I think the time is a little bit short today, maybe. I will round off. And I saw that also the Organization for Rare Disease India is a member of RDA, the International Organization for Rare Diseases. And I think I would advise you all to go to their website, the Rare Disease International, which really calls at this moment for the Sustainable Development Goal of the United Nations is to leave no one behind. And I think as Duchenne and as rare disease community, we should step into that and really work on no poverty, good health and well-being, quality education, gender equality, and reduce inequalities. That's all very important issues. And we have to call at the United Nations. And I think you are very well positioned in India to do so and join this effort to make sure that the United Nations resolutions on persons living with a rare disease and their families will get in place. And I'm really happy to keep in touch with you about whatever is needed. Thank you so much.
Thank you so much, Dr. Elizabeth. And you rightly put it, the patient should become in charge of the thing. And if it is data driven, we can really convince any government to really, because even today, the question is, what is a number? When I go to the government, immediately they'll say, oh, rare disorder. But if we are to really make them do something, then it becomes, because in the government it's a number game. So I think we should put process in place so that we have, and I know this 1.5 hours is too short to discuss something which is really needs time and which needs really to discuss it over. So thank you so much, Dr. Vroom. And of course, we have noted down and we would prepare a nice sort of minutes of it, which we will circulate among our counselors and parents, the inputs you have given. And now I call upon Dr. Roli Mathur of ICMR. I'm sorry it has become a little late and we are short of time, but still, Dr. Roli, it will be wonderful if you can bring in the ethics part as such to patients. And as you put it, and the request from Board of Genetic Counseling or the counselors is, we as counselors or genetic counselors should be part of the ethics board of ICMR. I think counselors are those who really bridge between patients and clinicians. And I think they need to have a space in the ethics board. So I just want you to comment on that, Dr. Roli.
The line, The line was frozen 1 second. So say it very brief, the last part again, Dr. Lakshmi. The line was frozen for a second. So.
Oh, okay. I thanked you, and I was just asking Dr. Rowley. Rowley, you're there?
Yes.
Okay. Okay.
Yes.
Fine.
Yes, Dr. Rowley, I was just wanted to sort of thank you so much for being here, and the request during our initial sessions where we wanted to understand the role of ethics in patient support groups as such, because at various aspects it comes in, like the clinical trials, during drug development, and even recently lots of companies trying to push certain diagnostic tests with parents. So there are lots of areas where ethics play a huge role. And again, counselors being a part of the ICMR ethics board as such. So I thought if you can deal upon these two questions from your experience, it would be wonderful.
Thank you so much. I do have a few slides, and I'll try to address the questions that you're raising. And so I'll go fast because I know we are running out of time.
Yes, I'm sorry.
So, that's
yes,
perfectly fine. So I just wanted to know that, as you've been hearing first of all, thank you for the opportunity to me to speak on this. And it's a really interesting topic. And I just, being a geneticist myself, this is very close to my heart, this topic. So we see that since I have been at ICMR, and there are enormous challenges in tackling this area, because you see, whenever we talk of genetics, we are really not sure whether we're talking of genetic research or genetic services. So these are, when you look at it from the ICMR perspective, we have to differentiate, because ICMR is the nodal agency for supporting research. And when it comes to service, it is really not in the mandate of ICMR to support service component of it. Now, genetics is an area where there is a big overlap and it's all interconnected, and we cannot really separate out service component from research. So that is one thing, that when ICMR supports, it is done in a research mode, because we are a granting agency and we will give grants for doing research on a particular area. Problem comes when the grant is over, because it's always a term period of a grant. It doesn't continue forever. So the sustainability becomes the issue. So I'll bring that point also. There are a number of realizing the importance of this topic, and the fact that genetic makeup is, when you prepare, do genetic analysis, it's not just individual, but we link to the family. The issues are, again, enormous when we come to ethics, and in realizing the importance of maintaining confidentiality and all this. That is how we came into the ethics, and we have a separate section on human genetics research and testing in the ICMR guidelines. It's a whole chapter in there. Also, we need to discuss here the challenges related to availability, accessibility, affordability. Because for genetic diagnostics or testing, we do not have these available. You can count the number of centers on your fingers, the number of centers which are offering testing and the costs that are, enormous to handle those things, and people cannot afford them. So these are other challenges. Funding, resources. We need a network of centers. ICMR has made efforts in building a network, because one center cannot cater to every disease. There are so many diseases, thousands of diseases, and it's important to have a network between the centers so that we communicate and build network with each other. And we know that it is not a priority, because we have huge priorities in terms of infectious diseases. So the major funding would go to those diseases which are affecting masses. I completely agree with your comment about this not being rare. I agree, because in terms of numbers, if you see in India, we don't have the numbers available, but then they won't be rare diseases in the sense that we have large number of patients who are affected, but still the number of in view of the population size, this is not a priority. We have very limited understanding at every level of genetics, very limited understanding to really make policies. There is lack of education in genetics. you see that there are only 2 centers offering DM in genetics, but we don't have. Where are these centers? Where are the centers which are offering clinical genetic courses? Short-term, long-term, degree, diploma. We don't have. Very, very few centers. Training is again lacking, whether it is training for counseling. There are some initiatives. Dr. Annie is here and she has been leading that, and the other center has been SGPGI, where counseling has been offered as a training in the last 2 decades. But for a country of the size of this magnitude, I think these efforts are really minuscule. So in the National Ethical Guidelines, we have full chapter on human genetic testing and research. And there is another one on biobanking as well as dealing with the samples. So these 2 chapters are relevant, which guide researchers in understanding how an ethically relevant research can be planned when we are doing it for genetics. The chapter, I'll not go into all this, but I'm just highlighting it addresses the issues related to making pedigrees, seeking informed consent, whether it is children or parents. It discusses about confidentiality requirements when publishing or accessing records of patients, with whom can they be shared. It discusses the role of genetic counselors, pre and post non-directive counseling, and what kind of education, training, communication skills are needed for genetic counseling. It discusses issues related to genetic screening programs that should be initiated, and when done, what are the safeguards? Similarly, prenatal diagnostics and pre-implantation genetic. I have not mentioned all the various. It's one of the longest chapter in the guidelines.
Yes,
and the other issues related to quality control of genetic testing. The commercialization aspects that is rampantly being followed now. Storage of samples, which is needed, but then how do you take informed consent for storing samples for long-term training, expertise, publication, misuse of this information, return of results. So it's not just doing a test and not communicating it back to the patient and their family. So benefit sharing, discussing the ethical, legal, and social issues. This is some of the initiatives of ICMR, and we heard from Mr. Prasanna Shirol. I completely agree with him. These initiatives are not enough. There are several initiatives from ICMR, also DBT and DST, but still we need many-fold initiatives. ICMR has set up task forces in the areas of several diseases. Newborn screening program, which I had coordinated in 100,000 babies, was done. Lysosomal storage disorder task force completed. It tried to establish clinical, biochemical, and molecular diagnostics and build a network of centers. But then, like I said, when ICMR does the funding, it is in a research mode. It was done for 4 or 5 years, and then the project is over. Once the research is over, the important thing is how you sustain these activities. We have published a number of books in this process, published SOPs, and developed a website also, but then again, the same problems. Also, ICMR provides ad hoc research funding for projects. Anybody who's interested could apply under the research grant in genetics, genomics, hematology. We have established Center for Advanced Research. There are DHR initiatives also. Genetic counseling course has been running for last 2 decades. Rare disease registry is being set up, and I don't know how long it is going to take, but it's probably still in that. But I come back to my point of grants and sustainability issues. And I think that was my last slide. Thank you very much. And you talked about, your question was about having ethics incorporated. So I wanted to tell you that ICMR guidelines have specifically mentioned that wherever a research study is dealing with genetics, there should be a provision of inviting special invitees in the committee, having patient advocacy groups on board, or having clinicians or geneticists on board to give that, to review that project. So these are all, they are part of this guideline document. And I also want to inform you that this guideline is now mandatory by law. So it is now regulated under the new drugs and clinical trial rules. So somebody cannot say that, we don't follow guideline, it's just a guideline. It is as good as a law. and it needs to be followed. So from ICMR, there have been number of efforts, but yes, many
Yes,
efforts are needed.
yes,
Thank you.
Dr. Rowley, sort of, it has been, you have just walked us through, and we completely now, all of us understand, each of us have given our perspectives, but we really understand there is no process put in place. So each of us are trying to do the best, but then the interconnecting thing to make things really complete is not happening. So though ICMR funds research, then end of it. So I think from the government perspective, again, I think really we are short of time and we have to finish, and we have the legal expert who has been working with ORDI. I'm next 1 minute, Mr. Sudarshan, you'll be having, because you have been on it with the policy. But bringing everybody to perspective, each of us have very passionately put across what we have done, from the patient leaders to the support group, clinicians, researchers, Mr. Prasanna. But what I strongly feel, team here, is we don't have processes in place to really bring things together. I think, Mr. Prasanna, we should be doing something to bring people together and put process in place. Each of us are in silo. And definitely, I think government, to take it forward, would ask for numbers. And we need to set things in place to really see the light. And now I call upon Mr. Sudarshan, a legal expert. We had a very nice chat, and I would like you to quickly tell us the main challenges you face when you're working with ORDI and policy making, Mr. Sudarshan.
Good afternoon to all. It's such a lovely pleasure to be amongst all of you. Firstly, I am really privileged to be working with ORDI, and especially with the pioneering work that is being done by Mr. Prasanna Shirol. I am happy to do my bit in the service. The entire thing started when when an adult patient was not being treated. So that took us to the Karnataka High Court, and Karnataka High Court was indeed very indulgent with us and directed a child hospital, that is Indira Gandhi Child Health, to start treatment for that particular adult. Nevertheless, that was followed by series of orders that were ultimately passed, because of which if I'm not mistaken, about 47 children are being treated in Indira Gandhi Child Health in Bangalore. And roughly, if I have the numbers correct, the government of Karnataka has now till now funded roughly more than 12 plus crores in treating these 47 children. That has been what has been the our way of getting the government to take responsibility and do this. I say this because as children, whenever we wanted something, we always went to our parent and asked for something, right? Same way as citizens, the government, the elected government or the executive, is our parent. I mean, it's in law, in common law, there's a principle of parents partiae. On that basis, we have gone to the court, and court has compelled them under this principle to give our children the treatment that they deserve. Now, as you rightly mentioned, currently the effort has always been only towards the procurement of the drug, whatever the drug that is being prescribed. Now, there are certain other challenges that come along here. Primarily, whenever there is a crowdfunding, there is the accountability is only towards the person who has contributed. Now, that whoever has contributed in a crowdfunding initiative would not really be happy to really find out what's actually happening. But once when you're looking at the involvement of public money, that is tax-paid money, it does call for a fair amount of accountability or the effectiveness of it. Currently, we are doing a bit of getting the drug, but there has to be a consistent effort by the doctors who are administering the drug and the clinicians who are there to assess and find out how effectively this is happening, so that this one can whatever the grant that we're able to get the government to fund can be evenly spread to reach a much wider audience. Currently, that is what presently the main challenge is. I would like.
Very much, Mr. Sudarshan, because you were explaining this, because now lots of groups are going in for crowdfunding, and now even for SMA it's around 16 crores. Yes, when government pitches in, as we rightly discussed, like we should have accountability. We should have teams of doctors and people who are following. For example, even if you give 10 children, if you're going to fund, but then that they have to be followed up, because these are drugs which are fast tracked by the FDA. So we need to be accountable for the money we are getting as crowdfunding or from the government. So as you rightly said, accountability is what really needs when we are working with such crowdfunding or funding from the government. And again, we have taken, and I thought at least one question from the audience. If do you think we have one question from the audience which we want to answer?
Please go ahead.
Ma'am, we don't have any questions from the audience at the moment.
Okay then. So it is more like there were quite a few common things which we wanted to address. Like Dr. Prochi, you wanted to say a few words on early intervention. Dr. Prochi, you're there?
Yes. Hello?
Yes, Dr. Prochi.
Yes. Hi, so since this is a platform even for the public, I just want to stress that there should be awareness among everyone that early intervention is really important, because as mentioned over here, you need to try and prevent damages as soon as possible. All right. So don't just wait and see ke like bacha badega, baad mein dekhenge. If you feel there is a problem, then just go to the doctor. Another thing is that everybody should know that DNA testing is very important. We have many cases where the parents come to us once she's pregnant, and then they give us a history that there was an earlier child with this problem for so many years. We did this test, but the child has died, and now we don't want the same thing for the next pregnancy. But then what was it? Nobody is saying, nobody told us to do any test for this genetic. So that even the public needs to be aware, so that it is not, I mean, genetic tests are very expensive. They don't have to do the test if they can't afford, but at least they should be aware that a little blood can be drawn in one purple top tube, which is the EDTA tube, and kept in the refrigerator for a few days till they find out where they can do the DNA extraction and storage, and that is not expensive. Even if it is just stored, and then when they need to do a test later, they can use that sample, and that will be better. And they all should know that before getting pregnant for the next time, all this should be completed. This is very, very important, because then you can have an accurate prenatal diagnosis. And also everyone should be aware that now, for those who can afford, there are things where you don't have to get pregnant and test and then abort if there is a severe problem. But from the beginning, you can go for an IVF, even if you are fertile. So these days, even fertile couples are coming for IVF in cases where one of them has a cancer mutation like the BRCA, and they don't want to pass it on to their children. So if we know the mutation, then we do an IVF. We have the embryos in our hand, and we can test all of them and then select the one which will be normal and then transfer that. So it's just spreading awareness to the public about all these. Thank you.
Yes. Thank you, Dr. Prochi. And I think since we are really going out of we have already 2:45, the other session is to start. I thank everybody who are here, who have come over. And I know it's a very tough thing to manage within an hour or so. And I would still say we would have the minutes, and if we could get again together to really, because what I strongly feel after hearing everybody and being in the field and having lots of hopes where though health is a state subject, we can convince the state to fund and still convince the center if we have the numbers. And there is a process in which we can do it. And I think the human will and the passion will definitely take us forward over there. And I thank everybody who are present, who have given their time, from the patient leaders to the support groups, Mr. Prasanna, Elizabeth Vroom, Dr. Rolian, Mr. Sudarshan, all of you, thank you so much for being here. And again, we are going to leave here with lots of hope. And I would just end with one slide. The human will, the force unseen, the offspring of a deathless soul, can hew away to any goal, though words of granite intervene. So this has been something which has kept me going for the last more than a decade. So I know it's a very tough subject, and we are all sort of to have this, say, the willpower is to the mind like a strong blind man who carries on his shoulders a layman who can see. Because all of us see a particular thing, we are unable to see, or our hands are tied in lots of other things. But still, with a will, I'm very sure that we can take things forward. And again, to say we are a group, in crowds we have unison, in groups harmony. We want a single voice. We need to be together, put a process in place, go out. We don't want single notes to be there. And I think that will be the secret of this group. And though being alone, rare, neglected often, I think we are making ourselves allowed with a voice in unison. And I'm sure this session will give lots of hope. We have come together, it's a start. And now we will have our own ways to take things forward. Again, thank you so much for being here, and we'll all keep in touch. And thank you all counselors, and together we make a difference. We'll make it. Thank you.
Thank you all.
Thank you all. Thank you all.
Thank you all.
I'm sorry we didn't have much time, but I know it's a very emotional thing, but thank you again. We'll be in touch. Thank you.
and namaste. Greetings and good day to all who have been able to join here with us live. My name is Suraj Manikantan, and I am a board-certified genetic counselor. My colleague moderator, Ms. Ariba Khan, and I am privileged to host a session on genetic counselors as champions of families in the era of genomics. Our dear French geneticist Emmeline Devoyne said, "The genetic counselor is like an air conditioner. When you do not have it, you do not realize you're missing it. But when you have it, you cannot live without it." Truly, genetic counselors give solace to families in distress. I'm sure you'll enjoy this session when we have attempted to portray the inevitable role of genetic counselors from experts across the different parts of the globe and eminent chairpersons. I take pleasure in inviting my colleague moderator, Ms. Ariba, who is also the organizing secretary for this conference, to say hi to you all.
Hello, everyone. It is a pleasure to be moderating this session with Suraj. As genetic counselors, we are continuously serving families with science and empathy. And this session is going to help us learn from eminent genetic counselors how we can do this even better. Back to you, Suraj.
Thank you, Ariba. Yes, we're going to start this session. May I take the pleasure in, of inviting eminent chairpersons to this session. May I introduce Ms. Sonali Sringaram, who is the founder and managing director of Cycle Oncology Private Limited. She has done her master's in business administration in Indian School of Business, and she has a BTech in computer systems engineering in Massey University, New Zealand, and her interests are in oncology and community cancer clinics. She has established a network of holistic cancer treatment centers in Telangana, and with the vision of expanding it to other states in the South India, aiming to improve access and affordability for quality cancer care in India. She has worked extensively in corporates like Accenture as a strategy consultant, transformation projects across the UK and Asia Pacific. She has numerous awards to her laurels, such as Healthcare Leadership Award, IBM Indian Onward Leadership Award, Indian Leadership Award for Healthcare Excellence, Accenture Leadership Program Award from the UK, Indian Business School rank holder, Leader of Future Award from New Zealand. And over to you, Ms. Sonali Sringaram. It's a pleasure and honor to have you.
Thank you so much, Suraj. Thank you for those kind words. It is wonderful to be with you all this afternoon. Thank you so much for having me. I think this is the third year that I've been part of the Board of Genetic Counselors of India's International Conference, and I must say you never disappoint. I always marvel at the richness and the quality of debate and discussion we have on how important and how relevant genetic counseling actually can be in India. And as we work at cancer clinics, we are also, I would like to think that in a way we are trying to adopt genetic counseling as well into becoming a part and parcel of cancer treatment in India as well. So thank you so much for that, and wonderful to be with you all.
Thank you so much, Ariba. Yes. Ariba, may I request you to introduce our next eminent chairperson?
It is my absolute pleasure to introduce Dr. Thangraj, who is an exemplary in his field, and he's an expert in genetics. Currently, he is a director of the Center of DNA Fingerprinting and Diagnostics. Previously, he was the chief scientist and a group leader at the Center of Cellular and Molecular Biology. In his career highlights, he was elected Fellow of the Indian Academy of Sciences, Indian National Science Academy, and National Academy of Sciences. He has been awarded with several prestigious awards, such as the Sun Pharma Award and the J.C. Bose Fellowship Award. He also has other numerous awards, including the Distinguished Scientist and Lifetime Achievement Award. He is the board editor of Mitochondrion, associate editor of BMC, Typical Medicine, and International Health. He is a member of the editorial board of journals Scientific Reports, Human Genetics, and Clinical Genetics. He has been a president of the Indian Society of Human Genetics, and his interests are origin of modern human, cardiovascular diseases, mitochondrial diseases, and male infertility. Hello, Dr. Thangraj, and welcome to the conference.
Good afternoon, good morning, and good evening for the colleagues who are joining from outside India. It's my pleasure to be part of this conference. I think I've been associated with for the last few years. And it's always important to have genetic counseling as a part of genetic diagnostics. Otherwise, whatever we do, it may not reach the common public. Particularly country like India, where we practice endogamy and the consanguinity, we expect that the population-specific genetic disorders are very high. So in that context, it's very, very important to organize such conference and make more and more younger generation to learn more about genetic counseling and take it as a profession for the betterment of the common people. Thank you very much.
Thank you, Dr. Thangraj. May I please request you to introduce our first speaker, Mrs. Carrie Cresswell.
So good morning, Carrie. Welcome you for this session. It's my pleasure to introduce you. Dr. Carrie, or Miss Carrie, has done MSc Genetic Counseling from University of Wales at Cardiff in UK. And she is a registered genetic counselor with the Genetic Counselor Registration Board at UK. And she is currently working as a genetic counselor at Yorkshire Regional Genetic Service at Leeds in UK. So without wasting much time, I invite you to give a talk.
Thank you. Hello, everybody. Good afternoon. I'm going to be talking about prenatal and preconception genetic counselling. Sorry, can you pass the next slide, please? So the aim of my talk is just to share our experience in Leeds of preconception genetic counselling and prenatal counselling. And so I'm going to just briefly mention about free fetal DNA testing, CVS, amniocentesis, also about pre-implantation genetic diagnosis, and then try and include some of our examples from our prenatal clinic. New slide. So just in the UK, we have obviously quite a lot of services, and we all liaise with each other. So we are very lucky that the predominant part of the UK is actually covered by genetics, mostly our regional services. Sorry, next slide. So again, in the Yorkshire Regional Service, we have a mixture of consultants, registrars that are training to be consultants, genetic counsellors. We've got a big research team, and we've also got a large admin team to support us all. And then we liaise closely with the DNA and cytogenetics labs, of course. Sorry, next slide. So from our in genetics and Leeds, we have we've got adult pediatric cancer, but we have prenatal pre-implantation genetic diagnosis as well. But we deal with everything. So Huntington's disease, cardiac, ophthalmology, we've got specialist clinics. So NF1, 2, and VHL, metabolic clinics, we've got sclerosis clinics, pediatric cancer. So there's a wide range of clinics that we do. But obviously I'm going to be focusing on prenatal and pre-implantation genetic diagnosis. Sorry, next slide. So with regards to preconception counselling, when we see our patients, we obviously have to talk about various reproductive options with them. But firstly, we need to confirm, is there a confirmed diagnosis, and is there a mutation to test for? Because obviously we can't go anywhere if we don't have a mutation in the first place, or a chromosomal change or something to test for. Secondly, what options are available for that couple? Would the couple want prenatal testing? Is that acceptable to them? But would the couple choose termination of pregnancy if the fetus is affected? There's no point in a way of doing prenatal testing if that couple then would decide they would never think about having a termination of pregnancy. So we could obviously then test the baby at birth on fetal cord instead. But would termination as well, another big thing is to consider is, would termination of pregnancy be offered for this particular condition? Is it life limiting and or at this particular gestation? You know, for example, cystic fibrosis. The trend now in the UK is more to not really put people off, but for them couples to really consider after 20 weeks, do they really want to consider termination of pregnancy? Because it is felt that CF has become more treatable. It's very targeted therapy in the UK now, and there's specialist clinics, obviously, and they get offered an appointment with the consultant respiratory person who leads a CF clinic. So it's very much depending on what the condition is. And also, of course, if it's after 24 weeks, because 24 weeks is viability in the UK. So if a baby, obviously, I'm sure probably similar in India, but if a baby is born after 24 weeks, you have to resuscitate that baby. So that's obviously a bit of a complication. And when the anomaly scans at 20 weeks, then if you get an abnormal scan or abnormal results afterwards, you've got to just be considering what condition is it? Is this appropriate to offer a termination for? And would the obstetricians do that? So also another consideration is pre-implantation diagnosis. Is that available for this particular condition? Has that actual condition been licensed for PGD by the HFEA? So it's a Human Fertility and Embryology Authority of the UK. And also, would the couple qualify for NHS funded PGD, because PGD is really expensive? Sorry, next slide. So non-invasive prenatal testing and IPT. So free fetal DNA testing, we're taking from 8 weeks in the pregnancy. So it's non-invasive, you're taking a maternal blood sample, but we need to have the woman scanned, have a dating scan to just confirm her EDD, her estimated due date, how far she is in the pregnancy, and then for the sampling from 8 weeks, because obviously before that we can't extract enough fetal DNA. So we offer fetal sexing for excellent conditions, for example, obviously Fragile X or Duchenne muscular dystrophy. We also do some direct gene testing for some conditions like cystic fibrosis, spinal muscular atrophy. We perform it for aneuploidy, so triploidies, and 45X, 47XX, Klinefelters. But the ethical considerations of that is that it's not for sex selection of fetuses. So it's not because a couple want a boy or a girl and then terminate the other sex. Next slide, please. So amnio and CVS, sorry, next slide. So of course, you all are aware of what an amnio involves. So you're obviously taking a sample of the placenta. We usually then take a sample from the mother as well, which I'm sure you would do as well, but we would do it for a maternal cell contamination. So you have a blood sample from mother and then the fetal sample for the chorionic villus. Sorry, next slide, please. And then versus amnio, because if we cannot do the CVS, if maybe the placenta is lying behind the baby, we'll have to wait a bit, for a few more weeks to see if the placenta is growing where we can actually reach that placenta, or if we can't, then we have to do amniocentesis, or if it's a late diagnosis, maybe on the 20-week scan, we then have to go for amniocentesis, of course, which is a fluid extraction. But of course, the time for results is taking a bit longer because you've got to culture the cells as well. Sorry, next slide. So now we are more tending to go for arrays. So either array, well, we used to go for array CGH when we're doing testing for CVS and the amnio, but now we're more going for SNP array. So, so obviously single nucleotide polymorphism. Each of course, you know what those are involving. So you hybridize a sample, and of course with the array you have a control sample from the array to a microarray chip, and you look for the differences in dosage against the reference. As I said, Leeds has moved from the array to go to SNP array testing. So there's different benefits obviously between the two, but array is better for detection of mosaicism, and they can also look for loss of heterozygosity and UPD, uniparental disomy. Sorry, next slide. So when we compare, different techniques, so conventional karyotyping, which we did years ago, obviously you can pick up aneuploidy, you can pick up balanced translocations and rearrangements, also inversions. You can pick up unbalanced translocations, of course, triploidy, but you can't see the heterozygosity and you can't check for consanguinity. You can't see, obviously, the CNVs, copy number variants. So the array CGH, that you can pick up the aneuploidy, but you couldn't pick up the balanced translocations or inversions translocations, etc. You could pick up the unbalanced translocations. You couldn't pick up triploidy, but you can pick up obviously the CNVs. Now going to SNP array, if you look down there, that's got the best pickup rate, because you can pick up aneuploidies. You can't pick up the balanced rearrangements or inversions, but if they're balanced, then in theory, they shouldn't really make any difference. So you're not really looking for balance. You're looking for the unbalance, which you can detect. You can see the triploides. You can see that, well, we can also see if there's any loss, the loss of heterozygosity, or if there's UPD, it's consanguinity, etc. And the CNVs you can pick up as well. Sorry, next slide. So for the benefits of array, it's early diagnosis. Advantage, early diagnosis, it's a first line test, reduce the need for other tests. It's high resolution, so we have an increased diagnostic hit rate, greater accuracy of location, size of imbalances than karyotyping or FISH. And you get information on relevant genes that could be, causing the baby's phenotype. But there's limitations, of course, to that. So there's dosage changes only for array. Balance rearrangements, as we said, is not detected. You don't get information, positional information on DNA gains, and low level of mosaicism is not detected. And the other big problem is that you can get variants of unknown significance, and that can be a bit of difficulty. So, and the other thing is that we can sometimes find incidental findings. You can find something that you weren't looking for. Next slide, please. So for example, I've just had a case in the last few months where we had an incidental finding on array. And so this lady had a CVS, and on the array, a VUS was detected. So there were several genes deleted, but including PMS2. So obviously that's a gene for Lynch syndrome or HNPCC. So therefore, the fetus was diagnosed with Lynch syndrome. But just to bear in mind, in the UK, in childhood, we do not test for Lynch syndrome, because particularly we have, with a Lynch, we normally start at 25 years of age for bowel screening surveillance. But for PMS2 and MSH6, we then would only start surveillance from 35 years, by colonoscopy. So it's a long time, and so there's no relevance to that baby. But so obviously then we had to work out, well, is this de novo or do the parents carry it? So the parents were offered testing for the VUS and PMS2 after we counseled them for Lynch syndrome. And then, of course, we found it in the one parent, so then we have to offer the parents and their siblings and their parents. So it's cascade testing then to see, okay, well, who else in the family has got this PMS2 mutation and who else needs to be screened, basically. So it's sort of a bit of a ripple in a pond, really. So next slide, please. So pre-implantation genetic diagnosis, we offer that as a service in Leeds. We liaise and we work with London. So we obviously offer it if a mutation is known in a family or if there's a chromosomal rearrangement, there has to be more than 10% risk to the embryo of having that condition. So sometimes we even offer if there's a high risk of gonadal mosaicism. So maybe a couple have maybe even had 3 children with the same condition, and we haven't found the mutation. We're thinking, well, okay, so far we haven't found anything, so it could be gonadal, so we do linkage or something like that. But obviously it involves IVF. Blastocysts are biopsied and genetically tested, and obviously we only implant the unaffected blastocysts, and we discard the other embryos that have got the mutation or the rearrangement. Sorry, new slide. So obviously it's a complex procedure. We need NHS funding unless a couple wants to fund privately, but it's in the region of £12,000, so not everybody has that amount of money. We can also do genetic haplotyping with that. So as you say, it's a step-by-step process at the bottom there. So really from start to end baby, take-home baby timescales, you could be looking at, well, take-home baby add another 9 months, but 2 years, 9 months. Used to be about 18 months from sort of start to referral to start of treatment. But now we're adding on a little bit of time, we're a bit short-staffed and, so it's a lengthy procedure. And obviously the couple have to then make sure that they're on contraception so that they don't have a natural pregnancy in the meantime, because obviously then they would be taken off the list and they wouldn't be eligible. Sorry, next slide. So haplotyping with PGD, we do that if we're offering, for example, exclusion testing for Huntington's disease. So maybe if our patient does not want to have a direct mutation test for HD, doesn't want to know CAG repeat, so, but he knows he's at 50 risk or she's at 50% risk, that his mother or father has the mutation. So we track the grandparents' allele, down through the pregnancy. And then we can obviously try and implant the embryo that does not have the grandparent who's affected, one of their alleles. So we can use that, and we do on occasions. Next slide, please. So just, I mentioned before, the Human Fertility and Embryology Authority. So they're the regulatory body in the UK, and they issue the licenses for PGD for certain conditions. But sometimes things aren't, particular conditions aren't licensed, so then we have to apply for a license. So we have to write a license and apply for that to be approved, etc. So that can add on 6 months to the actual procedure for the PGD. So again, it's a very lengthy procedure. Next slide. So things to think about when we discuss with our patients about referring them for PGD. So I might have a family who, they've maybe even got cystic fibrosis, we'll use an easier condition. So then they want to go for PGD because they might have had 2 children who've affected and they don't want the heartbreak and they don't want to opt for termination of pregnancy. So things I'll be talking to them about would be, would they be eligible for NHS funding? So for the woman particularly, she can't be too overweight. If a woman's obese, it reduces the fertility. So the body mass index should be below 30. Are they smokers? If they smoke, then they're not eligible because that's again reduces the fertility for men and women. Age, the female partner must be under 40 years of age. So for simple cases, yes, we can treat the woman age 39, but for more complex cases where we need to apply for a license and the lab needs more time to work up primers or whatever, then she probably needs to be 37 or 38 at the latest, the oldest. And of course, all mutations must be confirmed in an NHS lab, same as obviously any chromosomal changes or anything. De novo cases must be confirmed as well. Is the condition licensed? Yes, we've got to think about that. As I said, you add on 6 months. And availability of samples for pre-implantation haplotyping. So do we have the grandparents, are they still alive? For example, a Huntington's family, is that the man still alive that's got the Huntington's? Have we got a DNA sample stored on him that we could use? Because we obviously need his sample and his wife's, the mother's sample, and then the couple's samples as well. So we need 4 samples for that. But if the person's passed away and we haven't got a DNA sample, then of course we can't offer that. That will be very difficult. Now, the other thing also, of course, is the welfare of the child. So if we think that woman, maybe, for example, it's a woman who's got a repeat size of CAG, repeat size of, I don't know, 52 or something, and she's 32, 33, and maybe she's starting to develop symptoms of Huntington's disease, they wanting to then progress with PGD. And over the year or so, she develops more symptoms, becomes moderately affected. We're thinking then, who's going to look after that baby? It's all well and good to offer PGD because it's available, and the couple might tick all the boxes on the other criteria for getting the funding, but actually if that mother's then going to become severely affected within a few years, what is the welfare of the child? Who's going to look after that child? Yeah, sure, the father's around, but so these are things that we need to think about and talk to the couple, and we have to be open and honest with them, and sometimes it's difficult. Sorry, next slide. So challenges with prenatal genetic counselling. It's not always a crystal ball. We cannot always tell how or when someone may develop the condition. There'll be variability of symptoms within a family. So especially with more array testing done and VUS being detected, and or conditions indicating neurosusceptibility loci. So for example, these chromosomal deletions, some of them are not reportable antenatally if found on CVS or amnio. Sorry, next slide. So for example, 16p11.2. So you get deletions and duplications of that region, but that's a neurosusceptibility locus, and you could get different problems with that. So obviously language difficulties, seizures, fits, and you can get macrocephaly, etc. But the penetrance is 47%, it's not 100%. So there's going to be, more than 50% of patients are not going to have any of those symptoms. So they can carry it and be asymptomatic. So yeah, it just depends really. So proximal duplications, let's have a look. So percentage there. So the deletion's got the higher penetrance, but the duplication has got a low penetrance, and that is not reported as opposed to the deletion, which is reported. So is it a deletion or is it a duplication? Is it reported? If it is reported, then that couple then might terminate the pregnancy. But if it's not reported on array, in theory, we do not offer it as a test for subsequent pregnancy. If it's found in a child, for example, with speech difficulties and seizures, and we've done an array on them, and that is detected, it's very difficult to offer that to a couple in pregnancy because of the variability, because a parent might be carrying it and they'll totally be asymptomatic. So that is very tricky. Next slide, sorry. And so the next two slides are really just similar. So we're just saying, again, that there's various of these VUSs that are neurosusceptibility loci, and they can cause problems, but they're not all reported. Sorry, next slide again. So another example, so some are reported and some may be reported. So it makes us very, very tricky, because the family can say, well, my child is very severely affected, or in their mind is more, severely affected. He's battling at school, he's not keeping up, and now he has to go to special school. I want to have another baby, I want to have the testing in pregnancy. But if it's reported, that's fine. Then we can probably offer it in a prenatal test, because then the obstetricians would be saying, okay, well, we will offer a termination of pregnancy. But as I say, for some of them, they might, it's very difficult to then offer termination of pregnancy where we cannot, determine, even on the results, whether that baby is going to be affected or might be asymptomatic like the parent. Sorry, next slide. So obviously, when we're testing prenatally, we don't want to test for adult onset conditions if, for example, that family will not want to go for termination of pregnancy. So because obviously you're taking autonomy away from the child, that unborn fetus, that example, Huntington's disease, where it's not juvenile, majority is not juvenile, where there's maybe only 40, 42 repeats in the parent, it's not likely to expand fully to a juvenile repeat size of 60. Then we do not offer the testing in the pregnancy where the couples would not want to terminate, because you're then giving that fetus a predictive test, which is, in the UK, we do not do that. It's not ethical to offer a test, obviously, antenatally, but it would be offered if that couple would say 100% yes, they would end the pregnancy. Sorry, next slide. So, but just thinking about other conditions. So as we know, other conditions can be quite difficult. When you're doing testing in pregnancy, you're trying to make a diagnosis, or there's something in the family, if there's retinitis pigmentosa and you haven't worked the family up, it's a new referral in, this woman's pregnant. We don't know, it's obviously heterogeneous. There's different modes of inheritance. Obviously we can try and assess that with the family history when we're taking the family tree. But we need to find which gene is involved. We need to find the mutation first. So it's not that straightforward. And also then testing may not be always available. So causative gene might not be identified because it might be idiopathic developmental delay and learning difficulties, etc. Sorry, next slide. So what do we do if there's no mutation in the family? So sometimes then we can do a panel of genes, because we think, okay, if, for example, that in the pregnancy, if on scan they've found various anomalies, we then think, okay, well, obviously, what condition does that link to? What is it likely to be? And so, okay, it looks like a skeletal dysplasia or something. So then you can do a panel for skeletal dysplasia genes. But if nothing comes up, at the moment, we're doing fetal exomes, so we're doing the R14, but we're not doing a fetal genome just yet. But basically, the next step would then be potentially a fetal exome to try and figure out, okay, what is causing this fetus's problems. But this testing, the genomes, as I say, is more for after as postnatally, where we are at the moment. Sorry, next slide.
Kerry, you have 2 minutes, please.
Okay, sorry. So antenatal anomalies. So again, if we have any anomalies at 20 weeks, if the diagnosis is likely known, direct gene testing is requested. If it's a chromosomal imbalance, an array is requested. If diagnosis is suspected, we do a fetal gene panel. If diagnoses are not known, we do a fetal exome. Sorry, next slide. So just to give some examples, challenging cases. So I had a lady, we'll call her Tina, and she tested positive for an HTT mutation. She had a 40+ repeat size CAG repeats of Huntington's disease. She had a predictive test. And then she wanted to be referred because she didn't want to have a baby affected with HD as well, or to have the expansion. So they were referred and worked up because they wanted PGD. But unfortunately, Tina had a low ovarian reserve, and hence PGD was not possible. So the couple had a miscarriage at 11 weeks, and then they tried for 2 years to conceive. Now, by this time, she's 39 as well. So then she conceived, and then she was referred to our prenatal clinic where I saw her. And she's then requesting prenatal testing by CVS for HD. But actually this pregnancy was very precious, and she felt guilty for wanting the baby to have HD. That's why she was requesting the testing. Sorry, next slide. So she was aware that prenatal testing would only be offered if they would opt to end the pregnancy and if the fetus carried the expansion. So we need to be sure that the couple would opt for TOP if the testing was positive. But if the TOP is not undertaken on a positive CVS result, obviously, as we said, it would give a predictive test to a fetus. So we had lengthy discussions with Tina, and basically it boils down that Tina was pressured by her partner's family to do the right thing and to end Huntington's disease. So I just encouraged her to make the decision that was right for her. Ultimately, she wanted a baby and felt that prenatal testing and termination was too high a price to pay. And I was very relieved that she cancelled her CVS appointment, actually. So she didn't go through with the CVS. So she's still pregnant, and she's feeling better about that. So we're helping her to make the right decision. Sorry, next slide. So another case, and this is my last case, I'm almost finished. So challenging prenatal cases here. This couple had an amniocentesis after 20-week scan, and it showed multiple cardiac rhabdomyomas. So an array was performed on the amnio, but it didn't detect any abnormalities. The couple chose to terminate the pregnancy at 24 weeks, so they needed feticide as well. So after further scans, they detected more rhabdomyomas. So the couple named their son, they cremated him, they kept his ashes. He was very precious to them. The postmortem showed multiple brain tumors, and the fetal tissue, we then tested the fetal terminated tissue, and we detected a TSC2 mutation. And so this child had tuberous sclerosis. So both the parents tested negative after that, and we gave them a 1 to 2% risk of because of gonadal mosaicism. Sorry, next slide. But sadly, when the TS was suspected after the scan, the couple chose a TOP, and as I said, it needed feticide and induction of labor. And they felt it was the right course of action at that time, as they didn't want their son to suffer. But Our Lady Sonia fell pregnant unexpectedly. She was waiting for the contraceptive implant. She already had 2 children. She was worried this pregnancy would also be affected, and she needed reassurance that CVS would definitely detect the TSC2 mutation. And actually her LMP date was a due date for her baby. So it was really quite upsetting for her. I explained the CVS procedure would have a 1% miscarriage risk, roughly the same risk as a recurrence due to gonadal mosaicism. Next slide, please. And so she wanted to proceed with CVS, so I'm arranging that at the moment for her, but she's still grieving. It was only a few months ago that she lost the baby, and she feels a lot of guilt, and she just wanted her baby back. She was crying on the phone. I've just had times where I've had her half an hour, she's crying and crying. She's not come to terms with the termination and what she has done. She feels guilty. She's overwhelmed with grief, and it's really hard for her. So I encourage her to express her feelings, cry if she needed to, help to see the decision for the couple was made for them, that they decided at that time was the right decision for them. And so she also needed additional counselling support. So I referred her to a charity called ARC in the UK. It's Antenatal Results and Choices. And they offer a counselling to women and couples. And now she's proceeding with a CVS. And we're just undergoing that at the moment. So next slide, sorry. So that's the end of my talk, just to give you a few examples. Are there any questions?
Carrie, we'll be taking questions in the panel discussion at the end of the entire session.
Good.
Thank you. Thank you so much.
Thank you.
Dr. Thangraj, could you please introduce our next speaker, Ms. Brianna?
Good evening, Brianna. It's my pleasure welcome you for this session. Ms. Brianna has done her MSc in genetic counseling at the University of Melbourne in Australia. Presently, she is a principal genetic counselor at KK Women's and Children's Hospital in Singapore. She's a treasurer of Asia Pacific Society of Human Genetics and secretary of Professional Society of Genetic Counselors in Asia. So with this brief introduction, I welcome you, Brianna, and give us the talk.
Thank you, Dr. Thangaraj, for the kind words. Just give me a minute to pick up my screen. Okay, so I've titled my talk Looking for Trouble because this was something that one of the patients had said to me once, that, you know, we know what's going on in the family already, and looking for other people who have a similar genetic condition or who may have the similar variants carried by the proband, that's just looking for trouble. And to be honest, it is a little, but there are benefits to that, and let's talk a little bit about that today. So on this title slide, this is a picture of the hospital where I work, and if you ever come to Singapore, I hope that you will contact me and I would be happy to welcome you to the country. So I don't have any financial obligations to disclose, but I'll just very quickly go through today's talk, which will talk about what genetic cascade testing is, why we should do it, and how to identify the people who are at high risk. And then we'll talk a little bit about the barriers that we face in talking to some of these families, as well as how to overcome these challenges. So what is a cascade? I looked up the dictionary, and it was defined as a succession of actions, stages, or processes. But in genetics, we usually refer to this as the testing of a known familial variant that is pathogenic in nature. So why would we want to do a cascade testing for these families? First of all, it can identify individuals who have increased risk of certain genetic conditions. And a lot of the time, it can be cost effective. By identifying these people early, we can help them to avoid mortality, morbidity of the disease. And sometimes there is screening and surveillance available. Sometimes it is purely knowledge for patients. And ultimately, if we do detect these variants early enough, then sometimes patients and their families can have reproductive choices being made available to them. So I'll just go through a couple of families that I've seen over the years. And basically, this was a family whose child had OTC deficiency, which is a metabolic condition. And this is one of the metabolic conditions that is X-linked in nature. So in the proband, we did identify a pathogenic variant in him, and this is a urea cycle disorder that causes high ammonia levels in the blood when the patient takes in proteins. Okay, and for him, he was first diagnosed very, very early on in life. He was classically affected and he presented in the neonatal period. So in this case, because he was picked up very early and with appropriate restriction of the diet, we did manage to have a good outcome, and he is a fairly normally developing boy. But the issue was that this being an X-linked condition, we wondered whether his elder sister was a carrier of this condition. Mom at that time did not want testing for herself, so we did not know whether mother was a carrier or not. But we also know that approximately 18% of females who are carriers do experience these high ammonia episodes, and they can be fatal over the course of their lifetime. So with the sister, we were fairly concerned that she might be at risk as well. And so this went on for a couple of years until the boy actually ran into a high ammonia crisis. And this really sort of woke the parents up, so to speak, with regard to how serious this condition is. So they had been sort of lulled into a complacency because he was very well managed, much to the dietitians and the parents' credit. But having that crisis really brought home the reality that this was a serious genetic condition. And at that point of time, they brought their daughter in, and she was a teenager by that point. So we couldn't really just catch hold of her and subject her to testing. What we did was we really had to sit down with this young lady and her parents and explain the implications of testing versus waiting till an event happened. And ultimately, she did decide on having testing for herself with her parents' consent. And we did establish that this young lady was a carrier, and we were able to give her the precautionary advice that was necessary to keep her healthy and well. So for identifying individuals at risk, we really have to understand what the inheritance pattern of the condition is. And we also have to understand what the variant is, as Ms. Carey earlier spoke about, really knowing whether a variant is pathogenic or not does play an important role in giving advice with regards to the medical management of the patient from there on. There are many guidelines that are now available internationally, and we often encourage medical practitioners as well as patients to look up these guidelines. We give them as part of the genetic counseling session to the patients and for them to pass on to their primary care providers as well. And as always, when necessary, we encourage primary care providers as well as patients to engage with genetics professionals. And as a genetic counselor, even though we do have exposure to a wide variety of genetic conditions, if we do encounter something that is extremely rare, we can and we have engaged with the experts in those fields as well. So the next patient I'm going to talk about really brings home the point of knowing what the classification of the variant is. So to protect the privacy of this patient, I've refrained from mentioning the gene because it's an extremely rare genetic variant that we saw. And so this patient had her first pregnancy in her mid-20s, and at the 20-week scan, they realized that there was a skeletal dysplasia that was diagnosed on the 20-week scan. By all indications, we thought that it might very likely be a lethal skeletal dysplasia. And based on that information, she made the decision to terminate the pregnancy. But during the genetic counseling session, before the termination, we were actually talking to this patient about the fact that there were hundreds of skeletal dysplasias, and many of them have different inheritance patterns. And without a genetic diagnosis, we would not have been able to tell her what the recurrence risks were like for her and her husband. So ultimately, she went away and said that she would think about it, but she actually did not go ahead with any genetic studies. And after that, she actually went back to her obstetrician, who had mistakenly told her that this would very likely be an autosomal dominant condition that was de novo, and the recurrence risk for her would be very low. So with that, she felt slightly reassured and went on to have a second pregnancy. However, at the early scans, again, we started seeing signs of a skeletal dysplasia. And so with this patient, she had decided that because she had terminated the first pregnancy, she would want to actually go forward with this pregnancy and see whether it truly was lethal, because back-to-back pregnancies being affected, she felt incredibly guilty with ending the first pregnancy. And she thought, you know, if it truly was lethal, she would accept the consequences. But without any further testing, we would not really be able to make any decisions about what the genetic cause was. So unfortunately, with this pregnancy, there was an amniocentesis done so that we could get the genetic material of this pregnancy as well as the previous one. When we first knew the pregnancy had occurred, we had started some investigations on the stored DNA from the first pregnancy. But while that was in progress, the amniocentesis was in progress, about 3 days after the procedure, there was intrauterine death. And we had not received any information from either pregnancies about what the genetic diagnosis was. Eventually, we did get results from the first pregnancy, and we did see one pathogenic variant and one variant of uncertain significance in a autosomal recessively inherited condition. So based on this, we had decided that since we had cells from the second pregnancy, let's take a look at the genotype of the second pregnancy. So working up this whole family, the variants did show biparental inheritance, as well as the second pregnancy having the same genotype as the first one. So based on this information and other information from the laboratory, they managed to reclassify this VUS as a likely pathogenic variant. So while this did not help in the first two pregnancies, as well as the management of the first two pregnancies, the couple were now actually able to be given the options of pre-implantation genetic testing or prenatal diagnosis should they decide to have a future pregnancy. So in terms of the challenges and barriers that patients face, we do deal with a lack of knowledge and understanding, not just on the patient's part, but also in the primary care provider's part on occasion. And we do have to grapple a lot with the cost of testing. So here in Singapore, we do have some government funding, but this is a co-payment sort of model. And on occasion, there is no subsidy available for testing. We also deal with family and cultural beliefs that may be very variable depending on the cultural background of the patient, as well as interpersonal beliefs, as well as religious beliefs. And then the lack of awareness and access to genetic services may be something that is a barrier for patients to access appropriate genetic counseling and genetic testing in a timely fashion, especially in countries that are geographically very large. Then we could anticipate that sometimes if patients are located in rural areas, then it could be very challenging for them to get access in a timely manner. And then, of course, with regards to cascade testing, we always have to deal with insurance concerns if we are potentially identifying people who may be at risk of genetic conditions. So different countries have different policies as well as laws in place, but this is something that may be a very real concern, especially in countries without legal protections. So this family that I'm going to talk about is a family that was affected by TTR amyloidosis. And so this man that I saw came in his 60s, and he was suspecting that he might have perhaps some symptoms of amyloidosis. So he knew that his sisters were diagnosed with this condition. They were a fairly open family and shared the information, both medical and genetic, quite freely. And he had seen his sisters go through the whole diagnostic process, and he had become concerned that in his 60s, he was starting to feel a little bit of loss of sensation in his extremities. He was starting to experience a little bit of erectile dysfunction, and he wasn't sure whether these things might be related to the condition or not. So we do know from the family that there had been a pathogenic variant that was already identified in 2 of his sisters, as well as a niece in his family. But what he after that told us was that he also suspected that other people in his family, including himself, might be experiencing some of these symptoms that we were describing as related to the condition. And ultimately, he wanted to know for himself whether he had the genetic variant or not. So we did explain to him that some of the symptoms that he was experiencing might be a process of aging. It might be something that is unrelated, in which case he might need to seek attention from his primary care provider. But ultimately, that we knew that he was at approximately 50% risk of having a variant that could predispose him to amyloidosis. So he had gone away to think about it, because we also talked to him about insurance concerns. And, ultimately he made the decision that he would want to know, not just for his own health, but also to know how worried he should be about his children who were just about reaching adulthood, as well as starting to plan families. So ultimately, not to leave everyone on tenterhooks about this family, he did have testing, and he did not have this genetic variant. So we did counsel him that he would not be at risk of developing symptoms similar to his elder sisters, and his children also did not have a risk of inheriting that pathogenic variant. And in the result release, he was so relieved, because he had actually looked at me and the result and said, "Are you sure? Are you really sure that I don't have this condition?" Because he had been thinking so much about the symptoms, and he had privately convinced himself that he was affected already. And having that blood test to confirm that he was indeed not affected was something that he found very unbelievable. But really, before he started this journey, we had this conversation about what he needed to think about. So we grouped it into roughly 3 areas of conversation, which was, how did this affect me as a patient, knowing that test results are permanent, talking about whether this was a predictive or diagnostic test, and whether it changed anything in terms of management or treatment options for the patient. So this will vary depending on the disease that we're talking about. Okay, and then we also talked about who he would disclose genetic test results to. So was it necessary to disclose this to other family members? If a person is working, would it be necessary to disclose it to work or the insurance companies? And this, again, would vary depending on where you are in the world. And it would be good to familiarize yourself with the local regulations. And then we talked to the patient again about when the best time for testing is. So depending on what the condition is, as the 3 families I've talked about, it really depends on what other life stages of these individuals are at. It might be relevant for perhaps management if there was some sort of intervention, or it might be relevant if a person was in the family planning stage of life, and so on. And then ultimately, was there any utility to this result to the patient themselves? So in terms of overcoming all these challenges, there are a few ways to think about it, and we talk about whether it is through the education of medical professionals who are not involved in genetics directly, and how they can frame these conversations with their patients, as well as partnership with perhaps industry in the situations where there are medications being involved. We have been able to gain compassionate use for some of the enzyme therapies of certain genetic conditions, as well as dialogue with healthcare policymakers. So whether they would be able to institute policies that make sense that do not disadvantage the people who are subject to these healthcare policies. And then ultimately, we also want to talk about how to increase access to genetic counselors. And so this can take many forms. So I see that India has now many programs that are training up more genetic counselors in the region. And I think that there are also many more programs becoming available worldwide. And then also thinking about new models of genetic counseling service provision. So the COVID pandemic has really brought this to the forefront, but many of us are now thinking of new models such as telegenetic counseling to reach underserved areas, whether we can do group genetic counseling in certain situations. And I think this all has made access to genetic counselors much more available to the population that we are aiming to serve. So to end off, I'd just like to show a picture of my group that I work with. So this includes nursing staff, medical practitioners, physicians, laboratory staff, as well as genetic counselors. So I thank you for your attention, and thank you to the organizers for allowing me this platform.
Thank you, Brianna. May I request Dr. Thangaraj to say a few words?
Thank you, both the speakers, for wonderfully covering the importance of the genetic counseling, and happy to hear the work which they are doing in their respective countries. So with that, I like
yes, thank you. Thank you so much. And I would request Ms. Sonali to introduce our next speaker.
Thank you, Suraj. Very happy to introduce Dr. Joy Tumuluk. Dr. Tumuluk is the genetic counselor and university researcher at the Institute of Human Genetics at the University of Philippines at Manila. She is also the clinical assistant professor at the Department of Pediatrics, Philippine General Hospital at the College of Medicine at Manila as well. Dr. Tumuluk has a Doctor of Medicine, MSc in Genetic Counseling, and a BSc in Psychology, and has authored several publications on genetics and handled numerous research projects. Her interests include hemoglobinopathies, cancer counseling, as well as being a leading genetic counselor from the Philippines. She has helped numerous families cope with the diagnosis of genetic disorders. Dr. Tumuluk, welcome, and very eager to hear what you have to say.
Thank you, Doctor, for that kind introduction, and thank you to the organizing team for inviting me to this conference. So I am tasked to discuss with you the role of genetic counseling in newborn screening. So the outline of my talk will be a general overview of genetic counseling, a short introduction about newborn screening, the role of the genetic counselor, and the situation in the Philippines. So genetic counseling, according to the National Society of Genetic Counselors, is the process of helping people understand and adapt to the medical, psychological, and familial implications of genetic contributions to disease. It is a communication process which deals with the human problems associated with the occurrence or risk of recurrence of a genetic disorder in a family. This process integrates the following. Number one, the interpretation of family and medical histories to assess the chance of disease occurrence or recurrence, education about inheritance, testing, management, prevention, resources, and research, and counseling to promote informed choices and adaptation to the risk or condition. Genetic counselors are health professionals with a master's graduate level of education and experience in the areas of medical genetics and counseling. They work in research, laboratories, industry, the academe, and also in advocacy positions. Genetic counselors work as members of the healthcare team. They have many roles such as designing and conducting research, managing clinical cases, supervising trainees, teaching, making healthcare policy, and developing and implementing educational tools, while some work also in administrative capacities. The scope of clinical practice of genetic counselors varies within and between countries. In Europe, the European Society of Human Genetics suggested that the term genetic counselor should be a protected professional title, referring to a health professional who had been educated and trained at master's level to enable them to develop the core competence defined for the role and to practice according to the Code of Ethics. So frequently, genetic counselors are part of a multidisciplinary team in obstetrics, pediatrics, oncology, cardiology, neurology, ophthalmology, and metabolic clinics. So what do genetic counselors do? In terms of counseling, they provide supportive counseling by identifying families at risk and providing information and support to these families who have members with birth defects or genetic disorders, and to families who may be at risk for a variety of inherited conditions. They do interpretation, meaning they investigate the problem present in the family, interpret information about the disorder, analyze inheritance patterns and risks of recurrence, and review available options with the family. In terms of education, they serve as patient advocates and refer individuals and families to community or state support services. They also serve as educators and resource people for other healthcare professionals and for the general public. So this figure represents the global estimate of trained genetic counselors. As you can see, the biggest group can be found in the Americas with around 5,000 genetic counselors, followed by the Europe and Middle East with 1,000 genetic counselors. There are around 350 genetic counselors in Asia, closely followed by about 300 in Australia, and less than 50 are in Africa. Historically, the word genetic counseling was coined by a geneticist, Dr. Sheldon Clark Reed, in 1947. The first master's degree genetic counseling program in the United States was founded in 1969 at Sarah Lawrence College in New York. We now go to newborn screening. Newborn screening is a public health program aimed at the early identification of conditions for which early and timely interventions can lead to the elimination or reduction of associated mortality, morbidity, and disabilities. Newborn screening programs began in the early 1960s with the original work of Dr. Robert Guthrie, who developed a screening test for phenylketonuria and a system for collection and transportation of blood samples on filter paper. Countries include newborn screening as a standard of care, covering a wide range of conditions that genetic counselors could provide care for families affected by endocrine, metabolic, hematologic, immunologic, infectious, and many other conditions. Newborn screening is more than testing. It should always be a part of a system that includes screening tests, follow-up, diagnosis, treatment, and evaluation as necessary. The primary objective should be to ensure that every newborn receives appropriate and timely services. It is composed of evaluation, including outcome monitoring and quality assurance as an important component that encompasses the whole system. Screening, including proper timing and specimen collection, transport, laboratory testing, and reporting. Management, including counseling, treatment monitoring, and long-term follow-up. Early follow-up, including abnormal test notification, tracking, and confirmatory testing. And diagnosis, including clinical and biochemical evaluation. Inherent to each of these components is an education process of health professionals, parents, the general public, and even politicians. Generally, there are several roles a genetic counselor can do to help families understand the significance of genetic conditions in relation to cultural, personal, and familial context. Genetic counseling focuses on understanding accepting and adapting to a genetic diagnosis or risk, and their impact on the individual and family. It includes a discussion on the patient's understanding of what causes the disease, its scientific explanation, and the patient's interpretation of his or her condition. Exploration of the role of personal beliefs and their role in adaptation, and help promote feelings of personal control and mastery over a genetic condition. Um, The genetic counselor also collects, select, interpret, and analyze information, including family and medical history, pedigree, laboratory results, and literature relevant to the delivery of genetic counseling for individuals and families. As a side note on the family history, genetic counselors use standardized symbols in creating the pedigree. Family history can be a powerful screening tool because it holds important information about an individual. The family history can be used as a diagnostic tool and help guide decisions about genetic testing for the patient and at risk family members. If a family is affected by a disease, an accurate family history will be important to establish a pattern of transmission. The family history can also identify potential health problems such as heart disease, diabetes, or cancer that an individual may be at increased risk for in the future. Early identification of increased risk may allow the individual and health professional to take steps to reduce risk by implementing lifestyle changes, introducing medical interventions, and increasing disease surveillance. Genetic counselors can also assist in choosing educational materials for parents and other healthcare providers. They are responsible for the development of these resources or have developed them in partnership with other newborn screening professionals. With proper genetic counseling based on individual situations, families will be provided with important information and a better understanding of the medical recommendations and options presented to them that will help them make informed and sometimes difficult choices and adapt to the risk or condition identified through newborn screening. The role of the genetic counselor is to also help the family understand the medical management and treatment or non-treatment recommendations presented to the family by the treating provider so families can be involved in making the best decision possible for their child. To apply, genetic counselors also apply expert knowledge to facilitate the individual or family to access the appropriate healthcare resources, including medical diagnoses and resources for the management of the condition. Genetic counselors can serve as a central resource of information about genetic conditions for other healthcare professionals, patients, and the general public. Psychosocial counseling is a balancing act between trying to reassure the family while at the same time decrease their anxiety. Genetic counselors help individuals and families identify the psychosocial tools required to cope with potential outcomes. Often, the patient list can further extend to include siblings, the extended family, and their offspring. It is important for the medical professionals providing the counseling to keep in mind that the family as a whole is the patient, and multiple members may rely on the information being provided. This point of view gives the provider a unique perspective and fosters patient care and communication. Another goal of psychosocial counseling is to increase the family's understanding of a genetic condition and decrease misconceptions. Genetic counselors also discuss options regarding disease management and the risks and benefits of further testing and other options. So, newborn screening in the Philippines. Newborn screening here in the country started as a research group in 1996 and became mandatory when the newborn screening law was passed in 2004. It is named the Republic Act of 2004, and it institutionalized comprehensive newborn blood spot screening. When newborn screening started in the Philippines, only 5 disorders were being tested, including congenital adrenal hyperplasia, congenital hypothyroidism, G6PD deficiency, phenylketonuria, and galactosemia. In 2012, MSUD was added to the panel of disorders. And in 2015, expanded newborn screening was started, wherein we started testing for 28 disorders, including organic acid disorders, amino acid disorders, endocrine disorders, fatty acid oxidation disorders, hemoglobinopathies, and urea cycle defect disorders. The newborn screening program's efficiency and effectiveness depends on the smooth integration of sample collection, laboratory testing, follow-up, diagnosis, timely treatment, and tracking of outcomes. Included in this workflow is the counseling of patients. From the time that the family receives the call that their baby has a positive result to the time that the diagnosis has been confirmed can be a scary time for families. Feelings of anxiety, stress, and sadness are very common. Genetic counseling can help alleviate these feelings in order to help the family cope about the newly diagnosed genetic condition in their child, which will hopefully lead to better outcomes for the patient. The referral flow for the newborn screening in the country is divided into the short-term and long-term follow-up. Short-term follow-up includes the time from the newborn screening test to the recall of screen-positive patients undergoing confirmatory tests and the confirmation of the diagnosis. Once the patient has a confirmed diagnosis, they are transferred to the long-term follow-up team in the newborn screening continuity clinics. Currently, we have 14 newborn screening continuity clinics all over the country. In the short-term follow-up flow, the first session of genetic counseling takes place upon the disclosure of diagnosis. At this time, we help the families understand what the condition is and to help them cope with the diagnosis. In the long-term follow-up flow, sessions of genetic counseling can be done over time as needed. For example, some patients who do not follow their treatment or management plan can be recounseled, wherein we try to explore the reasons of their non-compliance. Or maybe the couple is thinking of having another child and they are referred for counseling to discuss inheritance and risk of recurrence and reproductive options. As of 2019, there have been 14 graduates of genetic counseling in the Philippines who are working in different capacities throughout the country. There are currently 20 students under the program. The Master of Science in Genetic Counseling is a 2-year degree program that prepares the students to become competent genetic counselors. The degree program will serve a vital role in the access, delivery, and expansion of medical genetics, not only in the Philippines, but also in the Southeast Asian region. The benefits of genetic counseling in newborn screening, of course, we help improve the parents' knowledge and understanding of the disorder, to increase the compliance to treatment and diet management, to have informed reproductive decisions of parents, and have better family coping mechanism and greater support within the family. Also, empowerment of parents as newborn screening advocates is also one of the benefits, and referral to support groups. So, the role of genetic counselor in the newborn screening is constantly evolving as technology and therapies continue to improve. Assessment of psychosocial and emotional status is equally important. Remember that the genetic counseling is a process that happens over time, sometimes the family coming back for more sessions or for recounseling. And lastly, genetic counseling is not a routine process. It is different for every individual and every family. I would like to acknowledge the following persons, and these are my references. Thank you very much.
Ms. Sonali, requesting for your remarks, and then we'll move on to the next speaker.
Suraj, do you want me to introduce the next speaker or talk about the remarks now?
Yes, please.
Very happy to welcome Ms. Laura Winter-Packett to this platform as well. Laura is a genetic counselor at Abu Dhabi's health services company, Seha. Also, as part of the largest healthcare network in the UAE, Laura works in the corporate head office to help grow and strengthen genomics initiatives across Seha's network of public hospitals and clinics. She has an MSc in genetic counseling from the University of Toronto and is a certified American Board of Genetic Counseling counselors. Part of our highlights include that prior to moving to the UAE, Laura had worked at Mount Sinai Hospital's Familial Gastrointestinal Cancer Research Registry in Toronto, Canada, and in Auckland at the New Zealand Familial Gastrointestinal Cancer Service. She's been involved with the application review and clinical supervision of students with the University of Toronto and is appointed as the adjunct lecturer with the Department of Molecular Genetics. Laura, welcome. The platform is all yours.
Thank you. I will share my screen. All right, so thank you for the introduction. And yes, my talk today is about supporting families with gastrointestinal cancer syndromes through a combined research registry and clinical service. And so as you touched on my background there, I'm from Toronto, where I earned my Master of Science in Genetic Counseling. And then after graduation, I moved to New Zealand. And that was where I was with the New Zealand Familial Gastrointestinal Cancer Service. So that is 3 offices that cover the whole country, and I was based in Auckland. Then I moved back to Toronto, where I worked at a similar service, the Familial Gastrointestinal Cancer Registry, based out of Mount Sinai Hospital in Toronto. And then most recently, I moved to Abu Dhabi in the United Arab Emirates, where I'm currently working at the corporate head office for SAHA, that's the Abu Dhabi Health Services Company. So this is the largest healthcare network in the country, and it serves it runs and operates all the hospitals and clinics in the Emirate of Abu Dhabi, which you can see is geographically the largest emirate. So the role that I'm currently in is a lot more of a planning role, whereas in the past I've been in more of a clinical role. So this talk is really using a lot of what I learned about in Toronto and in New Zealand with their registry services. So speaking about this model, where it's a combination of a research registry and a genetics clinic. And I like to think of it as being made up of several different pieces of a puzzle where the genetic counselor really has a role. And so what I'm going to do today is speak about each of these pieces, the first 2 in more detail, and then the rest more generally, to give an idea of what that role really looks like. So to start, assessment. This is where you would think of in a normal genetics clinic, a referral would come in, a genetic counselor might triage to see whether this is within the scope of service for that clinic. And then we have that general assessment of a personal and family history of cancer or polyps, which I'll get into, to see whether the possibility of a familial GI cancer syndrome. And that's what we're used to thinking of, about 5% of all cancers being hereditary. The construction of pedigrees, the pedigree analysis. An important role here is really confirmation of reported history with medical records. And particularly with an emphasis on pathology reports, especially when you're dealing with polyps. You want to know what type of polyps are these? Are they adenomas? Are they hyperplastic polyps? It can make quite a difference in our assessment. And there are oftentimes guidelines that dictate eligibility criteria for testing. So that can relate to funding in a lot of ways to determine who is actually eligible for further testing. A way that I like to think of when I'm doing a genetic assessment for GI cancer syndromes, is this a polyposis condition or is this a non-polyposis condition? So are you thinking multiple polyps? If we are, sort of thinking in the range from a multiple adenoma condition, so the most severe being familial adenomatous polyposis, FAP, and that's the image on the left there where the colon and rectum can just be fully lined with adenomatous polyps, hundreds to thousands. And then as we work more towards a mix of polyps, hyperplastic, serrated polyps, or hamartomas, MAP can look like FAP, but there may also be some other polyp types. Of course, I forgot to mention they're attenuated FAPs, so like the classic version, but with usually fewer than 100 adenomas in a later onset compared to FAP can happen even in childhood. And then more newly described genes, GREM1, POLI, and POLD1, often present as polyposis conditions, but they can look more like a non-polyposis as well. So there's a lot of overlap sometimes. And then hyperplastic or serrated polyps, those can be seen primarily in serrated polyposis syndrome, which right now is often more of a clinical diagnosis with criteria set by the WHO. And then think of the hamartomatous polyp syndromes. So if it's Peutz-Jeghers polyps, you think of Peutz-Jeghers syndrome. If it's juvenile polyps, which are named not because they happen in childhood, although they are more common in childhood, but they're an inflammatory or juvenile type of polyp. And then the P10 syndromes like Cowden syndrome. And then with non-polyposis conditions, the most common one is Lynch syndrome, but there are others as well. So speaking a little more about Lynch syndrome, it's what we think of as primarily we see colorectal cancer and endometrial cancers. And in fact, it accounts for 2 to 3% of all colorectal cancers and about 3 to 5% of endometrial cancers. But we also see other gastrointestinal type cancers, ovarian cancer, brain cancer for some variants of this condition, and as well as urological cancers. The average age of onset for colorectal cancers is 44 years of age and approximately 48 for endometrial cancer. So adult onset condition, but younger than average. And like most cancer syndromes, we do see autosomal dominant inheritance, and it's caused by a single mutation in one of the 5 mismatch repair genes. So MLH1, MSH2, MSH6, PMS2, or EBCAM. And there's this distinctive feature of the tumors that we see in Lynch syndrome where almost all of them show either microsatellite instability or are deficient for the proteins of those mismatch repair genes. So we say they're IHC deficient. And that is if you were to look at the tumor under the microscope and stain it with a dye for the protein products of those genes, one or more would be missing in Lynch syndrome. And when we relate that to Knudson's two-hit hypothesis, which we think of for all cancers, thinking of a particular gene. So your average person would have 2 working copies of that gene, one from their mother, one from their father. And throughout their life in a particular cell, they may have an acquired mutation. So damage happens to our cells all the time. And if it knocks out the functioning of one gene, you still have that backup gene. As time goes on, if a second copy of that gene gets knocked out in a particular cell, then it's predisposed to cancer and it may then start growing out of control into a tumor. Thinking of that as sporadic cancer. When it comes to hereditary cancer, we know somebody's typically born with a gene mutation in all cells of their body. So they're already starting one step into that process. So with time, it only takes a second hit, acquired mutation for a cell, for then that cell to be at risk of developing into a tumor. So for example, hereditary cancer, Lynch syndrome, it would be the mismatch repair genes and that mismatch repair pathway where without the functioning gene, the mismatches are not getting repaired and that cell can grow out of control into a tumor. So when we think of that as it relates to IHC, MSI, these features that we find in tumors, we can actually see Knudson's two-hit hypothesis in real life. So essentially a combination of somatic or tumor testing in this case, and germline, usually done on blood, can help to determine the cause of the IHC deficiency and distinguish a sporadic from a hereditary cancer. So I mentioned that Lynch syndrome tumors typically have this property, but actually about 15–16% of all colorectal cancers would also show IHC deficiency, whereas only 2–3% are Lynch syndrome. So what it might look like if we take this subset, this 15% of all the colorectal tumors, and focus down to try and see what's going on with the MSI or the IHC deficiency, this is where genetic testing comes in. So initially we think of germline testing for somebody who has a IHC deficient tumor. For someone with a hereditary cancer, we would expect their germline, their blood test to show one causative mutation. So that mutation we would expect to be in all their cells in one of those particular mismatch repair genes. For that same person, if we looked at their tumor and did genetic testing, we would actually expect to see 2 mutations, that same mutation from their blood test, as well as an additional acquired mutation. So just like Knudson's 2-hit hypothesis explained it. Sometimes this testing can still be uninformative, but more and more we're actually able to delineate the cause for those the rest of that, if the 2–3% were hereditary, we can actually find a lot of those sporadic ones at the genetic testing level. So for somebody with sporadic cancer, in this case, we would expect their germline blood test to show no mutations, but if we were to do that genetic testing on their tumor, we would expect 2 causative mutations in those cells, which were actually both acquired. And so that's a way that we can find the cause of that particular tumor and determine, okay, the person with hereditary cancer, it fits, we would expect them to have that higher risk for further cancers potentially down the road, whereas the person with sporadic cancer wouldn't necessarily be as at high risk for a second cancer, and different risks for relatives as well. Now on to the next piece for diagnosis. So this is, as we were talking, it can be germline and somatic testing, but also tumor testing like the IHC analysis and MSI, methylation, so different methods where a genetic counselor might be involved. Really helping to get patients a diagnosis, and sometimes it is a genetic diagnosis, but at times it may still be a clinical diagnosis. Where they meet criteria, but we haven't determined a mutation responsible. So it may end up where somebody's sort of deemed as a high risk, likely to have familial cancer, something like that, but the diagnosis remains unknown. So in the context of a research and clinical combined registry, this model that I'm talking about, we might recontact, a genetic counselor might be involved in recontacting somebody over time as new testing comes available. So for years, somebody may have that suspected to have a familial syndrome of some type, and we can actually find an answer as time goes on. And we can see how finding a diagnosis can help lead to personalized medicine. So personalized medicine, often defined as the characterization of individuals' phenotypes and genotypes for tailoring the right therapeutic strategy for the right person at the right time, and or determining a predisposition to disease, like in this case, and or to deliver timely and targeted prevention. So I wanted to give an example of personalized medicine in action when it comes to treatment in cancer. So, the general idea is you're doing analysis on a tumor unique to that patient and then targeting the therapy to that tumor. Now, what it can look like when we talk about the mismatch repair mechanism, where this is something we all have, and it recognizes and fixes errors that happen when DNA copies itself. It's just one pathway to cancer, but as I said, about 15–16% of tumors may follow this pathway. If there's a problem with that mismatch repair mechanism, it can be inherited like Lynch syndrome, it can be sporadic. As there's that problem, we see errors accumulate in cells, and this actually leads to a type of tumor that we call hypermutant. So there are a lot more mutations than the average tumor. And this study actually found about 16% of colorectal cancers showed a hypermutant phenotype. And when we know that this type of a tumor that has so many mutations in it looks foreign to the immune system. And therefore, it's actually been found to be have a positive clinical benefit from immune checkpoint therapy, or what we think of as immunotherapy. So tumors that are either Lynch syndrome or not Lynch syndrome may actually really benefit from immunotherapy. So a way of using personalized medicine from a genetic diagnosis. Now going on to the next piece of the puzzle here, recommendations. So genetic counselors are involved in this, and really the goal is prevention and early detection for cancers and polyps. And this is a lot more straightforward if there is a genetic or clinical diagnosis, because there are often guidelines that are published or even coming from the clinic itself based on screening, things like colonoscopy, endoscopy, other imaging, or prophylactic surgery. For example, a total abdominal hysterectomy with bilateral self-angle oophorectomy for Lynch syndrome in women after they've completed childbearing or an older age, targeting certain medications, particularly prevention. And there can also be based on family history if we don't have a diagnosis. So if someone family looks high risk, all the testing has been informative. Or if testing wasn't done, sometimes people decide not to have genetic testing. And then we may still offer recommendations. And these are typically written and provided to them and their healthcare providers in writing. And so genetic counselors, as you know, have a lot of role in writing, letter writing, but then bringing us to the next piece of referrals. So not every registry like this may offer this service, but what it would look like is initially after a diagnosis or an assessment, we may provide referrals. So colonoscopy referrals, other scopes, consultations with surgeons, that kind of a thing. And then the clinic itself would be obtaining copies of those results, review and enter those results. And then after that, it may come to a physician who may actually decide to adjust recommendations. And then we may send out further referrals or reminders that someone is due for follow-up screening. So in some, as I said, not all clinics would do this, but you get into that loop of a referral, obtain the reports, review them, enter, adjust recommendations, and then down the road, a year, 2 year, 3 year, 5 years later, re-refer. So that's a surveillance program. It's quite labor intensive and requires a lot of infrastructure, but it can be very helpful to patients and to really see that they are being managed appropriately, especially these high-risk patients. May not always be feasible and may fall to their family physician or others to arrange, but if it can be offered through a registry, it's very valuable. And that bringing us to the next point of data. So in order to manage all of this data, it's key to have a customized genetic software program and really data entry of pedigrees, very detailed entry, including demographic information, medical, pathology information, all of that is quite key. For quality research, you want long-term data that's detailed, accurate, and complete. And most helpful for both research and clinical is that you want to confirm as many as you can, at least, of the reported cancers and polyps, and you want to confirm them with surgery reports and pathology. So if you can delineate down, each polyp type that somebody had over the years, it's very helpful, as you can imagine, if you want to do a study, but even if you want to properly assess for some of these conditions, because the tally is cumulative with polyps when we're assessing these conditions. And when you're entering this data, you also would like to indicate whether this is confirmed, and if so, how. Is this just a reported history? Is this something where we had a medical note, or do we even have the pathology? And if you have entered all of this data, including clinical or demographic information for relatives, then in theory, if a family member from a family that's already been seen, one of their relatives is referred, then this type of genetic system would be able to flag that has this family already been seen, and in which case maybe we can save some time if other relatives give their permission to release information. Now, this is a lot of work, and in order to not get overrun with all of the reports and referrals and everything, it's really important to have knowledgeable support staff and really work in a multidisciplinary team. It's not just genetic counselors, it's everybody involved. And now support. In this case, I'm talking about support for patients. So something like a peer support system where people can find it quite helpful to speak to somebody going through, when they're going through potentially a new diagnosis, considering a surgery, where speaking to somebody who's been through it before can be really valuable. And that's, beyond what we as genetic counselors can support them, but we can help to connect them with other patients we've seen. Inviting patients to speak about their experience at meetings or at doing a share your story type of feature, connecting them to a support group where they can get greater support. And for some, it will even involve referrals for more significant support, like psychiatric support or a social worker if they're having difficulties dealing with their diagnosis. And now the information piece of the puzzle. So certainly we would think to write a letter explaining the diagnosis and all the recommendations for the patient. We may also have write a letter that the patient could share with their relatives to help explain this diagnosis and what it means for them. We may provide educational resources, for example, this FAP and me book, which the National Society of Genetic Counselors has put out for free. It's very useful in counseling children about FAP at the time of their testing, since it's often done around age 10 to 12, so targeted for younger kids to understand. And then these are other examples from the 2 clinics where I worked, educational resources that they developed internally. They also will often send out newsletters, so the latest information, research, updates, news, and often may host information nights for families. And all of this is usually maintained on a website. So much information that can be provided through these registries. And that brings us to the research part of all of this. So where, as I've described, the database, the registry itself is so important. And the types of research that can be done, it can be done within the service, collaborative research, international, a way of finding potential participants for clinical trials. And it can also maintain a biobank. So if you have this landmine of data that internally you could say, of all of our patients, how many have decided to have testing, how many have declined, sort of more of a genetic counseling type of study. You can also think about the pathology of polyps. We can see, what cancers have developed in these patients. You can really use this data, and if it's combined collaboratively with other services and internationally, just how powerful that is. And really that is benefiting patients because then we know so much more as over time. And education. So in addition to patient education, opportunities for training and supervision of genetic counseling students and other trainees is a big part of it. The affiliation within a university, so genetic counselors are often involved in teaching and having that role there. Lectures for other departments in the hospital, so endoscopy nurses and community groups and other students, high school, university, things like that, that genetic counselors can have a key role. And that was, of course, on top of patient education. And then families are really at the core of the registry model. So we're not just thinking about the patient, we're thinking about them in the context of their family. And we also want to recruit their relatives. And it can be recruitment to a surveillance program if that is offered, or it can be a recruitment for testing. So in some models, they may directly contact relatives, and some they leave it up to the program to contact their relatives and may help guide them in that process. But sometimes a letter might be sent saying something like, a member of your family has been identified to have a colorectal cancer syndrome, GI cancer syndrome, and you may be at increased risk. So something that's respecting the privacy of the program, your patient initially, but also respecting that, if that relative would like more information, they can come to you, but they may also choose not to know. And that's certainly within their rights. So really, we're following these families long-term. We're seeing multiple relatives. We're often seeing children as they come to testing age, and we may send a reminder to come back to us. So some key points, the main difference here from a typical genetics clinic is that long-term relationship where we enroll patients and follow whole families over time. And there is that keeping up of contact. And as new developments in genetics come out, families that were previously sort of uninformative may find a diagnosis. And at new treatments, new clinical trials, new information comes out, they're involved in research studies and giving back to others in the form of peer support. So certainly this is a set scope of service, but it's just applicable beyond gastrointestinal cancers and polyps. So you can easily see this as a breast cancer registry as well. All the pieces of this are not mandatory, and they're often not possible, particularly the labor-intensive surveillance program. But this is all the ways that genetic counselors can be involved. And certainly this model is best in a public or government-funded healthcare system versus private because of that public health promotion. And some of what we do is labor-intensive. Thank you.
Excellent. Thank you, Laura. Over to Ms. Sonali.
Laura, thank you so much for that session. It was fantastic. Especially to understand what you are doing in terms of making genetic counseling and genetic testing really relevant to treating GI cancers. But I love the structure. I love the way you put it all together to talk about the structure and the protocols that you need to use to try and make genetic counseling really relevant. So thank you so much for that. I didn't get to thank Dr. Tumuluk as well, but she had a fantastic session on newborn screening as well. So thank you, both of you. Thanks a lot. Over to you, Ariba.
Thank you so much, Ms. Sonali. All the speakers had really touched upon every aspect of life, starting from preconception, prenatal, newborn screening, and until late onset adult conditions, etc. So it was really delightful watching such insightful lectures from all of them. May I now request all the panelists to come on video. Finally, we can just see each other's faces and talk. May I request all the panelists to come on video? And I would request Dr. Thangaraj's remarks, if any, if we have missed, because due to lack of time, we had to go on with the lectures one after the other. So over to you, please.
Yeah, nothing specific. Let's go on with the panel discussion. Then if as and when something comes, then I can always tell.
All right. Thank you so much. And now we move on to the much awaited panel discussion. There are a lot of questions coming on. The first question I would like to put across is to, yes, now I can see Brianna. Brianna, it was wonderful wonderful lecture with your slides. The question we have for you is that Singapore is multicultural. Probably a lot of nuclear families are there. So how far do you reach cascade testing, and how challenging it is when you deal with conditions like DND or HPOC, where you many a times you have to come across, you have to deal with one side of the pedigree, HPOC, one side of the pedigree. So what are the challenges in cascading in a city like Singapore?
So thank you for the question. I think that being a small country, it's easy to pick up the people who are at risk. I think the benefit of the current generation is that their families are relatively small. And also we now live in a very a world without borders, I would say. So even patients who have family all over the world, I found that having conferences such as this, you get to know that there are counselors in the UAE, in the UK, all over the world, and now I know who I can call. And so that's one of the things that these platforms are really useful for. But to answer the question about testing the rest of the family, we have a national thalassemia registry, and I've found that sort of model very much like what Laura was talking about, where there is sustained contact with the patient. That really helps because ultimately we don't really convince patients to do a certain thing. Patients will do what they need to do or what they want to do. But if they know that there is a reliable place that they can come to, if they know that there's a safe place that they can come to, then even if they want to come back 10 years, 15 years, 20 years later, we've had that with the registry, and they do come back and get that information at the right time when it's right for them.
To just add to, if you come across a woman who carries a mutation in the DMD gene, and how far can you cascade with her siblings? All those would be separate individual families settled elsewhere, not with the primary family.
Mm-hmm. So I think it depends on how big the family is and whether they want to be contacted or not. I think, like Laura was mentioning earlier, the important thing for genetic counselors to do is really to be very respectful of what the family wants, what the person who holds the result also wants. Sometimes they may not be so willing to share. And we have got to respect that and trust that they will get information when they need it in some form or another.
Right, thank you. And the next question is to Dr. Thangaraj. Sir, there are a lot of consanguineous marriages in India. So could you tell us about endogamy practices here and your insights on population screening recommendations in a country like India? Say, may I request you to unmute yourself?
Yeah, sorry. As all of you are aware, the consanguinity is very, very high amongst the southern Indian populations. But if you take the endogamy, that's a marrying within the population, is across the country, right? It's a little broader consanguineous marriage, so marrying within the community. That also has almost equal effect as the consanguinity, because it's like extended family, right? So one of our study which we published a few years back in Nature Genetics, by looking at 1 million genetic variants, then we predicted that at least 1/3 of the Indian populations are expected to have a population-specific recessive disease. Because what happens in the consanguinity or endogamy is they increase the frequency of recessive mutations. So that's not only true for India, but also true for other South Asian countries. Because in another study, in fact, we have shown that India is mother for the rest of the South Asia, because the disease pattern or genetic history is almost same in other South Asian countries. So we have to keep eye on that, look for a recessive mutation and its frequency in a large number of populations. We, in fact, supported that evidence by looking at some of the diseases, particularly progressive pseudorheumatoid dysplasia, where in a southern region, we identify some 30 patients, the parents of them who claim that they are unrelated. But when we looked at the flanking region of the mutations and found that 6 out of 5 patients who had a founder mutations are having the same haplotype, suggesting that they all come from a common founder. Although today they are unrelated, but several generations back, they are related. suggesting that that kind of the endogamy practice is very, very high among not only in South India, but also throughout India and throughout South Asia.
Exactly, sir. Like in many autosomal recessive conditions like SMA, we see they're not related, but they have, they're being carriers. So from the same community. So that shows us. May I now request Ariba, do you have some questions gathered?
Yes, hi. I have a question for Kerry from Vishaka, Mali. What is your view about mitochondrial variants and prenatal testing, and how would you go about counseling in such cases?
We'd offer a mitochondrial panel on a CVS test, but yes, liaising with the laboratory to try and get more information if we need it, etc. So yeah. And
would the counseling be any different for mitochondrial conditions in prenatal counseling? Would it be any different?
Yes, we were explaining mitochondrial inheritance. If we found something, then we're explaining mitochondrial inheritance and so the usual pathway for maternal inheritance.
Right. Okay. Thank you so much.
Can I add to that?
Yes, of course, Dr. Thangraj, you can add.
Yeah. So what Carrie referring is Rob Taylor and this group in Newcastle.
Yeah. I liaise with him, and yes, I haven't met him personally, but yes, we liaise with him and his team. And
he's a good friend of us, and we have some collaboration. So if you talk about mitochondrial disorders, it's very complex. Okay. First thing, to diagnose the mitochondrial disorder itself is very, very complex. And there are large number of mitochondrial disorders. If you take only the neuromuscular, and again, there are several mitochondrial disorders, the symptoms are very, very high. For example, one disease, if you take MELAS, it says mitochondrial encephalopathy, lactic acidosis, stroke-like episode. Okay. Similarly, RRF, so it has again its own several set of symptoms. It has additional complexity where there are large number of nuclear genes are involved, particularly the polymerase gamma, which is the enzyme which replicates the mitochondrial DNA, has very potential cause for large number of mitochondrial disorders. So single mutation in the polymerase gamma can introduce multiple mitochondrial DNA deletion, which we cannot detect in the blood. You need the tissue, and the tissue of organ which is affected, or you take quadricep muscle and diagnose, right? So that's another complexity. Similarly, there are large number of novel nuclear genes which involved in mitochondrial DNA replications and mitochondrial complexity, nucleotide supply for mitochondrial DNA synthesis, and many more. Okay, so that has a huge area. Not only one symptom, several symptoms. The polymerase gamma, which I showed, can also lead to premature death, we have shown, and premature aging, and many more. Right? And it's very difficult to diagnose with the blood. You need the tissue for diagnosis of large number of mitochondrial disease.
Right.
I mean, often we also look at the heteroplasmy, the heteroplasmy levels, and if they're high, then you're thinking that that child will be affected, that fetus will be affected. So yes, they're concentrating on those particular heteroplasmy levels. Sometimes we also send, where it's more diagnostic, if we're trying to find the mutation, another non-prenatal, we send urine samples, and so yes, it's not only blood testing, we're testing other samples as well.
Yeah, another complexity is, there are many more complexity, because you are talking about heteroplasmy. The level of heteroplasmy, sometimes you can detect more than 10%. If they're less than 10%, it's very difficult to detect. You need to have very deep sequencing, maybe 1,000-fold, right? Then only you can able to identify the heteroplasmy. Then, because of the copy number, it's unlike the nuclear genome, whether it's heterozygous or homozygous. Here, the range of the heteroplasmy vary from the cell type to cell type.
Right.
Again, you cannot expect the Mendelian type of inheritance unless otherwise it is associated with the nuclear genes. So very, very complex.
Very challenging, but I hope with the advances and counseling and things, you can definitely help some families, going through this. Brianna, would you like to add something? I can see you replied to the question in the chat box with your comments. So would you like to highlight them as well?
Oh, yes. So Dr. Thangaraj and Kerry have already addressed the issue of heteroplasmy, and there is a lot of difficulty with that counseling as well.
All right. Okay. Thank you. I have a question for Ms. Sonali. One of the challenges that we face with genetic conditions and genetic testing is the cost factor with testing and treatment. And we are still, a long way from sort of getting any insurance coverage and things for that. So could you give us some insights on insurance advocacy for these things, please?
And this is a very tricky question, Ariba. As you know, in India, unfortunately, insurance cover is very low. We have less than, I think 17% of India actually does individual insurance. So most of the cost borne for genetic testing tends to be out of pocket. So that becomes very expensive for a lot of people to try and do something about. For many patients, you could still convince them to try and do somatic genetic testing, but when it comes to germline, it becomes extremely hard. And if now you don't have insurance cover, then that's difficult. I mean, to be honest, insurance cover for cancer treatment itself, that is specific cancer treatment related insurance, is also very new in India. They just started introducing it around 2015. So until then, it was called the critical medical insurance cover. So it was much more broad based. But yes, we do need a lot more insurance cover. We tend to be a lot more traditional in the way in which we approach it. We expect patients to be admitted for cancer treatment. So whether it's surgical, medical, or radiation cancer treatment, that's what we talk about. When it comes to genetic testing, it's very difficult. If we are able to convince insurance companies that the genetic testing was done as part of the treatment, then sometimes you can get cover, but otherwise it becomes extremely hard. So we do need a lot more advocacy in India. Very honestly, in the work that we do at cancer clinics, we actually run daycare cancer treatment centers. So sometimes I find it hard to even get insurance cover for daycare chemotherapy procedures. So, that becomes tricky. So we've got to include that as part of a traditional treatment, and that's how we work with the insurance companies. So there's a lot more work to be done. It's also a bit tricky because you've got the GINA Act now, the Genetic Non-Disclosure Act. It's strange. You have to provide the insurance companies with information that you have, but you don't want them to use that against you when the insurance cover has to be paid out. So we're still treading a very tricky path when it comes to insurance cover in cancer care especially, and also in genetic testing. So we're doing a lot of work. We are talking to insurance companies and things are changing. We're hoping to see a lot more changes in the next 5 years, but we need a lot more groups like ours putting more pressure on insurance companies to include other elements into traditional treatment now.
Thank you, Ms. Sonali.
Go ahead.
Yes, I mean, right said, passionate people like you, we can make it possible, hopefully in the near future, to get it covered.
We need a lot more people like us, Suraj. The voice has to be much louder, because it becomes very hard, because out-of-pocket expense, it starts hurting the patient as they go through things step by step, and every little adds up. So yes, I think when you are a state covered system, I mean, the NHS does fantastic work there with patients, but if you are an out-of-pocket medical country, then yeah, it's very hard.
So just to add to that, Suraj, a bit, sorry. So how do you think, Ms. Sonali, can genetic counselors help and be a part of such initiatives? How do you think we can be involved?
I think it's quite straightforward in one way, Ariba. You play a fantastic and very important role in talking. Look, what does insurance want? Insurance is very straightforward. If you can solve a problem proactively or with the least amount of cost, then that's what you want. If you can highlight and signpost that something could be a possible condition coming up in the future, then it is in the insurance company's interest to try and take that on board. I mean, the NHS, I know, works very hard on trying to get preventive testing done, because if you don't do preventive checkups, then you can't turn up with a disease, say at stage 4, and say, hey, listen, now pay for the treatment. That becomes much harder. So we've got to start getting more prophylactic testing involved. And I think genetic counselors play a key role in talking about what could happen and the possibilities of what can happen. And if that can start getting included is part of the overall treatment recommendation, then I think it's only common sense for insurance companies to start taking that on board. But you know, behaviors take time to change, so you've got to chip away at that slowly but steadily.
Thank you for that answer.
So now I have a question to Dr. Mann from Manila. I heard that it's raining heavily in Manila and she's trying to get connected. Thank you, Dr. Mann, for joining us. The question I have for you is, Philippines has wonderful newborn screening program that we have got to know. Do you pick, how do you in fact deal with asymptomatic cases in newborn screening programs? How do you go about counseling a couple who, get to know that suddenly there's something wrong in the test about the baby? So how do you go about it? What is the most prevalent condition that you pick by newborn screening in the Philippines or in Manila?
Yeah, so thank you again to the group for inviting me. So the most common newborn screening disease that we pick up is G6PD deficiency. And in our case, we have very mild G6PD deficiency patients. So it can range to very mild symptoms, almost asymptomatic, as Sir Suraj has said, and not really very severe cases. So it's really hard to counsel these kinds of patients who are asymptomatic because the parents feel that their child does not show any symptoms. So they feel that they are not sick at all. So you just have to be constantly reminding them about this disease and its risk of recurrence to the future children is also important. Discussing with them the reproductive options. And, you just have to be really, you just have to be really responsible in connecting with these families so that they can put their trust in you and you can help them in whatever way that you can.
I'm sure there are hardly 14, 15 genetic councils in the whole of Philippines, and you must be on toes always, catering to families. Congratulations.
Thank you.
And the next question is to Laura. Laura, we know that you have worked in the East, you've worked in the West in Canada, you're now currently in Abu Dhabi in the Middle East. So working in different parts of the world, how do you deal with conditions like prenatal counseling? How do you deal with prenatal counseling and things where every region has a different, has different cultural things. So how do you deal with it?
Yeah, definitely the cultural views, the society views, and even the laws can vary a lot when it comes to prenatal genetic counseling. So in Toronto, we saw a really international patient base because it's a really international city. So you would get a little bit of that where the patient views would vary a lot. But what was available to the patient was, everything was available. I'm really only learning more now about the prenatal view in the UAE as I'm soon going to be transitioning to a little bit more clinical work. But some things are just not allowed in the country. For example, surrogacy isn't allowed, egg and sperm donation isn't allowed. So what we would think of as something that might be options in different areas may not be, and they may not be viewed as something that patients would even want. So it can really vary when you're coming from one part of the world going to another, to be really aware of what the views are of your patients, but also the community and the laws in place, and just a different view on the priorities. So certainly IVF and other assisted reproductive technology is quite common in the UAE, because having children is seen as very, very important, not that it's everywhere, but and that what is available, what is acceptable can vary.
So we need to be up to date. Yes.
Yeah, to be up to date, and just, I can't come in with the assumption that I know, because of, the more I know, the more I find out that I don't really know.
You always learn. Yes. So I would like to ask Ms. Kerry, in her experience, again, UK has a lot of people with cultural differences. Do you ask ethnicity for genetic counseling to have it on records, and
Yeah, I mean, whenever that's supposed to be part of when we sort of clerk a person in, or we take, the new referral. So we're always supposed to ask about ethnicity, because sometimes that also depends on the testing we're offering, because, you might say, well, obviously they're Caucasian British, they have this certain percentage carrier frequency, but other populations will have a different carrier frequency, as we all know. So yes, it's important that we do get that information and write it down on our medical record. So so it's not it's just a helpful tool in then targeting your gene testing, because we know certain even like a BRCA, some mutations are popular in Jewish population, others are in the Finnish population. So if we know what the ancestry is for that patient, we can then say to the lab, okay, well, that patient's from that ancestry, look at these other genes, or etc. And or if we've done a gene test, then that will then alter the residual carrier risk or ultimate risk of the patient being affected, because we're sort of adding in the fact that it's a different ethnicity. So the population frequency, carrier frequency might be different. So yes, we do have to factor that in, definitely, because I mean, some of our areas we've got a high Indian and Pakistani population. Other areas we've got Polish, population, and so that all changes things when it comes to the lab testing.
Thank you. The reason why I asked this question is that it's very difficult to ask someone which caste they are from here in India. So it's very challenging here. So we have got.
Suraj, we have time for. Sorry, go ahead, Kerry.
We've got a question from the chat to Dr. Kangaraj again.
No. Just to tell that
yes, sir.
UK has another problem, because there are large number of South Asians in UK. Once they done the test and identify some mutation, and when they screen, they will not find anything in the South Asian population, particularly Indians and Bangladesh. So they have to do once again the exome sequencing for most number of the diseases, which I know. Another Robert Pitchley in UCL London. One story I can say that he's also working on mitochondrial diseases. But when we looked at, there are three populations who basically traveled from Gujarat. And it's a very unique mutation which he identified after sequencing the exome. Later he contacted me and asked whether any of our samples carry that mutation, but we didn't find, because our samples are from South India. I told him, after that I asked him where they have come from. He said that they are from Gujarat. Yes, naturally, here every state is every country, like one country. So again, we have to look at very carefully that the mutation exists in Tamil Nadu, it may not be existing in Gujarat, or Andhra may not exist elsewhere. So that's another complexity.
Exactly in line with, we have had a question from the chat, one of our delegates asking if we had to implement a newborn screening program across the country, would you suggest to be done statewide or nationwide?
Yeah, if we do nationwide, of course, the state also covers that.
All right. Over to you, Arima. if you have any questions for that.
Right. So I think we can just quickly ask one question, but it's a complicated one. Either of you can take it. So as part of one of our roles is to make sure we keep in mind our patient's interest, as well as make sure that we don't create any conflicts in their family or home. So in cases where, for example, there is a risk, say on the maternal side, and we have a mutation, or either parent side, and the parent doesn't wish to do the testing to identify if they're at risk, but the child would want to, so how would you sort of deal with such a situation? Because on one side you have a right to know, and one side you have a right not to know. So would any of you like to take this up? Kerry, I can see you are.
Oh no, I was hoping you'd say Laura. Well, it depends on the condition, obviously. So some of the things we are a bit more directive, like cancer genes, we're a bit more directive, and we say, look, it's really helpful if your mother has the testing, because she's a 50% risk of being a BRCA mutation carrier. She's high risk for ovarian, high risk for breast. But we would still say, okay, you're still entitled to have your own test. But we discuss with the patient, again, more so if you think about the consideration of like Huntington's disease or adults, these other neurological conditions where there might not be any treatment. So it's very different depending on what we're looking at, what we're testing for. But with the HD, you can say with the BRCA that it will be in the woman's best interest, the mother's best interest, because she's at risk of cancers. And we also explain that if you're positive, that the daughter's positive, then it gives the mother indirect results, obviously. But as I say, with the HD, if you compare it, that can be very, very, very tricky, because if the mother doesn't want to know, she's got a right not to know. If she might be at 50% risk, but the child might be then 25 and wanting the children, might be wanting PGD or something. So it's really tricky. And we then have to really have long discussions about, well, how are you going to keep this information from your mother that you are positive? If they test positive on a predictive test for HD, it's an indirect, again, result to the mother. So it's a lot of discussion and saying, well, if you can keep the information to yourself, that person, we can't deny them a test, but we have to try and mitigate against family arguments and families falling out. And, the mother might be our patient. We might have seen her before. So we have some responsibility to her as well. But we can't just say that, well, we can't test the child. But it's very tricky. It is really difficult, and it's lengthy counselling sessions. But at the end of the day, they still have a right to be tested. But obviously, then it depends if it's a childhood onset thing or an adult onset. So again, if the mother, we've had pressure sometimes for the parents wanting testing on their children where it's inappropriate. So just depending on what the test is for, if it's adult or onset, or if there's treatment, it really depends as to what we say as genetic counsellors and how directive we are, because we would always try and encourage people, if they're cancer genes, yes, please do test, because you can have screening and there's this prevention. Whereas HD, we're more on the side of, well, at the moment, there's no cure, and this information just for your own benefit, and can you live with that result? As somebody said earlier, you live with that. It's a lifelong result. You've got to live with that. Sorry, I'm waffling.
No, it's insightful to know, what happens in different parts of the world. Laura, would you like to add to that?
I was going to say, Carrie did an excellent job answering that. Yeah, really.
Right. Dr. Ma, would you have any thoughts on that?
No, I do not have any further anything to add.
All right. Okay. So I think, yes.
If we can entertain one more question, I would like to just put it to the panel in common about, if you could share your experience with support groups in your practice. When do you actually initiate such facilitation in your hospital, or probably another institution, government or private? What are the difficulties, so your experience and insights on support groups, please? Anybody?
I'll just briefly say, sorry, I know other people can talk as well, but I used to work in Southampton. I've worked in different places, including New Zealand actually as well. But in Southampton, we used to run a clinic, a family day for BRCA carriers, BRCA mutation carriers. And that was very helpful. We had it every year. It was on a Saturday, so it was in our own time. And then the families came, we arranged an educative agenda. So you'd have the breast surgeons with updated surgery techniques, or oncology, or radiotherapy, or even cosmetics like implantation and the underwear to wear and stuff. And then we had breakout classes, and we'd be able to talk, the patients can talk to each other, and they can ask questions facilitated by genetic counselors. So I think different places. Unfortunately, we haven't got anything similar here, but I'm trying to set up a Klinefelter's for the northeast of England, because I think we need that. We've only got one Klinefelter's multidisciplinary clinic. So it's also working as multidisciplinary clinics, I think, where we get involved and we're talking and spreading the word of genetics. But I think for us, for example, in the UK, and particularly in Leeds, we're just a bit short-staffed. If we had more staff, we'd be able to do more patient involvement, patient interaction, and having support groups, I think, is a very good thing. But it's down to staff members that we short-staffed, unfortunately.
Yeah, just building on what Kerry said, I think it's actually essential to have support groups. I mean, from our perspective, we think it's mandatory, but I completely take a point. You've got to have time, and it normally is time that another practitioner is taking away from what they normally do. So that becomes difficult to try and constitute the support group. And again, in India, with especially what we've seen in cancer treatment, with the kind of stigma and social trauma sometimes that's attached to the disease, people don't want to volunteer, but it's important to have the group. It's important to give them that information and let them make their own choice. There are individuals who are quite skeptical, who actually come forward about 6 or 7 months later after the idea has been introduced. Some will jump at the idea and talk through it, but I think it's important to have it there. But it's also very difficult from an institution standpoint sometimes to even get the right funding for the support group, because we can never really understand how many people are going to join at what time, what the strength of the group's going to be, who's going to be running it. So there are practical implications and complications to running it, but I think there is no substitute to a support group. It should be there, and it should be made mandatory in all institutions.
And just to hop in as well, I think the strong suit for genetic counselors is when support meetings are, like Carrie talked about, information-led. That's where our knowledge and our expertise is. So when it is an information night on explaining the genetics of something, the treatment options, all of that more medical side of things is where we have a benefit. And sometimes support groups, when they're more patient-led, they're the experts on their experience with the condition. So sometimes it's, mothers or parents of somebody, of children with the condition, or the peer support groups that are often on Facebook. One risky thing with having a support group is if suddenly it turns a bit negative and people are criticizing their healthcare providers. It can be more tricky to run something like that. Whereas if you're leading with information, and then what people speak about privately in their own experiences can be a little bit separate. But certainly, I think they're both really valuable to patients to be able to have access to that information support and also the peer support. Yeah. And sometimes, if they're a counselor, somebody with more counseling experience can lead. And certainly, those inpatient meetings, who's the funding, the running it, how big is it? It can be quite logistically difficult, because you never know how people will feel if they want that support at that time in their life, if they will show up, that kind of a thing.
I think if we can't find, if we can't get funding for or support group, because obviously we're doing it our own time, I think a big emphasis these days now is multidisciplinary working in the UK. So it's setting up as many MDTs as you can. So multidisciplinary clinics, we've got different clinicians, like we've got your own HD. So, or now it's called Enroll HD. So Huntington's disease, we've got multidisciplinary clinic, 2 of those in our region. So you've got a psychiatrist, you've got neurologists, you've got genetics, you've got researchers, and we've got, I used to run in Nottingham, I used to run an telangiectasia group. That was an MDT as well, but it becomes like a support group as well, because the genetic counsellors is there to support and discuss, and then to pick up any problems, then you refer on to other agencies where you need to. But I think multidisciplinary work is like the way to go, because you're also educating your other clinical colleagues that aren't in genetics, but you're giving information to the family, and you get these, when you're doing MDTs, you're getting it funded, obviously by the healthcare. So it's slightly different, obviously, to a support group, but I think that's very essential for some conditions, particularly when they're very rare conditions. Like the ataxia telangiectasia was the only clinic in the UK. And I was involved for 6 years. It was really good. And it was really good for the patients because they got, one-stop clinic and very comprehensive care. And I think that's really the way to go in genetics, is to try and do as much as possible in MDTs. So genetic counselors to get out there and liaise with other, colleagues. Sorry, I'm carrying on.
No, that's fine. Unfortunately, we are out of time. So, I mean, we would love to keep going, but we have another session after this as well. So I would request Dr. Thangraj and Ms. Sonali to quickly just say a few words, and then we can close the session for the day.
Sir, after you.
Okay, thank you very much. And that was actually a pleasure for me to listen all the talk and part of the excellent discussion and contribute to this discussion as well. I hope that the organizers will continue this kind of conference, and we need a country like India, because we need more counselors. Actually, the way the number of genetic diseases have been identified, we need more and more. I hope that we'll have large number of genetic counselor, at least in every medical school, every genetics department. It is essential, and this is a way that to give some kind of induction to those kind of people who are willing to join this kind of groups. So that way it would be very, very useful for the societies. So with that, I'll thank once again to all the panelists and also the organizers. Thank you very much.
No, I'll just building on what Dr. Thangraj said. Thank you so much to all of you for spending your precious time with us. I know Sundays are very precious and you've had to take some time off from that. So thank you again. And thank you so much to Suraj and Ariba for doing a fantastic job moderating the session. Thank you so much.
Thank you so much for being here today. And like Sonali ma'am said, Sunday, and Laura, for you for getting up so early in the morning. And thank you so much. We will now, in the next few minutes, move on to our next session, contemporary tools for genetic counselors, which will be moderated by our friends and colleagues, Dr. Madhavi Latha and Ms. Shruti. So please be here and join us for the next session. Thank you.
Thank you.
Thank you, everyone.
Thank you.
Thank you. Bye.
Nirav, are we on?
Hello, everyone, and a very good morning, good afternoon, and good evening to one and all. I'm very happy to welcome all of you to the last session of the 6th International Conference by the Board of Genetic Counseling of India. And this session is Tools for a Contemporary Genetic Counselor. I'm Madhvi, a genetic counselor associated with MedGenome Labs, and I'm joining you from Trivandrum, the southern tip of my country. Coordinating this session with me is Ms. Shruti Mathur. She's joining us from Delhi. We have 5 wonderful speakers, a panel of 5 wonderful speakers here with us today from across the globe to share with us their views, opinions, and knowledge regarding the tools that a genetic counselor needs or at least should have a knowledge about. Okay? And we also have 2 eminent chairpersons to chair the session today. And it gives me great pleasure to introduce Dr. Kunal Sanghvi, joining us from Connecticut. So good morning, Dr. Kunal. It's a pleasure to have you as a chairperson for this session. Dr. Kunal is a senior program manager, genetic counseling, the Jackson Laboratory for Genomic Medicine. And he completed his training in Mumbai, India, and genetic counseling program in Boston, USA, following which he received the board certification by the American Board of Genetic Counseling. His interests are ethical, legal, and social implications, the LC that we know of, genomic workforce development, genomic health equity, virtual genetic counseling training initiatives, and somatic germline correlation. His career highlights are he's president of New England Regional Genetics Group, director of professional development, Professional Society of Genetic Counselors in Asia. He's a reviewer of a Charles Epstein Award ASHG, and he's one of the 2 GC members at the ACMG CELI committee, that is the Social, Ethical, and Legal Issues Committee. The second chairperson for the session is Dr. Rachel, and my colleague and friend Shruti will be introducing her today. And over to you, Shruti.
Thank you, Dr. Mathvi, for your kind introduction. As the world is getting technology-driven, tools for genetic counselors are the need of the time. I am going to introduce our other eminent chairperson for this session, Dr. Rachel Jesusasan. She is a distinguished scientist and has been associated with Center for Cellular and Molecular Biology, Hyderabad, from past 35 years. She is also a research advisor with Osmania University and an emeritus scientist in Inter-University Center for Genetics and Genomics, University of Kerala. She had her doctoral in cytogenetics from Banaras Hindu University and has done her postdoctoral fellowships with University of Southern California, UCLA. She had also been assistant research fellow with University of California, USA, and faculty to summer internship program of medical and pre-medical students at the Cleveland Clinic, Ohio, USA. This is going to be a very exciting session, and each session talk is going to be around 20 minutes. So over to you, Dr. Kunal, for initiating the session.
Thank you, Dr. Madhvi and Ms. Shruti for this kind introduction, and to the organizers for planning this session. It's my pleasure to introduce the faculty with my colleague and co-chair today. So our first speaker or faculty member is Ms. Nicole. She is a molecular biologist by training from Hebrew University in Jerusalem. Nicole has worked for the past 15 years in clinical research for cutting-edge medical technologies, and for the past 5 years has been leading the research studies at FDNA, which most geneticists and genetics professionals have been using these days, a company whose technology combines different forms of artificial intelligence with genotype-phenotype correlations. Nicole's focus is in next-generation phenotyping technologies, which couples the automated phenotype analysis with the continuously growing genomic knowledge. The aim is to open new ways to rapidly reach an accurate molecular diagnosis for patients with genetic syndromes, and as a result, contribute to the emerging field of precision medicine. What a fantastic way to kick off this session. Over to you, Ms. Nicole.
Hello, everyone. Thank you very much for the organizers for having invited me. It's a real pleasure to be here with you today. We will spend the next 20 minutes talking a little bit about the applications of artificial intelligence in the evaluation of rare disorders, mostly with a tool called Face2Gene. which for the first time automatically allows us to extract the patient's phenotype to translate it into a ranked list of syndromes and then of genes that can help us for variant prioritization. We call this next generation phenotyping, a form of it. And my talk is divided basically into 4 sections. First of all, a little bit about what next generation phenotyping is, how we use it in the clinic, how we use it in the laboratory, and then a very short and quick tutorial about how to use Face2Gene. I'll be very happy to receive your questions afterwards. So what is next generation phenotyping? Already in 2012, Doctors Hannekam and Biesecker wrote this interesting piece where they were saying that next generation sequencing demands next generation phenotyping. And they argued that NGS in diagnosis will yield variants in many genes, thousands of variants. But the consequences of these variants will need to be analyzed and integrated with clinical findings in order to make a diagnosis. Without that, in some cases, we will not be able to make a diagnosis, and we will end up with just the possibility of telling parents, there are a few variants. We don't know the level of pathogenicity really well. So of course, this was at the same time that the ACMG guidelines were being developed, but it very much helps us to think what the outlook was then about almost 10 years ago. And together, in parallel with all these developments in our fields of genetics, there were many advances in computing, in machine learning. Here I just brought some, as we can see how much these deep neural networks, as they are called in computing, are helping in skin cancer conditions, in breast cancer condition, and of course with the retina of the eye. So in medicine, in the clinic, we receive all these huge number of signals and images that we can analyze. Imagine if the machine, the computers, would be able to analyze all these different types of images from which we can extract the phenotype, and quickly, within a few seconds, it would let us know what are the possible syndromes, what are the possible genes. So we are not there yet, however, advancing extremely rapidly. And I want to show you where we are now in terms of this Face2Gene platform. So again, we can see all the phenotypic data signals. We can nowadays analyze facial photos and translate it into syndromes and genes. We can analyze clinical notes. We can analyze and the genomic data in order to help us arrive to the pathogenic variant. So let's see how this works. And we call this technology deep gestalt. You can see here the pipeline where typically the face within a photo will be recognized. Different points in that photo will be found. The distances between those points and the ratios between those distances will all be then converted into a vector, a numerical description. This is why the patient's privacy is very much observed, because this from this vector, I cannot go back and reconstruct that particular face. And it is this vector that we compare to all other syndromes and genes in the database. So again, the photo is very much separated from the vector extracted, which is then the one that's being compared. In order to help us in the clinic, we convert an average of those vectors into masks or into composite images that just can help us in the clinic, and we'll show that in 2 minutes why and how. Let me just go into a little bit more detail in this area. Here, And we can see what happens in that process. So we saw the different points in the face. Then what happens is the cropping of that face is cropped into many, many different areas. And each one of these croppings is compared to the relevant cropping of all the syndromes in the database, yielding at the end of the day a lot of probabilistic vectors or probabilities. And when we aggregate all these probabilities, we end up with a ranked list of syndromes. And it is this that you will be able to see when using this kind of platform. Now, this was all published in Nature Medicine. You're very welcome to look it up, and you will have there a lot more detail than I can go in nowadays. So let's see how we use this basically in the clinic. And in the clinic, typically a clinician will take a photo, will write some phenotypic analysis or some clinical traits that she found in the clinic. And then the clinician will receive a list of possible syndromes. Each one of them will have a meter telling her whether it was how likely it is similar to the gestalt, meaning the photo, and how similar the patient is to this syndrome based on the features that have been entered. And I will then be able to quickly review these syndromes and go into those that can be relevant for me. And I will see here that mask, you remember that we saw a few minutes ago, which will help me compare how similar or which are the areas in the face that are very similar to my patients. I will also have access to the London medical databases and learn more about that specific syndrome, and also find the typical features of that syndrome, so that can help me what else to check in my patient. So again, the outcome here is a list of possible syndromes, and they are ranked. So it is very important not to look only at the first one, because it's not a diagnostic tool, but rather a probabilistic list that can help me in the clinic. I can then send this to the laboratory. If I am going to be doing an exome or a whole genome analysis, I can send this directly to the laboratory. If the patient does not give me the possibility or the permission, the consent to send the photo, then I can also send just the phenotypic information, because what the laboratory will receive is already the translation of the extracted phenotype into possible genes, which can help in the lab very much to shortlist the number of genes and variants being observed and computed. So how will the laboratory actually use it? Typically, they will use it for variant prioritization. And again, here we see the idea in a graphic way, where the photo, okay, it's being converted into a vector and then translated into list of genes. Each one of the genes that come out will have a certain probabilistic Gestalt score, and this will be joined for the feature score, so that the laboratory or the clinician, whoever is doing the variant analysis, can then see to which one of these to give a little bit more weight than the other. At the end of the day, and this is courtesy of Perkin-Elmer Laboratories, which is the first laboratory in India to offer the phenotype-based variant analysis. So this is a typical, they call this a VCF viewer, or a typical table in which they will have the genes and the rating and a lot of different parameters by which they filter them, and the two additional parameters that come directly extracted from the phenotype. So what is this based on? So there have been a lot of different publications. I invite you all to view them. and some of them are more about what happens in the laboratory, some are more about what happens in the clinic. So very quickly, I want just to go a little bit deeper into this one. What they did, this is a team from Europe, the group here is from Germany, and they asked for the participation of 32 different centers all around Europe. And what they did is they combined the traits together with the photo of the patient, together with, and they received also what was the disease-causing mutation. So these are solved cases, about 679 in number. And for each one of them, what they did is they used these different type of scores that AI gives, not only from Face2Gene, they also used a tool called Phenomizer. And they combined these three, they combined the traits with the photo with the CAD score. And CAD score is one of these parameters we just saw in the VCF analyzer, which is simply a score that gives us the level of pathogenicity of the different variants. And when combining all of this together, they were able to see that they could arrive to a much higher and better interpretation. So let's see how this worked. Let's look at just the top 10 accuracy, meaning the top 10 genes that they received. So using only the CAD score, meaning only the information that comes from the molecular analysis, they arrived to a 41% diagnostic yield, meaning 41% 41 out of 100 cases, they were able to arrive to the correct diagnosis based only on this molecular score. When they added the feature scores, meaning the clinical traits, they arrived to an 83% correct diagnosis. And when they added, which is, by the way, this is more or less what happens in most laboratories nowadays, because we always, when we fill out the paperwork for the laboratory, we add some clinical traits. And using the scores that came from the facial analysis, they arrived to a 98%, which is very, very high for our world of biology. Now, this was a very encouraging result. Of course, there are limitations, like in every study that has been done. Mostly that these were all cases where there was some type of dysmorphism in the face. This was only monogenic disorders of Mendelian inheritance, and it was not representative of all ethnicities. But since I'm happy to say that there have been many, many more research studies and papers that have come out in different parts of the world. And today I only have here 3 that recently appeared in Indian population. So these 2 appeared in 2019 and 2020 in Indian pediatrics. And this one in the American Journal of Medical Genetics appeared, I think, in 2020 as well. So yes, it's being used in India, and yes, it does work with Indian phenotypes. And the more this type of platforms is being used, the better it gets. The better it can analyze and recognize Indian phenotypes. So just to finish, how do we set this up? You're all welcome to go to face2gene.com and register. This application is only for healthcare personnel. We do not want this in the hands of parents because it will only be a reason for hysteria. Again, this is not a diagnostic tool. It gives lists for a clinical eye to be able to go through it. So first of all, you're also invited to use it in your phones. Just register quickly. It will take a day or 2 for this registration to be vetted, please write your real profession and it will work out. Then your first task will be to add a new photo, a new case. You can do that by accessing your gallery or taking a photo directly from Face2Gene, which is of course very much recommended for privacy issues, so that in case your phone is stolen, nobody can access those photos taken, whereas in the gallery, they are all accessible. So you take a photo. If you like the photo you've taken, you click on done. Then you can add some names if you want. Again, this is all data that is private and only viewable to you. Many teams in Europe work as a team, meaning that, for instance, a genetic counselor will be taking the photo, adding the traits in, and this is shared with the MD clinical and sometimes also with the laboratory assistant. So if you want to set a team, just contact me, and this is all possible to do. You will then receive a list of possible syndromes just based on the photo. Okay, you can click on it. Now, no matter what, it will always suggest 30 syndromes. Again, this is a computational tool, an artificial intelligence tool. Even if you upload your own photo, it will still suggest 30 possible syndromes, probably with a lower Gestalt score, with a lower score, but still it will suggest 30 syndromes. Once you have done that, you may want to click on features in order to add these features, okay? It will have also some suggested features. You can then use the search in order to add more features. You can add measurements, okay? And you will be able, by clicking this icon here, to see the growth charts. These are growth charts that are from the World Health Organization. They are for unaffected children, normal children. And then you will be able to review your photo again and add a heat map. How do you add a heat map? The heat map will tell you the level of correlation between your photo and what has been, and the syndrome that you're studying. In this case, telling me that the ocular area and maybe around the mouth is very similar to mucopolysaccharidosis. However, the malar area here, the chin, not as much. You can move and toggle with this bar in order to get a better comparison. You can then also look at the typical features, which can very much help us in the clinic to see what else do we need to check in that patient. You can also compare to published photos. Compare your patient to publicly available photos. These are photos that have appeared in peer-reviewed publications, and compare them side by side. Look at the structure of the eye, for instance, if it's up slanted or down slanted, just as an example. And you can learn more about the syndrome accessing the London medical databases. You can then, whenever you are done with this review, there will be a diagnosis, probably maybe more than one differential diagnosis. You can mark it and then send this to the laboratory. You can here choose what you want to send to the laboratory. If patient has not consented for the photo, then you can send, for instance, the pedigree. You can add here the test request form. And then when you receive your results back, you can molecularly diagnose it and mark it, or clinically diagnose if it's not the case of a molecular analysis. This is a very important step, because only now when you do that, we will be able to learn from your experience in India and improve the algorithm. So with much further ado, I hope that this was interesting for you, and I'm glad to receive your questions. Many, many thanks.
Thank you for this excellent talk. Dr. Rachel, can you introduce the next speaker, please? We will take the questions at the later part.
Yeah, it's my pleasure to introduce the next speaker, that is Megan B. Farmer. She is a genetic clinical operation director at My Gene Council. She has an MBA from Healthcare Management and Information Systems Management from University of Alabama at Birmingham, MS in Genetic Counseling from University of North Carolina at Greensboro. Her interests are genetic counseling, precision genetics, and digital health. She is a licensed and certified genetic counselor, former director of cancer genetic and counseling at the University of Alabama at Birmingham, former National Comprehensive Cancer Network panel member. Yeah. Megan, we'll be happy to listen to you regarding tools for a comprehensive genetic tools, contemporary genetic tools. Yeah.
Great. Thank you for that intro. And it's really great to be here with you all. These are really important discussions that we're having, and I'm honored just to be one of the guests. So I'll be talking about some online genetic counseling reports called living lab reports. And that's why the title of this lecture is really Precision Medicine in Practice. Many people talk about sort of end-to-end solutions to genetic testing, and they suppose that the genetic test result is the end of that journey, when for many patients, the genetic test result is the beginning of that journey. So we need to think about ways to use technology to make sure that we can support patients and clinicians over a lifetime once genetic testing is done. And I just want to share a little bit about the genetic testing landscape that the founders of My Gene Council were considering, that some of the challenges as they developed these living lab reports. And while some of these numbers are based in the US, I think it'll show trends and challenges that we're really sort of experiencing on a global level, and in some places are more challenging than others. So here there are around 5,000 certified genetic counselors, but many of those don't see patients. They may work in industry. And of those that work in clinics, they may subspecialize. So they're not necessarily going to see all types of patients. And so suddenly that funnel gets smaller and smaller in terms of actual numbers of genetic specialists that could be potentially connected with patients and could support other types of clinicians. And we've got, 75,000 plus genetic tests on the market. That was in 2018. Obviously, that number is even higher now. And by some estimates, there are 10 new genetic tests introduced each day, which is just kind of staggering. And we've also seen shifts in terms of how people are accessing genetic information. So at one point, it was only in very specialized clinics. And then it started to kind of permeate all areas of medicine, where it isn't just genetic specialists that are ordering genetic testing. And then consumers could order direct-to-consumer genetic testing. And now we're seeing a shift where there's consumer-initiated medical grade testing that maybe gets signed off remotely by a physician. And all of this to say is it's just this swell of genetic information that's just outpacing the number of specialists we have to interpret that and help people understand what to do with it in the short term and certainly over a lifetime. And it was these sorts of difficulties that the founders of My Gene Council were trying to address when developing the living lab reports. So when you think about what could happen to patients if there aren't enough genetic specialists to interpret test results, one, someone may just not order testing at all. They may say, we just need to wait and let genetics do that. But as we've discussed here, and as I'm sure all of you know, there's just not enough genetic specialists for that. And so in some cases, genetic testing doesn't get done at all. In other cases, there can be long wait times, which can have significant health impacts. And then sometimes genetic testing is done, but without genetics expertise, maybe clinicians don't have the support they need, and they may order the incorrect test. They may order the right test, but interpret it incorrectly. Or someone could have wrong medical management based on just the person not having access to the right guidelines. And my group's actually published a series of papers on what happens when there are errors like these, sort of this types of mistakes that are made, the impacts on patients, and also just the costs that can come from that. And even if someone has the best genetic test and they even have genetic counseling, we learn so much so quickly that can quickly become outdated. And so as our knowledge grows, those patients can also be left further behind, where they may not be benefiting from everything, all the advances in the field. And this can also really be hard on physicians. So physicians are very busy. There are not enough of them either. And they're trying to cram in something complicated like genetics into an already busy clinic, where the consent process is different, where the labs that they might be ordering from may be different. And they don't really have the point of care support they need to interpret results and to make sure that the patient's getting the right information from them. Sure, there are guidelines and articles they can turn to, but that's a lot of information to synthesize when it's not the thing that you do every day and when you already are being pulled in so many different directions. That's a pretty big burden. And so some may say that they just need to refer to genetics to handle that. But again, that's going to create significant wait times, which is stressful for the patient, but also can be stressful for the physician that's trying to manage them and take care of them. So my Gene Council developed these online genetic counseling reports called living lab reports. And just from customer need, we realized we also could use some help on the front end with pre-test information so that we could help with informed consent. And these genetic counseling reports are taking test results. So we're not actually taking raw data or interpreting genetic information. We're taking interpreted test results and then matching that with an online genetic counseling report that you can think of as kind of the most important topics to cover with a patient, all the things that you wish you could say in clinic, but you'd never have time. But you can kind of break it down by topic so patients can learn more as they're ready. And then we also have separate genetic counseling reports for clinicians so that they have all the information they need in one place and can reference that as they manage a patient. And then most importantly, these online genetic counseling reports get updated over time. So if something really important changes, the patient and the clinician would be notified so that they continue to benefit from the genetic information. And a little bit more information about the platform itself. It is online, but it's mobile friendly. So we're seeing people access this on phone, iPad, other tablets, desktops. It looks good on all of them. It is secure. And we hope that these living lab reports can be used anywhere where genetic testing information is being used. The reports are easy to understand because they're written by genetic counselors or other experts in whatever area of that genetic condition. They're really robust, so there's much more information than I could ever hope to cover with a patient in one session. But again, it's there when they need it as their needs change, not just by age, but as life circumstances change. As I mentioned, there's pre-test information to help people understand the testing that they're going to have. And there's also post-test information, whether someone tests positive, negative, or has a variant of uncertain significance. And this is important because oftentimes people say, well, could I just use these living lab reports for patients who test positive? But we all know that sometimes it's the negatives or the variants of uncertain significance that are really a little trickier to interpret because negatives may be understood as falsely reassuring, or variants of uncertain significance sometimes get treated by non-genetic specialists as pathogenic. And again, there's tailored information for patients and for clinicians. And the real-time updates or notifications, again, the content within these living lab reports is constantly being updated, and examples of things that could change would be new clinical information, so new risk information in association with pathogenic variants, but also updated management guidelines. And I'm going to show you examples of just how often this changes, although I'm sure intuitively you all know just from your everyday practice. So I mentioned at the very beginning that right now we have this end-to-end approach, and many labs and other precision medicine companies try to create end-to-end approaches to make it easier for clinicians to feel comfortable ordering testing. But what that ends up looking like is There are tools to identify testing candidates, which is important. We've got state-of-the-art genetic testing. Of course, that matters. And then results get returned, perhaps by a physician, by a genetic counselor. That might be in person, or that might be by telehealth. Perhaps there's a result letter generated that can guide a patient and a clinician, but then it stops. And as we learn everything from risk information to management guidelines to even precision therapy options, the patient may never benefit from that because they may never speak with a genetic specialist again. And perhaps their physician is still working with that result letter that was written years ago. And I still experience this. I see patients part-time at UAB just because I wanted to stay in clinic. And I used to, call out a test result and say, please call me back every year so I can keep you up to date, knowing full well that I was never going to hear from that patient again. And I would write in my result letter to the physician, here's what we know today, but we're going to learn more. So please check in with my clinic at least, every 1 to 2 years so that we can give you the latest guidelines. And again, I would never hear from them. And the truth is, if I did actually hear back from all of those people, I couldn't handle it. So these are the problems that I was experiencing, that the co-founders of My Gene Council were experiencing. And that's what led to these online genetic counseling reports, that we actually do have a connection to the ever after. So in addition to just kind of supporting pre and post test, suddenly we've got these ongoing notifications. And it's good because it also improves patient experiences. So they can have the peace of mind of knowing they know where to turn when they have questions in the future, or when they see new physicians that may not be as familiar with their genetic condition. Some of you may have heard from patients that say, I feel like I'm more of an expert in my genetic condition sometimes than physicians do, especially if it's not the genetic specialist that I might get to see, every once in a while. I'm educating my clinicians in some cases. Well, now they've got an extra layer of support to do that. And the engagement is not just good for that patient and for that one clinician, it can also be helpful for the health system. So if a health system provides living lab reports to patients, and patients are learning about new medical interventions they may qualify for, that patient's more likely to get those interventions, which is of course good for medical care, but it's also good for downstream revenue for the health system because that patient's going to stay plugged in. Another way that you can think about this are these online genetic counseling reports. They don't replace genetic specialists. They kind of amplify their efforts or allow them to reach more people. So, if you've got this huge pool of patients that need genetic testing, rather than every single person needing a pre-test and a post-test appointment, they may be able to have genetic testing that is initiated by their physician and supported by pre and post-test online genetic counseling reports. And then perhaps those that test negative don't need to see a genetic counselor. They're a physician and they have the information they need, and they can feel good that they understood what happened. And those who have a variant of uncertain significance, some may feel like that's enough. Others may want to see a genetic counselor, and it could be optional. And only 10% on average, depending on the clinical situation, may actually test positive, have a pathogenic variant, and really benefit from that one-on-one discussion with a genetic counselor because they're dealing with a more complex situation. And so you may go from hundreds or even thousands of patients, depending on the situation and health system, to only around 10% of those that actually need to sit down one-on-one with a genetic counselor or meet with one by telehealth. So that frees up those genetic specialists to potentially reach more people. And just to give you an idea of how often medical management changes, we actually published this it was an abstract with ACMG last year, but we looked at, we used the ACMG 59 just as our list of genes, which as you all know is around 25 cancer genes, 30 cardiogenetics genes, and 4 other ones. And we looked at the guidelines from 2014 to 2019, and we actually counted how many times something updated that could potentially change a patient's medical management, something that if you were a patient, you would want to know about that because a new intervention may be available, or perhaps the schedule of screening has changed. And there were a total of 623 updates over those 5 years. That would be hard for anybody to keep up with, but having it automated, you could see would be much easier. So for cancer genes, there were a total of 265 updates, or about 10 updates per gene. For cardiac, 333, or about 11 per gene, and other 25, or about 6 per gene. And that may not sound like many, but imagine you're a patient with a hereditary cancer syndrome, and over a 5-year period, there were 10 changes to your medical management that you never heard about. Or you were a physician trying to take care of this person, there were 10 updates that you didn't realize that you should have applied. And so you can really see the need here. And so this is actually when we counted, with My Gene Council Live last year, how many patient notifications did we send out based on not just medical management, but other types of notifications. So we've got medical management. Risks might be new risk information linked with a genetic condition, maybe new phenotypic information we know about. Family information might be related to inheritance patterns, something new we've learned. General information, one example, we added information on somatic testing, even to hereditary cancer reports, because we realized patients didn't understand what they were getting, and clinicians needed a little bit more guidance too, just on kind of what the differences were. And then also things like resources and support. So maybe, online support groups or, patient webinars, things like that. So within cancer, there were about 9 updates per gene in just 1 year that we were able to send patients related to medical management and other things. Cardiac, it was almost 6, and then you can see other there. And if anybody was curious on just kind of how it all breaks down by gene, you could see these are the cancer genes, and we sent out the most updates related to BRCA 1 and 2, followed by some polyposis and Lynch genes. And then for cardiac, you can see the ones we sent most for, which were some aneurysm conditions. And it may also be helpful just to kind of think about how you might use this. So you could see where online genetic counseling reports, when we have it pre and post test, and we have online counseling reports or living lab reports in a variety of areas. We started with the ACMG 59, which of course now is more than 70, but that's mainly cancer and cardio genes. And then we kind of filled out from there based on what people needed. So we have coverage for most of the genes that would be on commonly ordered cancer and oncology, cardiology panels. We've got prenatal, some neuro, and we can always create living lab reports in different disease areas as they're needed by customers. So sometimes people say, well, what if I do have a genetic counselor? If my hospital system's lucky enough to have that expertise, why would we need living lab reports? And in that case, it can really help with, again, making genetic counselors more efficient, allowing them to practice at the top of their scope by supporting some of the more repetitive conversations like pre-test counseling or negative reports. And also just for that long-term engagement piece. So like I was mentioning, when I encouraged patients and clinicians to call me back and I knew I wasn't going to hear from them, living lab reports could provide sort of an electronic link back to that patient and tied by gene and variant. And so it may augment what genetic counselors are already doing. In other types of healthcare systems, people either may not have genetic counselors or they may not have enough genetic counselors. So there was one forward-thinking private hospital that said, well, our cardiologists are ordering cardiogenetic testing. Our oncologists are ordering, cancer genetic testing on the germline side. And if, we do have some access to genetics, but we're using telehealth with a private company. So they were wondering how living lab reports could help them. Well, on the pre-test side, we could help with informed consent. And on the post-test side, those oncologists, those cardiologists could benefit from the living lab reports that also face clinicians so that they had the best information to provide patients. And they were having trouble affording supporting one-on-one telehealth sessions for every patient. But this way, the health system could just pay for those one-on-one telehealth sessions for the people who test positive. So it allowed them to use their resources more wisely. And this doesn't just have to be sort of clinical or medical grade testing. You could also use living lab reports to responsibly return population study results. So we're seeing more and more genomic population studies and often seeing return of some findings, especially, the ACMG 73. And so this is a way that living lab reports could help return those results in a responsible way by explaining to research participants what the results mean. And in the case that medical grade confirmation is necessary, could even explain that in the report, that this is the variant that was found, this is the condition it's associated with, however, it needs to be confirmed in a medical grade lab, and this is how that can be done. Or, a lot of research participants say that they sometimes don't really feel valued by the research study. They don't really know what's going on. They don't know what lessons have been learned. And so because of our updates, we could also update them, not just related to that genetic variant that was found, but we could send updates on how the study's going, what's being learned, and make them realize just how much they're contributing to research. Another example is when you launch a new type of test and physicians are already dealing with the stress of that, but then they also need to think about kind of how to do it fairly so that all patients are getting equal access, but also sort of equal level of care. So there was a hospital in the US that was going to start offering non-invasive prenatal screening or prenatal testing to all pregnant women, whereas before it was only pregnant women that were, advanced maternal age or had another indication for the testing. And so they said, well, many of these OBs have never had to do this before. They're nervous about it. And so, or they're just busy and it's a lot for them to do in an already busy clinic. And so this way, My Gene Council could offer pre-test reports to all of the women in clinic who are about to have this test so they could learn about what that means. And of course, it's available on their device so they could continue to read about it while they're waiting on test results. And then when results come back, both the patient and her physician get living lab reports about that test result so that they can understand what they mean, next steps, have an engaged discussion, and it really kind of level sets so that everyone's getting initial the same test, but also the same quality of care. And sometimes it's easiest to just kind of show screenshots from the platform so you can see what living lab reports look like. It's not a perfect representation, but I think it will help everyone understand a little bit more how these could be used. So imagine you've got a patient who has cancer and they're going to have germline testing through their oncologist, and that the health system is a client of My Gene Council, and they're giving pre-test education reports to all patients having this test. So like I said, it is web-based and they can look at this on any device. I've just captured a few key areas. All reports always start with a summary, which is the most important information that you would want a patient to have. So in this case, that about 5 to 10% of cancers have a hereditary cause. The basics of what genetic testing for hereditary cancer is what it would mean if a mutation was found, how it can impact things like treatment, future cancer screening, or implications for relatives. And then, some patients would say, good, I have a good general understanding. That's everything I want to know. If they have other questions, maybe they'd ask their oncologist. But other patients are going to want to learn more, especially if they're waiting weeks for test results. And so in that case, they could toggle over and look at this navigation bar and click through different topics. So, overview might be general information related to the testing, which I'll show you. Medical management might be hypothetically how this could change things if they have cancer and test positive versus if they don't. Family information would be risk to relatives, insurance as it applies depending on the country and situation, and then medical and support resources as well. So we want to give them that anticipatory guidance that a genetic counselor typically would as well. And you'll notice that there are, yes.
Sorry to interrupt. We just have 2 minutes left.
Yes, I'm almost done.
Okay.
And so within overview, you can see the different questions. There's a Hover dictionary in case there are tough words that a patient might not know. And then when results come back, more detailed information about risks. And we can alert them later of notifications, which are updates, which they'd get an email or text message. And then clinicians would have a very similar experience, only in more clinician appropriate language. And in addition to just those general risks, they may want much more detailed guidance about things like treatment. And so they can see that as well. So that is all from me. Thank you again for letting me share. I'm happy to be here.
Yeah, That was a good talk. I think we're going on with the next talk. Kunal, will you be happy to introduce the next speaker?
Thank you, Dr. Rachel. Happy to. And thank you, Megan, for an engaging talk. Now, our next speaker is Ms. Ambreen Khan. She is a genetic counselor at Huntsman Cancer Institute and has completed her master's in genetic counseling from University of Utah and BDS from the University of British Columbia. Ambreen's interests lie in genetic counseling, cancer genetics, and precision medicine. And she's been a licensed and certified genetic counselor and genetic counselor for hereditary cancer risks in the Family Cancer Assessment Clinic. Pleasure to invite Ms. Ambreen. Thank you for joining us today.
Thank you for having me. So my talk today will talk about cancer genetic counseling in the era of precision medicine. And I mostly do a clinical role in the genetic counseling field. And so while Megan works mostly in the lab setting, my interactions are mostly in the patient setting, but a lot of what Megan covered would also be relevant for the talk. And so I work at Huntsman Cancer Institute in Salt Lake City, Utah. So if you were to look at the map, it's kind of towards the West Coast. I don't have any conflicts of interest to declare for this talk. And today I will be covering the types of genetic counseling and or genetic testing rather for cancer, discussion of what needs to be included in pre-test genetic counseling, as well as overview of tools used in familial cancer risk assessment. So you may be familiar with the different types of genetic testing. One of the specific types that is more increasingly used in clinical settings is somatic genetic testing, as well as germline testing and correlation between the two. So for somatic testing, it's usually present only in the tissue of interest, so the tumor tissue. It can be found in circulating tumor DNA, so we could use blood samples, and it's generally not passed from one generation to the other. However, the germline testing is relevant because it is usually present in all cells of the body. It can be identified in any tissue, blood or saliva, and we tend to use skin fibroblasts for people with heme malignancies, such as leukemia or have those who have had a bone marrow transplant recently. It may not always be, the germline mutations may not always be found on somatic testing, and these mutations can be found and can be passed down from one generation to the next. So what needs to be usually included in pre-test counseling, and I'll come back to the somatic and germline testing, but just to review some of the things that we generally cover in a genetic counseling session before a patient pursues genetic testing. And these are the guidelines set by the American Society of Clinical Oncology. So we would cover the information specific to genetic mutations being tested. We would cover the implications of a positive, negative, and uncertain result, the possibility that the genetic testing may not be informative for the person that we're doing the testing for, the risk that family members may have inherited a genetic condition and the cost involved for the testing as well as counseling. And we would also cover the psychological implications of test results. In certain areas of the world, there may be protections against genetic discrimination, and so we would cover the risk and the protections involved in that, some of the confidentiality issues that may come up, as well as options and limitations that we have of surveillance and prevention strategies in terms of cancer risk. We would also discuss the importance of sharing results with at-risk relatives, as well as plans for disclosing results and providing follow-up. More commonly, we're doing panel testing in a clinical setting rather than testing for just a single gene. And when we do panel testing, there is a possibility of high penetrance mutations that are not necessarily something that we would think of when we're looking at a family history, but can be detected when we're doing a large panel. So the discussion of that could be important in giving the patient the anticipatory guidance that they need. We would also cover implications of a positive result in a less understood or a less penetrant gene, and in finding of mutations in genes associated with syndromes that are not suggested by personal family history, as I mentioned. We would also talk about, when we're doing a panel of genes, the higher rate of variants of uncertain significance that we could find when we are doing panel testing, and how that may cause sometimes anxiety for some people because we're having these uncertain results. And then lastly, we would also cover potential reproductive implications of mutations in genes linked to recessive disorders, for example, with ATM and ataxia telangiectasia, or BRCA2 and PALB2 genes and Fanconi anemia risk. And so what are some of the tools that I routinely use in a familial cancer risk assessment setting? Those would include somatic versus germline testing correlation, family history, which is one of the easiest and most accessible tool in most settings, NCCN guidelines, or the National Comprehensive Cancer Network guidelines, as well as risk assessment models. To start with the somatic and germline testing, usually somatic testing with or without germline testing is usually treatment driven. And some of the considerations, or one of the major considerations for somatic testing, would be if a person's a candidate for new precision therapies for advanced cancer. Sample types usually used in somatic testing would include blood for circulating tumor DNA, as well as tumor samples, specifically tumor samples, seeing if there are any somatic mutations. However, sometimes when we're doing somatic testing, some labs do paired somatic testing where they do somatic and germline testing. When we're focusing on germline testing, that is usually risk-driven. And so what would be the risk of cancer in the patient if they're unaffected, or what are the risks for the family's risk of cancer, as well as how do we manage that risk? More commonly now, we are doing germline testing, and the current ASCO conference that happened in 2021 emphasized this as well, but there are precision therapies available for germline mutations as well that we're more routinely talking to patients about at this time, and that is creating a huge need for germline testing in individuals with a cancer history, a personal cancer history per se. When we are doing germline testing, as I mentioned previously, the samples would be the blood, saliva, or the unaffected tissue, depending on what tissue type we're using. The all-encompassing goal of both the somatic and germline testing is really what the patient's goals are as well for genetic testing, and where those goals align with the clinical practice. So somatic testing does not always pick up all germline variants, and some labs do report possible germline results while others may filter those out. Most of the time, when you do find a germline mutation on a somatic testing lab report, even when they're doing pair testing, you would need to confirm it through a germline testing lab, and you cannot assume that a somatic lab will cover germline mutations comprehensively. A whole presentation could be done about somatic and germline testing and the correlations that we see, but this is just a brief summary of some of the things that we would consider when we're doing clinical genetic counseling in a cancer setting. As I had mentioned, family history, red flags, there's another tool that we use in cancer setting. Some of the things that are in current practice include looking at a family history of early onset diagnosis, younger than age 45 for breast cancer and younger than age 50 for colon and other cancers, as well as patterns of cancers associated with hereditary risks, such as breast and ovarian cancer in a family with hereditary breast and ovarian cancer syndrome associated with the BRCA1 and BRCA2 mutations. If there is family history of breast and pancreatic or breast and colon cancer, we may think of moderate risk genes such as CHEK2 or ATM. And then colon and uterine cancer in families would point us towards Lynch syndrome or hereditary non-polyposis colorectal cancer syndrome. When we see increased prevalence of breast cancer in a family, so greater than 12% population risk, and there have been studies looking at this risk in populations of European ancestry versus other ancestries. However, mostly the risk numbers are pretty similar in various ethnicities and various groups. And so the 12% population risk may or may not apply to all populations worldwide, but that is the most commonly indicated risk that we have based on literature. And then there is increased cancer prevalence in families. So greater than 1 in 2 males and 1 in 3 females. If we see those in the family, those again raise what we call red flags or concerns for a hereditary cancer syndrome. So in this case history or pedigree, as you can see, there's multiple red flags that we would look at. So we would look at this person with triple negative breast cancer at age 35. So that's breast cancer diagnosed prior to age 45. We see multiple generations affected with cancer, but triple negative breast cancer in itself is something that we get concerned about as being associated with a BRCA mutation. And the guidelines currently do say anyone with a triple negative breast cancer before the age of 60 should consider genetic testing. If we see family members with breast cancer, ovarian cancer, pancreatic cancer, and high-risk prostate cancer. And so in this family, we do see the breast cancer at age 55 in the mom, and then we do see abdominal cancer, which is most commonly usually ovarian cancer and mislabeled as abdominal or gynecological cancer. Now this family is, even though this family is pretty limited, we still can appreciate that there is a young age of diagnosis of a triple negative breast cancer, which would then prompt genetic testing for this family. Some of the things that we take into consideration are the NCCN guidelines or the National Comprehensive Cancer Network guidelines. These are updated pretty regularly, and there is expert consensus in developing these guidelines. Usually, different continents and countries would have guidelines in place, or individuals could visit the NCCN webpage and follow the guidelines here for North America currently. And so, as I had mentioned previously, these are some of the things that we would take into consideration when considering genetic testing. And these are similar guidelines, but for colorectal cancer. The previous ones were for breast cancer. The next tool that we use are risk models. So these are some of the more common risk models that we may use in clinical practice. And these are used either during pre-test counseling or even in post-test counseling if a genetic test result comes back negative, but we still have a strong family history. A couple of models that I have highlighted here. One of them is the BRCA Pro or the BRCA Pro model, which estimates breast and ovarian cancer risk over time. It can also estimate contralateral or a new breast cancer risk for women who have already been diagnosed. It also estimates the risk of having a BRCA1 or 2 mutation and provides more limited mutation probability regarding things like Lynch syndrome, potential melanoma, or pancreatic cancer risk genes. So I've provided the website here where people can access that for their clinical practice. It does include a free or need a free registration, and the models that it would output are the BRCA Pro model, MMR Pro, which is mismatch repair deficiency associated with Lynch syndrome, MELA-Pro and PANC Pro, as well as Gale and Klaus models, which I'll touch on in a little bit. The other model that we use routinely is the Tarrer-Cuzick risk model, which provides breast and ovarian cancer risk estimates, as well as BRCA1 and 2 mutation risk. It can only be used in women who do not have a personal history of breast or ovarian cancer. So it's a little bit more limited as compared to the BRCA Pro or the BRCA Pro model. For Tarrer-Cuzick model, it includes both family history information and personal risk factors such as hormonal factors, breast density, history of breast biopsies, etc. And then one of the models that we use to calculate risk for a mutation in any of the 5 Lynch syndrome associated genes is called PREM5, which can be accessed here. It does not necessarily calculate risk for cancer, but it does calculate risk for gene mutations in Lynch syndrome genes. The reason why we may use these risk models in clinical practice is, one, to see what the likelihood of this person having a mutation is. So for example, for the PREM model, but also to see where they fit in terms of their lifetime cancer risk in the context of family history. And sorry, this pedigree is not as maybe not as clear, but as you can see here, this is the proband here. They have a BRCA2 mutation, they're unaffected, and they have a family history of a few different mutations, but they only inherited the BRCA2 mutation. Family history is significant for the breast cancer as well as the colon cancer. And I use the BRCA Pro model to estimate their lifetime breast cancer risk. And as you can see here, even in the context of a BRCA2 mutation, their lifetime breast cancer risk up till the age of 85 is roughly about 55%. Sometimes in a clinical setting, a patient can really benefit from a 5 to 10-year cancer risk because knowing that they have a 55% lifetime breast cancer risk can induce a lot of anxiety in individuals, and they may think that they're doomed to have cancer. And giving that context that their lifetime breast cancer risk may be 55%, but their 10-year breast cancer risk is around 7% or so, does bring down their anxiety and understanding that this risk does increase incrementally over their lifetime. And then similarly with ovarian cancer risk, here the risk is about 30%, but their lifetime risk is really, really low, or I apologize, their 10-year risk is really, really low. It's about 0.6%. And that again provides a little bit more relief to a lot of patients because they, when they find out their mutation status, it may be very anxiety inducing. So the psychological implications that I touched on in the beginning are very important in the context of a known mutation in the family, as well as the age of diagnosis, because when individuals are 35, they may still be family planning, and having this information can then help them make decisions that are best for their family as well. So for the second pedigree, you may see that this patient does have a strong family history of breast cancer, and the shaded circles are individuals affected with breast cancer. They have some early age of diagnosis of breast cancer, as well as breast cancer on both sides of their families. And I believe this age is likely not correct because they're 31, so they can't have a parent who is 28. But going back to their genetic test results were negative, which then puts them at not a population risk, but an elevated risk for breast cancer based on the family history. Again, knowing that they have family history of breast cancer on both sides of their family, knowing what their familial risk or lifetime breast cancer risk based on their family history can be really helpful in, one, their medical management, but also helping them understand what their risk is like and what are some of the tools they have to take control of their health and really empower them with this information. As I had mentioned earlier, and as Megan also touched in her talk, it is important to realize that a patient may still be at an increased familial risk even when there is no mutation identified. In this case, we use a Tyrer-Cuzick risk model, and calculating this risk model gives us an output of 32.5% estimated breast cancer risk for this individual. You can see that the blue line represents the population risk, whereas the red line represents the patient's risk. Again, we have the breakdown of the 10, the 20-year risk for this individual, which can again give them more context what their lifetime risk versus their incremental risk over the next 10 years would look like. Having this information, at least here in the United States, can also help provide coverage for additional screenings for individuals. So individuals who are above a 20% threshold using the Tyrer-Cuzick risk model can qualify for breast MRIs as well as breast mammograms alternating every 6 months just based on the familial risk. Compared to if we didn't have this risk model to justify, or their lifetime risk despite family history was under 20%, their health insurance would unlikely cover those additional screenings for them. Now, a lot of times having these additional screenings can be reassuring in the case of family history and no known mutation for individuals, but also we definitely have seen patients where they may not have a known mutation, but they do have this increased risk, and they are doing these preventative screenings, and they are diagnosed with breast cancer, but we're catching it at a very, very early stage. And that can be really helpful because then their treatment options can be not as intense as going through, even sometimes going through chemotherapy or radiation. They may just need a lumpectomy if it is small enough tumor.
Ms. Ambreen, sorry to interrupt. We have 2 minutes left.
Okay, I am just about done. So this is the last pedigree that I have to show, and this is a patient who had a personal history of colorectal cancer and a not super strong family history, but family history of prostate cancer in a couple of generations as well. So I used the PREM score to calculate the overall probability of having one of the mutations in one of the Lynch syndrome genes, and the probability was about 7.7%. In order for genetic testing to be considered, the probability has to be over 2.5% or equal to 2.5%. And so this patient definitely meets the criteria for genetic testing. Here's a list of some of the other models that I had touched on previously that can be used in the context of family history, as well as personal history of an individual. There is one model that can be used in the presence of other mutations such as ATM, CHEK2, or PALB2 mutations as well. One thing that is important to remember is these models, these risk assessment models are validated in majority European cohorts, and so precautions need to be taken when extrapolating the data from these models to aid in medical decision-making for ethnically diverse cohorts. And myself and a couple of other colleagues did post an abstract that was published for ASCO, or American Society of Clinical Oncology, covering some of the we delved deeper in into some of the models, as well as some of the cohorts that were used. So if you were curious, you could look more into that. Here are some of the other resources that I use routinely in clinic to get more information for my patients. And with that, I do appreciate being invited to this talk, and I am thankful for your time. Thank you.
Yeah, that was, again, a very interesting talk on, germline testing, the models for risk assessment, etc. Really good. I guess the questions are to the end, I guess. Is that right?
Yes, Dr. Rachel,
yes.
We will take it at the end.
Fine. Now may introduce the next speaker. It's my pleasure to introduce Arjun Gupta, who is a BTech and an MS in entrepreneurship and technology commercialization from University of Michigan. And he's a founder and CEO of Genetical Research and Diagnostics Private Limited. His interests are clinical genetics and research, rare disorders, bioinformatics. He's had, different awards like the BIRAC Award and the NITI SSS Award and the other awards that are listed over here. And he is featured in Orphanet Journal of Rare Diseases. He's worked at multiple bioinformatics and also has some played around with some, drug discovery. It's really good. And I think now we can have Arjun tell us his story.
You're on mute, Mr. Arjun.
I hope you can see my screen and I'm audible.
Yes, sir.
Yes.
Great. A very good evening to all the attendees, speakers, and the organizers of this wonderful conference. It's truly a pleasure and honor for me to be speaking at this forum. And I would like to express my gratitude towards Dr. Annie Hassan ma'am, Dr. Lakshmi, Dr. Prachi, and all other members of the organizing committee for inviting me to speak at this conference. My name is Arjun Gupta, and today I'm going to talk about the clinical genetics software that Genetico has developed that could assist in reducing time to diagnosis and enable new medical discoveries in the field of rare and genetic diseases. To begin with, to share a bit about my background, I'm a biotechnology engineer with exposure to drug discovery research against cancers at a large pharma, and a Master of Entrepreneurship graduate from Ross School of Business at the University of Michigan. I was first introduced to the field of rare diseases in 2013 while working for a venture capital fund when I was understanding the orphan drug industry. And I soon saw, the challenges that were there in the genetic industry and the flood of information that NGS was going to bring and how it was going to revolutionize. So I soon joined, I worked at a couple of bioinformatics startups in the US. And at that point, I was dealing with researchers all across the world. And I saw that, in countries like India, the landscape was fairly different to what I was seeing in the other countries. So soon I decided to move back to India and see what can I do, what kind of technology solutions we can build that are specific for our country, and which ended up being it ended up me founding Genetico, and I'd be happy to talk today about it. So I think many speakers, Megan, Nicole, covered the need for having these kind of tools for the medical fraternity. But just to give a quick overview, we have about 7,000 rare diseases that are linked to over 13,000 phenotypes with over 150,000 associations as described just in the human phenotype ontology. So it is, it's fairly difficult for clinicians or genetic counselors with the evolving knowledge that is coming every year to keep a tap on on across all these genetic conditions and effectively, differentially diagnose solution solely relying on the experience that they've had with the patients that they have. And with in India, with the estimated 70 million people affected with rare diseases, it's fairly challenging with only one medical geneticist per million people and far fewer genetic counselors to do justice to such a wide patient population and such vast area of conditions. Now, is us at the same time, it presents an opportunity if able to this clinical data, actually some quite a bit of knowledge that can then translate into so many artificial intelligence based technologies and possibilities of discovery research. So when I came and I worked at I worked at a genetic testing lab for a year, what I realized that most of these centers were storing all their genetic data either on paper or it was in Excel sheets with different formats across the country. So this really, in my view, called for a dedicated software for researchers and clinical experts in the field of genetics to store their data in a structured format that they can which can also help them generate some real-time insights to assist in diagnosis, and then also create opportunities for new discoveries as they move along. So Genetico was founded in 2018. The mission was to begin with, the mission was to first build a software that can be used by our genetics community. And then later on, as we pile on the genetic data that comes in, different companies, research groups, and even Genetico can build some strong technologies for these clinicians, genetic counselors, and medical geneticists to assist in the research and diagnosis. Now, we were fortunate to get support of BIRAC, Jammu and Kashmir government. That's where the company is incorporated, and various top technology incubators in countries such as IIT Mandi, and a few visionary investors, even though it's a field where investors are not very comfortable investing given the small size of the medical fraternity. But today I'm very happy to share about the first version of our software, which is available to individual genetic counselors, medical geneticists, even a team of experts or clinical research groups across India or across the world through our invite-only early access program for now, and I'll share about that, how you can gain access to it. Okay, so this is just a standard pedigree that you might see or draw regularly in your practice. Typically, a lot of this work is done on paper, but if you've used some tools or if you've used Microsoft Word or PowerPoint, I know how hard it has been. So, most of our effort first went into building a strong pedigree editor, which we are continuing to upgrade. And through this screencast, I would like to first show you that how the same pedigree can be built in a very user-friendly way on our platform. And it's a fairly smooth pedigree editor, and we are continuing to build on top of it. You can see that how you can add partners, sibling, and also even show things like consanguinity. If you click on any of these nodes, there's an opportunity to select gender, assign proband, and even add clinical data, which in this case we have used the human phenotype ontology. And you'll see about 5 phenotypes that are being added here. You can search it just like you do it on Google, and it will show up the results. And then there are other sections like the gene data if you want to nominate any kind of genes. All of this genetic data is being stored in Hugo nomenclatures. And then there's also free text for you to scribble some notes in the medical history. Now, measurements is another part of the clinical workflow. So you can add these measurements at different time points. And as soon as you're done with it and you add that, we display the growth charts, which uses the reference for the Indian data sets. So if we are enabling this for other countries, we can also add their growth charts to the software. And other than that, there are various labels that you can put on the pedigree. Maybe that's just for you to display it. And the same concept that we did on the proband, it works for all other nodes. And you will see that, within, it's just about 1 minute and 40 seconds here, and you are almost done with the pedigree. And you've added a bunch of phenotypic data, and now you're going on to the parent nodes and adding various other features. So I'm just going to let it run for another few seconds. Right. I guess I can move on. So, and then, we are hoping that we build the pedigree editor in such a robust way that predominantly a large part of your workflow gets covered into this. But obviously, we also have a separate section which would take down the, which would allow you to do more detailed clinical workflow in a proper patient editor form. So this form is also of the same patient for which we drew the pedigree. And you will see it is divided into 13 key categories. You have your patient personal information. You can add pictures right there, and then, patient contact information, the chief complaints that they have presented with. Then if you click on show pedigree data, it opens the existing one, or can, you can create a new one. And then various development history parameters. This can be customized based on your workflow. We are already in the process of customizing it for a few centers. Then your prenatal, perinatal information. This also can be customized to your workflow. Many a times we see that institutes want far fewer options, so we are geared to offer what they need. And just a second, sorry. So, right. Now, after that, once you've done with the prenatal, perinatal information, there is a section for measurements. You can again see the graph that you've uploaded, or you can add new measurement data. As I said, it can be done over time, and you can track on the graph. Then there's a section for medical history. If there are reports to be added, it can be added in that section. And this is the key section where we have enabled deep phenotyping based on the human phenotype ontology terms. So you can search it just like you do on any search engine, or you can utilize this tree structure. So you will see that it is similar to the human phenotype ontology. This ontological structure actually enables a lot of downstream analysis and also open new avenues. So here, even if you would like, you can drill down on the tree structure and select a very specific deeply phenotyped term. Right, so it gets added on the right-hand side, and you will see a sufficiency score, which basically gives you an assessment of, how well you've covered various phenotypes and how deeply you've phenotyped a patient. So if you've added a much deeper, assessment, the phenotypic score also increases with that. Other than that, right now there's a very basic section to add the genotypic information, and this would soon be complemented with other technologies. But you can add that. You can add diagnostic notes for your own reference, or patient case summaries, which can be printed separately, and reports can be printed out of it. So just before we move on, I just want to kind of share, I just spoke about the sufficiency score, and this is taken from the Monarch initiative. It is a good assessment to kind of see that how well we've covered, but we will try to augment this further and even try to suggest additional phenotypes in our upcoming releases. And then right now, if you click on this analyze button, you will see that a table appears with a list of phenotypes. Now this is still in beta phase. This is kind of similar to the other public tools that are out there, because the underlying data that we are using are public associations, associations which are in the public domain between the phenotypes and the conditions. So, but we are already doing some quality research collaborations. We are trying to collaborate with institutes where we are taking the anonymized data of the phenotype and the diagnosed conditions, and then improve these algorithms as we move along. And I would really welcome various institutes and even individuals to come join us in this effort, and we'd be happy to share more details on what all it entails in the collaboration. And then we also enable, it's just a placeholder for now, but we'll enable even the gene recommendations. And just like Nicole spoke about that, how you can send this data to a laboratory, there are provisions that you can create a customized TRF forms which goes directly, and it has the ability to be integrated into the analysis pipeline of that particular laboratory where you're sending the samples, and they can use the phenotypes to prioritize their genes that they would like to investigate. Or even you can nominate a certain set of genes, which we can predict as a part of our analysis for the laboratory to certainly have a look at. Now, the other aspect I wanted to touch upon is that we frequently, as I've seen in the Indian ecosystem, many people are very strong experts in certain conditions in certain parts of the countries, as they see frequently such cases. So we've built the opportunity to share a particular case with a practitioner, and if you click on this icon, it shows the case privacy as if you wanted to share this within your organization, or if you want to share with a doctor outside of your organization. And if you're sharing this outside of your organization, you will see, just notice that this patient personal information and contact information, which goes from the user, which is myself here, Arjun. And when I share this to the different user, you see that the share icon, first of all, the patient personal contact information is not present anymore. So it will only share the anonymized case information, so that you can be a little more assured on the data that is being shared in a fairly anonymized way. And then on top of that, the share icon that was present in the previous view, which was the original author of this case per se, the same share icon goes missing. So if anybody has to share this case, if your collaborator has to share this case, they have to do that with your permission. And in fact, you will be the one sharing that case with somebody else. Now, the next thing that I wanted to talk about is that when I saw so many clinics in India, sometimes there's not even a place to stand, and you take babies in a separate measurement room, and it's fairly crowded. So we thought that can we build some a quick way to handle some of that work. So what I noticed was, one quick thing that people wanted to do was add patients while they are in the waiting room. And they in India still people come with a bunch of physical documents, which can be reports, prescriptions, and so on from another clinic. So we have built a document scanner in this phone app, and you can scan that entire laboratory report, and that report does not get saved onto your phone. So if you have an assistant doing that job for you, you can be assured that laboratory reports will not be saved on their phone, but it will go directly onto the cloud, and it will be saved. It will be tagged to your case. Additionally, when you take the child or the patient to the measurement room, you have some very basic, functionality where you can add these growth parameters and generate these graphs rapidly. So by the time it goes to a senior clinician, they already have all this data on their application, on their desktop application. So that basically, hopefully, that would allow you to save some time and streamline some of this work. So next, I would, these apps, by the way, are available on App Store or Android Store, so you can download that if you're a user of our product. Now, as a part of our BIRAC grant, we realized that for rare and genetic diseases, it makes a lot of sense to match undiagnosed patients with diagnosed or undiagnosed patients. So, and we saw that there's no such patient exchange in India. So we decided that we'll build one, and we got approval for same. And so in the coming month, you will see that we will come up with a patient matching exchange for the country, where an authorized user can push an anonymized case to our platform. This can be done from the product, or you can separately have that interface to do this. So once you submit a case, and if that case matches with a case that is already submitted by another authorized user, it will notify you, and it will also break down the phenotypes that have matched and the phenotypes that have not matched, and also the gene where you found common mutations. So hopefully this would also open new avenues to conduct research. And we can even, just another thing is we are even looking at adding a feature where amongst different databases, if you want to choose a set of clinical parameters, that can be gene, phenotypes, growth parameters. So you can share that setting with some of your collaborators, and they can see if they have as many set of patients in their database, so that you can potentially build a cohort and do some amazing research, which I think should definitely come from our country. And that's part of our product roadmap. Now, on how you can access this product, if you visit our website, www.genetico.in, you will see a link called Get My Invite. Right now, we are working with select centers so that we can ensure that some really quality workflow gets embedded into the system before others can get access to it. But I think we are pretty far along. New updates are also coming in the next week. I would highly encourage all the people here from institutes or individually genetic counselors, medical geneticists, India and even abroad, to sign up for this. And possibly, most likely, I would get in touch with you to see how we can take things forward. And if you kind of heard about us on this conference, we would also be happy to consider discounts for you to access the product. Now, we've been building this product for past 2 years, and there's a lot that needs to be done. We are happy that at least we have the ball rolling. We have the very basic infrastructure that can be leveraged by our community, but we still don't have a name for this product. And I would put this out to the community which is attending the conference. If you are able to suggest a good name, and if we choose that, we can share. I mean, I'd be happy to kind of announce that and share a small token of our appreciation for the creativity. And given we are a startup, we can afford this much. So thank you so much. And, it's truly a pleasure being on this platform. And I look forward to the panel discussion and the questions. Thank you.
Good to have, people who play around with software. I mean, this is what we always look for in our research, because, it's one thing to discover, it's one thing to, put it in perspective. I mean, to get the perspective out, you need bioinformaticians, you need software building, etc. Really good. Kunal, would you like to now go on to the next speaker and introduce it?
Thank you, Dr. Rachel, and thank you for another engaging talk, Mr. Arjun. My pleasure to introduce Mr. Roland, who's the founder and director of GeneBlock.ai. After pursuing her master's in entrepreneurship from Dublin, Ireland, he sort of went on to become the head of marketing and sales of GeneBox Ireland, and has also served as the consultant of Croxa Limited Italy, has been a sales manager in GSK, Merck, Smith & Nephew in India. So with a wealth of pharmaceutical experiences, his interest lies in genetics and genomics, artificial intelligence and blockchain technology, healthcare and pharma, and most importantly, problem solving. So I'm interested to hear how GeneBlock can problem solve some of the digital platform related issues. So over to you, Mr. Roland. Thank you for joining.
Hello, Mr. Roland. Please unmute yourself.
Right. Thanks. Thank you, Dr. Kunal and Dr. Rachel for warm introduction. And also I extend my thanks to Dr. Shruti and Madhavi as well. It's a really great honor, presenting in front of you with our company and, presenting to an audience which we really value a lot. Basically, we try to understand your problems deeply, and we wanted to leverage the technologies like AI and blockchain to solve your real-time problems. So choosing the right tool is really critical for the geneticist, especially when you find no simple and safe solution to effectively compress, store, and manage your sensitive DNA data. And not only that, there are no community support system in place for genetic counselors. However, Arjun highlighted few tools which could able to solve the problem. As a matter of fact, globally, there are concerns about sharing the data, and the geneticists are worried about the threat of data breach when they share the data for the research or other commercial purposes. Put together, it might be a problem statement for a geneticist to choose the right tool for them to take it forward to address their unique research needs. So it's important to find the right solution for these problems. So ladies and gentlemen, my name is Roland Lamville, and I'm the founder and director of geneblock.ai. And at GeneBlock, we understand our fellow geneticists, their deep problems, and strive to solve them by leveraging deep technologies. And here we are launching the GeneBlock's Enterprise Studio beta version for the genetic community to address the real-world problem by leveraging deep technologies. So let's deep dive into the Enterprise Studio and see how it solves your unique problems. So when it comes to NGS analysis, there are a lot of questions in terms of the data analysis, the interpretation, and report generation, and an automated approach which can be customized based on your unique research needs would play a vital role or comes in handy for research individual researchers or even organizations to perform NGS data analysis at ease. Also parallelly run a compression algorithm and you can efficiently store it on a private vault which is highly secure and safe. When I say highly secure and safe, even the company which built it, which is us, even we should not be able to access the data which is put on the private vault. And last but not the least, having given all these values, we still wanted to make sure that the technology should not be complicated to the end users. So in order to improve the customer experience, we wanted to make sure that we wanted to go forward with a minimalistic design when it comes to the user interface, which makes it handy for people to do it themselves. So the geneticist or the genetic counselors who's going to access these tools would find it much simple for them to play around with the options and the tools that are provided within the Enterprise Studio. We also have great news for the genetics community to explore and connect with your fellow genetics society, where you'll be able to share your data and also request access to use the data from your fellow geneticists, to take care of your research or other requirements. and with the confidence that the data that you're going to share is going to be completely owned by you yourself. So this kind of data privacy and ownership is what the key value GeneBlock is trying to offer to its clients. I just wanted to focus largely towards the security architecture because GeneBlock as a company is concerned about the security of the genomic data and how the data is managed within the ecosystem. So we leverage the technological blockchain. Many of you have known, and for those who do not know the technology, so blockchain is a technology behind the cryptocurrencies like Bitcoins. And a lot of financial institutions and global banks have started adopting blockchain technology as an effective alternative to secure their financial transactions. And there are a lot of literatures that are supporting the use of blockchain as a technology in genomics to solve the genomic data security bottlenecks. And a genomic data being an immortal legacy for mankind should be given utmost care to protect and safeguard them. So we made sure that our architecture or the model that we're going to build should be at par with the global standards and also compliant to the data protection regulations. So we came up with this model where you'll be securely logging in, and when you sign up, you'll be able to generate two keys, which is a private key and a public key. Using the private key, you'll be able to access your private vault, and this private key is generated only once, and no one else has the access to get the private key except you yourself. So in the private vault, you'll be able to upload all your data, or if in case of genetic counselors, you can upload your patient's data, and it could be highly anonymized. You can also integrate your data upload system with the LIMS, but however, it will be masked and anonymized. And the data which is you have uploaded to the file upload system in the private vault could also be used for other purposes like the pipeline runs, which is in the Enterprise Studio comes with a lot of other pipelines which can be used to analyze it, or you can compress it, which I will talk about in the further slides. And coming to the public key, as you sign up, you'll also end up getting into the generating a public key, which will help you give restricted access to the community, and where you can share your data and allow access to use your data within the community and the marketplace. So this is a significant advantage per se, and no other company globally have attempted to get into the space, as we have leveraged multi-level security systems than the currently available security systems for genomic data in place in the market. So we take data security very seriously, and that's the reason we wanted to build the state-of-the-art security architecture to solve the genomic data security bottleneck. And besides that, even in the event that of data breach, which is highly, not possible, but still, even in the case of breach, your data will still be encrypted and will be tough to decode by anyone. Besides, as I told, we have the option to integrate with the laboratory information management system, where, however, there will be an option to de-identify the personally identifiable information, and this would be a completely automated solution for the end user. So thereby, we are complying with the global data security or the data protection regulations like the GDPR and HIPAA. So at GeneBlock, overall, the data security architecture is given the utmost priority, and you can be rest assured that the data that you're going to share or collaborating with the community, it's going to be a safe place to share. So besides the security, the huge value that we are trying to offer within the Enterprise Studio is the project management architecture for genomics specifically. So through this value, you will always get more for less. The files in the private vault, as we see, will be handy in terms of using those secure or even safeguarded data could be used in multiple pipelines like the clinical genome analysis pipeline and the compression pipeline. So these are the two pipelines that we have built at the moment. And we have plans to expand into multiple analysis pipelines like the microbiome and other somatic genome analysis pipelines and etc. So there are a lot of plans in the pipeline. However, we are active with the two pipelines at the moment. So we look forward to trial with the multiple people who are interested. So when it comes to the genome analysis pipeline, so we one unique thing that we have is it comes with a completely automated approach where you can upload the raw data file, be it the FASTQ or the VCF file, and you have to set some few parameters, and then you'll end up getting a report. So these reports also you'll be able to have the option to customize them. And besides that, the entire framework is on top of the ACMG and AMP guidelines, and even we are updated with the 2021 versions as well. So we also spoke to a lot of thought leaders within the industry, both locally and globally, and we were able to design a proprietary framework or an algorithm to minimize the incidence of VUS. However, it's still in the trial phase, so it's not there in the market yet. But sooner or later, we will be launching the pipelines in the market. So besides that, we'll be also able to customize the pipelines and the report based on the individual research or the organization's needs. And given the high computing infrastructure within GeneBlock, we will be able to process multiple samples, a large volume of samples at a given amount of time at a much faster rate. Coming to the compression pipeline, we again have built a proprietary algorithm where we were able to compress the data up to 90% with 0% data loss on decompression. And the one-click transfer option will enable the users to transfer a large genomic data, which is about 100 GB worth of file, and you will be still able to transfer it just like you transfer a movie file to your friends. So if you're still wondering how deep technology like AI and blockchain would directly impact your day-to-day practices, then I really wanted to elaborate more on the technologies that we use within GeneBlock. So the genomics analysis and the interpretation process automation was made possible because of the lot of advances in the technologies like AI, and the technology was mature or like in the verge of mature at this stage. So we were able to leverage a lot of cool features within the technology to use it within the genome analysis pipelines. So that way we were able to pass on the values of scaling your research faster and accelerating your research. Even if you have if you're planning to scale your company, then you will still able to be much more faster in terms of your analysis and your outputs. You will also be able to generate faster results than before, and with a minimal human intervention, you will be able to cut down cost on most of the skilled resources. As Arjun rightly pointed out, the 70:1 ratio for the skilled resources. In India, at least, we have the lack of skilled resources. So as the consumer adoption is going, multiplying by many folds, it's important to leverage technologies to solve the real world problem. And to scale your business faster, it's important to adopt new technologies to solve your real world problems. And with the DIY approach, you will be still able to do it everything by yourself without depending on other domain expertise, like say bioinformaticians to analyze your raw data to your VCF files, which could still be done by the automation tool. So you can avoid a lot of multiple resources handling a single sample data. And through the technology, you will be able to collaborate your data. And when it comes to the combination of AI and blockchain, there is still a significant value that we can leverage. And the team is working on multiple R&D projects to help solve the real world problem more efficiently. And when it comes to the combination of the technologies where we can leverage the faster analysis at a much more safer environment, we were able to pass on the benefits of privacy and ownership of the individual data that's been uploaded. Besides, we were able to pull down the turnaround time at a much more lower rate. And by leveraging all these technologies like AI and blockchain, we were able to make genomics more democratizable by making it more affordable and accessible through our one-stop shop approach. And when it comes to the technology switching cost, I know many people will find it difficult to switch from the traditional mode to a technology adoption. But still, when it comes to the technology switching cost, you will always get more for less. So I would also encourage you to have a look at our demonstration, where you will, you will able to, get answers for the questions that you might have.
Welcome to the demonstration of GeneBlock Enterprise Studio. If you are a new user, sign up by filling in your particulars. Once you're done, you can select the option based on the choices, as there will be a dedicated dashboard for each account. For example, if you are a genetic counselor, log in into your account using your mail ID and password. As you sign up, your security keys will be generated in BSP. Your dashboard will display a user-friendly control panel where you can create your own projects. As you generate a folder to upload your files, you will have convenient options to play around with your project. The archived data can be viewed in the My Repository section of the panel, or you can directly upload the documents here. Once a new project is created, there will be options that will minimize your work, and you can anytime modify your task as per your comfort. For example, if you need to run an automated genome analysis pipeline, you need to fill in the relevant parameters based on the file type you are going to select for the run. The timestamp will be recorded, which can be tracked during the run, and the parameters can be modified, or a default option can be set before the run. Once the run is completed, the results and test report can be viewed and downloaded on BSP. An added advantage is that you can track the activities of your tasks. You can finally log out of the Enterprise Studio with the logout icon in the top right corner. We hope that you relished our demonstration video. You can visit our website for more details, and we are looking forward to trial with each and every one of you. Thank you.
So hope you would have got an idea on how you can take complete control over your research for genome analysis especially. So we encourage you to free trial with us for the first few samples. And if in case if you want to have a multiple demonstration or in a person-to-person demonstration, we'll be happy to do it for you. And visit our website to know more about what we do, and check out our LinkedIn page for updates. So GeneBlog is always hungry for like-minded people like you. So we look forward to discussing with you and uncover new areas of opportunities working with you. So thanks for the opportunity given, and I hope I didn't bore you on a Sunday evening. Thanks for hearing me out. Take care. If you have any questions, please post it.
Yeah, would the moderators take on now, or how does it go? But that is a good talk too, Roland. It is more of these wizards, and yeah, it's good.
Yes, ma'am.
Good
Yes,
idea.
yes,
Do
yes.
it yourself. It's
Yeah.
really good.
So we started off from face to gene, and then how diagnosis, and then by the end of when we came to the fifth speaker, we are actually analyzing the data itself once with the VCF file. So it has come from the diagnosis to getting a report. The final speaker actually gave a report by the end of the video that we have seen. That was really nice. So now I think I invite all of the speakers and the chairpersons. Let's go to the panel discussion. We have few questions that have come up, and then let's discuss and see how we can actually get to adopt these tools. These are some things that I have seen now. There are lots of digital tools coming up. So I think I will ask Dr. Kunal, to take up as a chair. And then you have been working with, trying to get tools or helping the genetic counselors how to use the virtual tools, right? And then I think we can go ahead and see how what are the challenges that we face in adopting these tools. Actually, both Dr. Arjun, Mr. Arjun and Roland have given us some tools, but then I actually want to know what will be the challenges for us in adopting these tools, either in departments or as individuals or as genetic counselors, geneticists, doctors, right? So this is something that we need to, I think that is what as I was looking, listening to all the talks, this is something that has come into my mind, and I would want the speakers also to put their opinions and views here regarding it. Please, Dr. Kunal.
Yeah, thank you, Dr. Madhvi, and thank you all our speakers for excellent presentations. So the question is about the digital tools, and the insights from all the talks that I gathered and I learned was there is a lot of emphasis on adaptability and diverse representation. Even the questions, the presentations from the speakers reflected that. Starting from the FDNA, the questions and the talk was around how do we make it representative for patients from different communities and different backgrounds. It reflected throughout other talks as well in different capacities, whether it's the cancer models that are out there applicable to other ancestry or other community members. For the I think the last two talks were about the basic science and the tools that are available to sort of make that happen. So the diverse component representation from the DEI, diversity, equity, and inclusion spectrum applies. And we also learned from Megan's talk, right? I mean, they showed us the data from their updates that were curated from the ACMG 59 genes. Now it's ACMG 73. So there is always a constant need to evolve and adapt to the growing needs, technologies, and the policies that are out there. So there were a lot of questions that you asked Dr. Madhvi about the challenges and how these tools are sort of utilized in the clinic kind of thing. I would be curious to learn from our speakers and invite them to share their thoughts before sort of the chairs and the moderators chime in. So without sort of putting anyone on the spot, anyone who is willing to volunteer and share their thoughts, I think the audience would appreciate that.
So if I may, thank you for the very interesting talks and the summary you've made. I think that one of the main challenges that this adoption of AI tools face is on the one hand, the inclusion of different ethnicities, different ages, in some cases, gender issues. And on the other hand, the understanding that we're talking about statistical models many times. And biology is so much more complicated than a given statistical model. So this is why in the case of Face2Gene, these tools are in the hands of genetic counselors, of MDs, of trained professionals who can use their thinking together with, of course, the statistical propositions or suggestions that the models have as an output. But it's very important to keep that in mind, that it's not that the AI tools will take the place of the human being, but rather it's a combination. It's a help, it's a fabulous help in some cases, but it's not a replacement.
True. If I may go ahead with what Nicole said, I just wanted to add whatever for Nicole suggested. So truly, AI is going to be a companion for genomics. So until now, for the past 2 years, the question was all about how we can use AI for genomics. Is AI really ready for genomics? So that was the question. And for the last 2 years, as the technology advances and the new libraries for AI has popped up. So that's when we were able to leverage the artificial intelligence as a technology to solve the real world problems of genomics. So the question is truly, is genomics really ready to adopt the artificial intelligence and its applications? So despite there are a lot of questions, ethical questions that's surrounding the scenario, it's important to understand, use the technology wisely. Always, that's the best option. When I spoke about the blockchain advantage for security, data security, there are still a lot of concerns about, how we leverage the technology for our own use. Blockchain as a platform is a decentralized platform, but the data to be decentralized might have ethical questions on why my data is going to be shared with the public, but it's not the case. It's about how we use the technology for our own good and how we restrict technology to overlook our core values of protecting the data. So I believe if we as a community or thought leaders, if we use the technology wisely, join hands, work for the betterment of the community, we truly will be able to realize the true potential of our people. At the same time, value the emotions and of the both the clinicians, the healthcare providers, and the patients as well. So that's it from my end. Thank you.
Yeah, I would just like to add, India being, India, there are so many patients in the company, in the hospital setting. So usually you would hear that technology is not really the limiting point here. And a lot of technologies that we see coming are more from the Western countries. So when you look at a clinic that is doing 5,000 cases a year, and there's a line of patients, and it's very hard to give them a piece of technology that works in another country and then have them use that for the routine workflow. So when we started, when I started, going out to these clinicians and asking, would you want to use something like this? So their first response was that, how to go about it. Arjun, we start using computers here, then we're going to spend X number of more time per patient, and it's just not going to work out for us. So still we felt that, this will be the way forward, because a lot of these clinicians are the people who are doing research in India. So when they go about publishing these cases, they have to go into those files, take out these cases, put into Excel sheets, and then they go through a very extensive, laborious process. So I felt that, that can be the kind of motivating factor for them to get onto a platform. And we actually released our beta last year, almost about 8-9 months ago, even more, I think. But it just couldn't stand the test of the Indian clinics. So we went back to the drawing board, we made some edits, we tried to simplify it even further. And now we are seeing that, over a period of time, they realize that, it cannot be faster than paper. But at the same time, what kind of downstream applications is it enabling? How is it helping our research? How is it going to help with the undiagnosed cases? And there are examples where, some centers have even come forward and said, hey, why don't we even digitize our rehabilitation center so that we can kind of correlate, the kind of educational programs that they do for, say, children with intellectual disability, how they can see that people with a certain kind of clinical profile were assigned a certain, educational curriculum. So what kind of baseline analysis changes over a period of time? Do a meta analysis and see, can you get artificial intelligence based recommendations that which courses are going to work with a profile of certain children. So having said that, moving from paper onto computer, especially in a country like India, is very, very hard. It's a very hard challenge to solve. But I felt that, it is a problem that we have to overcome at some point. And research was a very big, motivator for some of these centers of excellence to kind of, work with us, suggest recommendations. And then, it's still an uphill battle for us to get this to a point where they see the value that they are getting out of investing those few additional minutes into putting this case on the software.
I would want to know who are your current users?
Ma'am, I would keep that confidential for now. Okay. We are in the middle of a few.
Are they researchers or doctors?
No,
at least that much.
Right. So
academics or industry and hospitals.
These are some of the centers of excellence in specific disease areas, especially on the rare disease and the genetic disease sides. Okay. But then they're also publishing quite a bit of research. Because they do come across some interesting cases, and then they call each other, or they meet in the conference and they say, hey, I saw that interesting case. And I actually overheard some of these conversations on the conferences, and I felt, can we find ways to help them build these cohorts without putting the data privacy into question? So these are mostly clinics right now which are seeing patients, but they are also very active on research.
Okay. So I think the challenge, as you said, the challenge is to use them day to day, especially even by the clinicians. I think one, as you were telling, the challenge even for us is, I would want to put my, my opinion or my request here. If you can, the entry that you were doing, if you could do like, a voice to word, instead of typing, that would be faster. You are technical,
right. We've got that.
The fast test, okay.
Right.
So that is something which as counselors we are thinking, and I've got this request from lots of clinicians also, because
we've got the same request. We are exploring. We are hoping that, and see, the goal is that there are companies in India which are doing this in different vernaculars. So once some of the complementary, technologies in the country, we cannot solve all these problems. So we are hoping that I'm aware of some companies which are doing some incredible work in converting these different vernaculars. So once that start to happen, then I see a revolution of a very different scale in India, because, you have all these conditions from different parts of India. There's a human phenotype ontology who's translated these phenotypes into French, Spanish, for wider adoptability. So I see that, if once the vernacular comes there, not even speech to text. Once the vernacular comes there and we translate that into these ontologies, it will spark a whole revolution. But yes, we hope that this comes to a point. There are technologies that are being used in clinic like that, but we are yet to explore that for the platform.
Okay. I'll just move over a little to Megan. I really love this online, the living lab reports that you say. And I completely agree that you tell them that most of the time when there's a VOS or a negative report, ask them, to come back to us after a year or two for reclassification or reanalysis. We put it on the report, but still, as you said, not many of them come back. But during the post-test counseling, we do tell them that, you go to a doctor or any other counselor. I know in India, we actually do a lot of telephonic from what I do. So I know that wherever, in whichever city they are, there is definitely a genetic counselor. So they would be my colleagues itself. So maybe if they go there, I just tell them that, the questions that they need to ask, I prepare them for that. What I wanted to ask you also is, we have seen some of the clinicians that they want us to give a pre and post-test counseling summary together instead of giving two different reports which the patient might not have, especially in hereditary malignancies. I have got this request from personally by clinicians, because we know that they're going for the test and then they would definitely be getting a report. So what is your opinion about this, Megan? Is it, I know that as a counselors, we need to give a pre and a post test, but what's your opinion here?
I think this question comes up a lot. There's so many different workflows, and we've really seen everything condense more and more. I know in my training, I actually did rotations somewhere that saw a patient once pre-test, they brought them back for test coordination, and then they brought them back again to discuss results. And now, I know in my clinical practice not long ago, I was doing pre-test counseling and then just calling out results. Patients might be standing in a grocery store and I talked to them for 10 minutes about their results, and then I never talked to them again. And so we really need to turn that on its head. So we need to think, where are genetic counselors most needed? What are the most complex aspects of what we do? That should be, what's one-on-one, and everything else could typically be supported by technology. And when you use technology, you can kind of flex it to make it work for the workflow. So perhaps we'd use online genetic counseling reports for pre-test. We also have them for post-test, but then a subset of those patients see a genetic counselor, and all of that can live in the same space, whether that be at My Gene Counsel platform or somewhere else, so that the clinicians and patients can access it as they need it. We really have to be flexible. And I think that's one reason that one of our company's strengths is that it was founded by clinical genetic counselors who understand these pain points, and that our solutions are going to be used in different ways by different practices depending on what works for them. And one of the reasons I've actually stayed part-time in clinic is because I want to still experience those challenges so that I know how to kind of continue to develop our products so they work for people, and so that I can be in those conversations with customers to say, well, have you thought about this for your workflows? Or if that's what you need, what can I do to make that happen? Because it's not one size fits all. And I'll just add that there is not any one tool that's going to fix all of these problems. We really have to create an ecosystem, but kind of collaborating and bringing all the tools into one place so that we can really scale genomics.
To add on to what Megan was saying, I wanted to add on just how we have adapted over the past few years with our genetic counseling. Even with the increased patient load, we have shifted from not even doing face-to-face pre-test counseling. We have an educational video and a chat bot, and that's how we connect with patients and then pick very specific patients and triage them to see them in clinic. So it has evolved from seeing every single patient in person to having different groups and different patient risk-wise, and then seeing them that way. And so I agree, it's evolving. And while the human factor is super important in terms of empathy and providing the psychosocial support, it can come in really at any time.
Shruti, any questions that we have?
Yes, we do have a few questions. Dr. Kunal, would you like to take them? It is in the Q&A.
Sure. I think the first question was for Nicole. It's in the context of FDNA, if I recall correctly. It's about if the application is free of cost, how do you manage the expenses?
Okay, yes, the application is free of cost for clinicians. It is not free of cost for the laboratories using this data, the phenotypic data, in order to correlate it with the genotype. It is also, it has certain areas that are not free as well. So like the research part, like the London access to London medical databases. So this is how it's done.
Okay. There is one question.
The other
Dr.
question
Kunal,
is
you're on
about,
mute.
yeah, sorry. The other question is about telecounseling, emphasizing how it was useful during the pandemic. And it's likely becoming a more traditional method for counseling, and in future it might become. So the question is, what are the pros and cons of it considering nonverbal communication, which I think Amreen highlighted while giving the update on using chatbots and telehealth. So that's one part of the question. The other part is it safe to say 10 years down the lane from now, will there be genetic counseling apps at fingertips of people, and will they have access to certain genetic counselors, for example, pre-test counseling? How do you think it will affect genetic counseling as a field in years to come, kind of thing? So I think the second part is very easy, but I would open it up to our speakers to address the question here.
I'll take on that. Oh, go ahead.
No, you go ahead. I was going to address the second part, and actually I think they're right. Okay. You might be a better fit for the first.
Okay, so for the first part, we actually have a pretty good infrastructure in place because we're, as I showed on the map, we're in Utah, and there's a lot of surrounding states with really rural areas with maybe 1 or 2 genetic counselors in the whole state. And so currently we provide telegenetics to those clinics. And I think while we do lose a little bit of that nonverbal communication, I think at the same time it eases a lot of stress for patients, because rather than having to travel for 4 or 5 hours just for a genetic counseling visit, they're able to sit at their home. They're able to have access to the documents that they need, and if they don't have good internet access, they're able to hop on their phone and talk about whatever information that they need to talk about. So it does increase a lot of access, especially in rural areas where people may not have access otherwise. And I feel like one of the papers that I actually authored is about alternative service delivery models in genetic counseling. And we found that there is actually no inferior patient rapport building or patient relationship, even if we're using alternative models such as telegenetics or phone counseling. And so patients still end up with the same information.
So what about the psychological, emotional aspects of, patients who are going to really tough situations when you have, these conditions? So in a telecounseling or in a chat box, do you think that is satisfied?
I think it also depends on the specific indication, and that's where the tailoring to the patient's needs comes in. So we have seen patients that we see virtually via telephone, and if they have very specific needs, we are able to offer them to come in. So I think that still remains an option. Sometimes people choose to do a video call over Zoom instead of having to come in, and that way they can have lots of their family members around. So there are still options, and doing telehealth doesn't eliminate the option of meeting the patient in person. It's just one other tool that can then help them obtain genetic counseling.
I would like to add here, Rachel ma'am, that yes, your question is right. But then I have also observed that over the phone, the psychological aspect that we are actually covering is somebody's there to actually listen to them. That's the first thing that they want. It might be even over phone or Zoom, as Amreen said, but it's like we are a phone call away for them. So we tell them that we are there, and then they would pick up, and they know that somebody is at least listening to what they want to say. That's the first thing. So we are actually having a rapport, building a contact, and then go on. As you know, it's not a one session, right? So, but at least we are there. They know whom to contact, and if we are not the right person as counselors, we try to find out if there are others that they can go and do. So I think in telegenetic counseling, this is also an advantage, that they need not wait. I think that we are just a phone call away for them. Yeah, sorry. To the next second part, Megan, yes.
No, that's okay. And I'd actually add to that. I think we've all made some assumptions about only being able to support people in person. And I was actually surprised to see that some of our online genetic counseling reports, it's written by genetic counselors. So we're thinking about those psychosocial implications. And we actually had a patient who was a user say she had questions that she was embarrassed to talk to a genetic counselor about in person or by phone. She read about it online, and that was normalizing for her. And she said she actually cried reading about some of the emotional issues of mastectomy, and then did feel comfortable talking to a genetic counselor. Or that there were people who had never heard of a genetic counselor, but through their online genetic counseling report, learned about the value, and then went on to have a telehealth session.
Exactly.
So I think the fact that genetics experts are behind all of these tools means that we're taking those psychosocial considerations kind of into account.
Yeah, I guess they take it more as matter of fact, like it's more common. It's nothing, maybe not just me alone.
Right.
Yeah.
And then for the second part of the question, I have a lot of, especially new genetic counselors, worry that if we're using more digital tools, that we're going to replace them, that they're not going to have a space anymore in kind of the field. And really, I think that as we use more digital tools, we're going to see genetic counselors practicing at the top of their scope. So those most complex discussions where you need a one-on-one interaction the most, that's where a genetic counselor will be. And I think these tools don't take away from the importance of human interaction. It really just amplifies efforts. So we'll be able to keep in touch with the patient over longer distances, over longer times through technology. We're not replacing genetic counselors.
Thank you, Megan. I agree again here with you, Megan, because again, as I said, in my experience, what we have seen is we don't get requests for counseling, either pathogenic or likely pathogenic variants. But then it's most of the time the null reports or the variants of uncertain significance, where the patients, the family members actually call us and ask, and we have more than one session, or definitely more than two, to make them understand. And then yes, it could be, yes, once it's telephonic, then they do a video with all the family members. What does it mean, or what are its implications? So definitely, yes. Again, I agree with you there. Yeah, the next question. There was one question by, yes, Dr. Kunal, sorry. Yes.
Megan, thank you for pointing that out. And I think we've all learned from different sessions here that technology is as good as whatever information you feed into it. So it works for you. It's not the other way around. So the GCs are sort of going to be the driving force for the technology to be used in the clinic for any sort of service delivery models. And to Ambreen's point about the chatbots, a lot of sessions have happened at NSGC on chatbot. In fact, NSGC, the National Society of Genetic Counselors, also put out an online course. It's actually going to be published in the next month or so. We developed it. It's on emerging technologies and tools for genetic counselors. So it includes chatbots and other online digital platforms in utility to serve the patients in research and clinical settings kind of thing. And one minor point, thank you, Dr. Rachel, for bringing in questions that humanizes everything that we are all talking about digital right now here. So thank you for doing that.
I heard a funny quote because in radiology, AI is playing a big role. So physicians have a similar kind of a question: is it going to replace us? So the quote that I heard was that AI will not replace doctors, but the doctors that use AI might replace the doctors that don't use AI. So I think we should definitely welcome.
Well said, Arjun.
Yeah.
The next one I think is along the lines of the AI. So there's one question for Roland, but I'll talk about the AI technology first. The question is, what is the current AI technology in terms of its ability to translate information in various languages, which I think was addressed in some part.
Yeah,
I think Arjun did. And
yes,
this
Arjun.
can help overcome the challenge for genetic counselors that do not speak the same language as their patients. So I think there's some notation about interpretation. And I saw a comment on the deafness as well, the inclusion of sign languages. So if the speakers could address that. Sorry, Dr. Rachel, you were saying something. Would you like to add anything?
No. That's fine. Arjun covered it, is what I was saying. No, you go ahead. Yeah.
Yeah, when it comes to AI, Arjun, you want to go ahead? Yeah.
No, please go.
Yeah. All right. So I don't have the answer for the deafness thing, but definitely I do for the language processing. And yes, we have solutions available using artificial intelligence to translate it into multiple languages. And not only that, we've been working on to decode the billion letters within the DNA code, and we call it as genome language processing, which is way advanced than just a language translation. And AI has been advanced in those areas as well. And when it comes to the translation part, it's not a big thing for AI, I believe. So to answer that question, but when it comes to the deafness thing, I think Arjun, I think you can add on.
Right, I see the question, and it talks about, there's a need for a congenital deaf school databases. So right, so I will get in touch with this particular gentleman and talk about it. We are also working, as I said, on the school on the database on the academic side, for children with intellectual disabilities. When a teacher, once you've done with your analysis in the clinic and you're choosing a specific educational program or set of therapies, you may want to observe that over a period of time, and then later on have a database to compare it with, to take that decision of what should we consider for the patient. So I will be happy to connect with this gentleman.
We are all on mute, Dr. Kunalia.
Oh, okay. Any other thoughts from the speakers on interpretation and utility in different languages?
I would add that.
Yes, Megan, please.
I would just add, from a genetic counseling standpoint, when it comes to online counseling reports or chatbots, you could see where that would lend itself well to translation. So that's something we're keeping in mind. But then again, it could cause issues for people who are vision impaired. So we're thinking about, how could we add audio to support those users, and then, video maybe to support people, who want diagrams and everything, but maybe hearing impaired. So I think technology actually offers some solutions here, even when a one-on-one interaction with a genetic counselor through telehealth that might speak the same language or sign language may not be an option.
Shruti, are we up? Time up?
Yes.
All right.
Almost, but I think we can take one more question, which is from a different perspective. It is mentioned that thoughts on direct-to-customer genetic testing and the challenges. Maybe each of you speakers can make one point or so on that. And what do you think about it? Would you like to start for it?
So yeah, so I work for a direct to consumer genetics testing company. I don't know how much I can talk about this whole scope, but they were published by the Indian Association of Medical Genetics, in which they somehow discourage the use of these kind of prognostic tests. They came from a specific perspective, but in my experience, there were certainly cases where people were benefiting from it. And, especially a lot of these cases would give you your pharmacological profile. It will assist you with the drug interactions. So if that database is with the company, that what kind of medications you're on and something which might not be working for you. So there's pharmacology aspect of it that I saw had some relevance. And then to combine it with the medical history, if they're experiencing any phenotypes and so on. So there are mixed feelings about it. It's just that how you go about genetic counseling is a very big part of it. I can tell you that. And then how nutrition can supplement that. How can you supplement it with biochemical test that can tell you your annual situation of the various kind of risks. So there has to be a lot put around that system for it to be successful. Just one report or session may not be enough. I'll just.
To add to Arjun's point, interestingly, I've been selling whole genome as a service to the well individuals. So there was a lot of it, and that was like 2 or 3 years before, and we were launching it in European market when after the success of Veritas Genetics within the US market. So we faced a lot of challenges within, and we were restricted to sell it through only the top channels within the high net worths because the cost was the limiting factor. However, when affordability concerns were, if it were to overcome, but still we feel that the advanced technology should be leveraged. When I say that, the report should not end only with the pulling out the significant mutation and reporting on the high risk variant. It also should extend to, as rightly mentioned by Arjun, in terms of pharmacogenomic profile, nutrigenomic profile, and also a little bit of proteomics would solve the purpose. I think the right kind of an approach would really solve the problem, and it's believed that it will take the technology would bring us forward, and there will be a huge consumer adoption within this space. Is what the belief system within the society. So definitely, it's going to take things up, and it's going to be commoditized in the near future. But there are a lot of other questions in terms of how significant it's going to impact their life, or the quality of how it's going to improve the quality of life of the consumer who took the genetic test. So if you were able to answer all these questions, then I think, yeah, we'll be able to take this technology forward.
Yeah, the optical mapping is something which you should really consider. When you're putting genome analysis, into an automated thing, optical genome mapping, where you can, very easily capture translocations. Definitely translocations. I mean, like, or even other things like, the chromosomal arrays, duplications, this, that. I mean, I don't know how you're going to, like, there's a lot to be done. You're doing a lot. Yeah.
I think now I request our chairs to summarize what the interesting session that we have had.
Yeah. Kunal, as a genetic counselor, I would encourage you to do that. I'm a basic biologist sitting on your panel.
Without the basic biologists, genetic counselors wouldn't be able to do anything if we didn't know what the genetics was. So that's very kind of you to think of us in that regard, Dr. Rachel. Please go ahead. I would love to hear from you.
You do it, Kunal. I mean, I'm serious. Yeah.
All right. I think it's Sunday evening, so we'll keep it short. Of course, a big thank you to the organizers, the lot of thoughts, efforts, sweat that went into this. Our moderators, Dr. Madhvi and Ms. Shruti. It was truly a pleasure to sort of co-chair this with Dr. Rachel. And above all, our rock stars of this session, our speakers who made such a sort of wonderful, engaging conversation with everyone, addressing all the questions. The biggest takeaways for me from this session, after the summary that we all talked about, was that technology is there to aid our work, simplify our work, not to replace us. And there is a lot of potential, a lot of opportunity. And I'm very optimistic about the use of technology in all of our lives, our respective roles, whether we are genetic counselors, medical geneticists, molecular geneticists, or serving in some other roles in this healthcare ecosystem. To help our patients, right? Above all, we are here to make the best of these tools for our patients. So I'm truly optimistic about it. And once again, thank you to all our audience for participating in your questions, and our speakers and organizers and moderators again.
Thank you, Dr. Kunal, and thank you, Dr. Rachel, so much for joining us and chairing this session. And as you said, rock stars are speakers. Thank you for taking out the time out from Sunday and bringing us all the knowledge at one center. And it was amazing to hear all of you. Thank you so much. With that, we will be ending this session and we will be moving on to the valedictory session. Thank you. Thank you so much.
Thank you.
all.
Thank you.
Hello everyone, I, Gayatri Arayar, Organizing Secretary for the 6th Annual BGC, welcome everyone to our valedictory function. With this session, we come to the last segment of our 3-day conference. Hope all of you have enjoyed the talks, learned from our experts and had a pleasant experience. I now invite BGC President and our Chief Advisor of the conference, Dr. Q. Annie Hassan, to address our audience.
Hello. I am really delighted with the organizing committee for planning and successfully executing this wonderful conference. But my professor always said that it is only at the end that you realize what more do we need to do. BGCI has reached a milestone today with the help of international and national experts in the field. Some of them are here in this valedictory function with me. I would briefly like to say that it was Dr. Maya Thangavelu and Dr. Suchita Bhatt who were the first ones who offered their support to start a genetic counseling program in India. Then it was Dr. Pragna Rao who gave shape to the first genetic counseling course in India. Dr. Vijay Lakshmi Kodati has constantly been a part of the certification process, and along with them, Dr. Lakshmi and I have been founders for the BGCI. But now as BGCI grows, the large group of people are there, and I don't have to take the names of Prochi, Jaya, and all the young genetic counselors who have done this wonderful job. But I need to tell that Dr. Maya Thangavelu, who was with me in 2006 when we thought that India needs a genetic counseling program, I request her to give a brief overview of what was then, how we started, and where we need to go from here. Thank you, Maya, for joining us.
Aini, thank you so very much for the invitation to join all of you. It is so good to see you all. If there is one thing that the last year has done is that we can see one another without having to sit in a plane and travel all the way down to India. It is wonderful. I still remember, Aini, seeing you at the ACAG nearly 15 years ago and talking about what genetic counseling is and the need for it in India, and you took that idea and went on with it. This is so amazing to see what all of you have done there. We've come a long way, and I'm so, so happy and proud of all that you have done. It's amazing, amazing. So thank you again, Aini. You worked very hard on the grounds there. And remember how we used to have the annual meetings, trying to get the clinicians involved. The whole goal was bringing the clinicians and basic scientists together because one of the challenges then was that they were working in their own silos, the clinicians in their world and the basic scientists in their world. And the goal at that point was to bring the two groups together. And I think you have done a wonderful job there, Aini. Thank you and congratulations on that. And thanks again for inviting me. And as I said, you know, we need to keep this going. If there's one thing that came out of last year, is the use of digital technology for us to meet. And we should make this the forum a little more frequent. It does not have to be at formal meetings. We should be having maybe seminars where we discuss some things so that we have new ideas on how to move the profession forward. You have come a long way, but there are still very interesting things that can be done in India because of the very specific nature of the population in India. And I'm looking forward to how I can be part of that group. Thank you again.
Thank you for assuring us that you will continue to be part of us.
Absolutely.
Thank you, Dr. Maya. Before we announce the e-poster winners, I would like to share with our audience that the e-poster format that we adopted this year had an innovative and meticulous algorithm chalked out by our senior members, Dr. Sucheta Bhatt and Dr. Prochi Madan. I request Dr. Prochi to give us an interview of the poster marking system. Over to you, ma'am.
Thank you. Let me share my screen.
Yes, ma'am.
Just a minute. Yes, so is it visible?
Madam, I have already shared. You can see the screen.
Oh, okay.
Yes.
Okay, one sec. Right. So this time, right from the beginning, Dr. Sucheta has given ideas as to how we should have the judging system this year, because last year it was too cumbersome for them to judge so many posters at the last minute. This time we have got 135 entries, and we selected 125 out of them, and we divided these into 10 judges who were grouped into in pairs. So for each section, so we had 5 different criteria, choosing the right test and others. So each pair of judges, one national and one international, had got it. Now, so the evaluation criteria also was suggested by Dr. Sucheta, and this is how we had it. We had invited abstracts, videos, and posters. And so 4 marks were from each judge, 4 marks for abstracts, which was for data, presentation, quality. For e-posters, 7 marks, content, novelty, presentation, visual. For videos, 4 marks, presentation, quality of matter. And for abstract deadline, as well as video deadline and the video timing, which we said 3 minutes, we kept marks again for those who had deviated from this. So can I have the next one? So we have our judges now. And so we had these international judges, Kunal, Smita, Urvashi, Preetha Shetty, and Deepika. And our national judges were Rachel, Jayashree Shankar, Radha Saraswati, Shirisha Vaidya, and Dr. Mala Ganeshan. Next one. Yeah. So this is the way MICE had prepared the platform for us, which at least to me was unique. And it was, so each judge was just given those about 25 posters to judge. And they had, when they open it, like suppose it was abstract number 24, you see the abstract, you see that candidate's video, and you see the candidate's poster. And when you click on it, then for the abstract, you have a marking system and there were even quarter marks. Okay. And so they put the different categories. Next one. And similarly, you could see the video and hear the video and judge them. And the next one. Yeah, and then you could see the poster and then judge them again. And for each one, you have to save your evaluation. The marks go straight to the MICE computer, and the judging of the submission deadlines and the time of the video was done by MICE itself. and all these marks were added. So it was 15 and 15 from the 2 judges, which became 30, and 8 marks from for all the other things by mice. And so we have given our result out of a total of 38 marks. And so that is why at the end, I will be also sharing, besides the winners, the list of and the marks that each one got, because they were so close together that it is not just right to announce only 3 of them. Okay, so you all can try to find your name over there and the marks that you got. Okay, any more slides? So now, yeah.
No slides, ma'am. Over to Gayatri, ma'am.
Yes, ma'am. I now request Dr. Maya to announce the prize winners of the e-poster competition.
So before I make the announcements, I would like to congratulate every single one of you that participated in the poster session. I hope you all enjoyed working and creating the posters, because that is truly a learning experience and it really helps with maturing of the profession. So I do congratulate every single one of you that took the time and the effort to do a project and present it at this session. So having said that, the third prize winner for the posters is Sugridana Pratibhan, and very interesting presentation. Congratulations again.
The only thing missing is the clapping. I think we should unmute and clap.
So, would any of the winners be here live and they can just say hi and say a few words? Is the third prize winner live online?
Yeah, I'm here on the line.
Okay. We would like to see you.
Hi, this is Sugirtana. Good evening, all. I'd like to thank BGCI for granting this opportunity to present, and my mentors, especially Dr. Kumara Manikavel, Dr. Rudra, and other interns who really motivated and helped me with this work. Thank you.
Could we have the second prize winner, please? The second prize goes to Dhanashri Warang from Jasal.
Good evening, all. Thank you for giving me this award. I thank Dr. Prochi Madan, Dr. Arundhati Atle, Dr. Firuza Parekh, and all of my Justlo family. And thank you to BGCI organizers and the judges. Thank you.
And could we have the first prize winner, please? The first prize goes to Dr. Nandini Annamalai. What an interesting topic.
Ma'am, Nandini is in attendee. She is having some issue to come in as a panelist. So.
Okay.
Okay.
So congratulations, Nandini.
This was a very, very good piece of work to just show how important it is in the public sector. You know, we all talk about genetic counseling and counselors working in sophisticated private sectors, but there is great need for them in the public sector, and I really enjoyed this particular one. Thank you again and congratulations.
Thank you, Dr. Maya. I congratulate. Okay, this is
Gayatri, just let us show this.
Yes, yes.
So, Dr. Maya, you can continue.
Yes, so I just wanted to say that, as I mentioned previously, thank you all for taking the time and presenting, taking the effort to work on these abstracts and presenting your data. It is very impressive to see how all these, they were all pretty close, And, you know, it's a good piece of work that every single one of you did. So thank you again for taking the effort and making this conference really worthwhile. Congratulations to all again.
Would the judges like to say a few words? Who is over here? Dr. Urvashi? Dr. Urvashi? Or Kunal? Or whoever else is. Okay, Kunal, come.
Thank you, ma'am, for the opportunity to review the abstracts. I echo your thoughts that the authors actually made it difficult for us. I can, if I may take the privilege to talk about the other reviewers. I think we all have areas that we can improve, including all of us on this panel as well, if I may say so. So, you know, so the top three are there, but each one who submitted an abstract is a winner as well. So thank you again and congratulations.
Thank you. Any of the other judges would like to say a few words?
Hi, this is Urvashi. I very much enjoyed judging it. I really enjoyed the meeting, and I really appreciate the efforts that you all have made. And, you know, we are really, the distance is no longer a barrier. I remember 50 years ago when we were trying to interact with other scientists and clinicians, it took days. And now it's a matter of minutes or seconds. Congratulations, and I wish you all the success in the future.
Thank you, Urvashi. Gayatri, you can continue.
Yeah, thank you, Dr. Urvashi and Dr. Kunal. I congratulate all the e-poster authors for their commendable efforts and thank them for choosing our conference as a platform to communicate their scientific work. I now request Dr. Vijayalakshmi Kodati, Chairperson of the Examination Committee, to take us through the certification process for the benefit of practicing as well as aspiring genetic counselors to get associated with the board. Over to you, Dr. Kodati.
Thank you, Gayatri. Well, I'm myself a practicing gynecologist for the last more than 40 years. But because of my interest in genetics and my friendship with Annie, thanks to Annie.
Hello, doctor. There is two sounds coming from your system. One, you need to off.
Oh. Is it okay now?
Ma'am, do you have the meeting on in two different devices?
Well, I'm just checking. Is it okay? Is that okay? I think it was not opening here, so no. There's new instruments, difficult to find out how to turn off.
I think your phone is on the table now as your laptop. That's the difference. That's why it's echoing.
What should I do?
Ma'am, you can log out from one or you can close the application in one.
Well, I'll just leave it 1 second. Because I was sorry about it. I couldn't get to the login into the computer. So I tried on the phone, it came and then it's working, then this started working. Well, I think Annie should be congratulated for thinking out of the box. And then way back in 2015, she thought that this genetic counseling thing should start. And being a clinician, by then I was already become a geneticist because of Annie and Professor Ahuja and my interest in genetics, did my PhD in genetics. And after that, and then the journey with her was, I think it's like a one-way pathway, that's all. And it's always on the ascending. And today, I think the decision that she has taken that day, which I had a little doubt in our country, what will happen about this counseling and all. but I think, Annie, you have proven correct and right. And I think I should clap that for Annie, really. And then I have already been on the examination committee of the National Board of Examinations, Delhi, and was the first one to start the DNB course in the state of Andhra Pradesh, which was a combined state in the year 1989. And since then, the obstetrics and gynec post-graduation started, and on the board of National Board of Examination, which gives the degrees of DNB, obstetrics and gynecology. And now today I heard from Dr. Dhavendra that DNB genetics also the National Board is planning. And I think, Annie, this is the next job for you. And we have to pursue that. She's nodding her head. Is there enough of it? Huh?
That's not mine. That's clinical.
Clinical.
Mine is
Okay.
genetic counseling. Isn't it, Maya? We
the
are
main thing
on
is the
genetic
genetics,
counseling.
isn't it? I think I have that idea in my mind anyway. And being on the examination board for the obstetrics gynecology, I also, you know, it was quite smooth enough to enter into this. And over the initially, even the examination process has evolved here from the basic examination system, which was mostly subjective, partly objective, and manual corrections and scoring and all that. But in 2018, the Board of Genetic Counseling took a decision with the advice of Special Advisor Dr. Rajiv Sareen also, that there should be a structured objective examination, and the SOPs were laid down for that. And 2018 and 19, you know, we did have very successfully conducted objective examinations on the conventional way. And in 1920, because of the pandemic, we had to change the examination structure. And that was online examination in partnership with Meditrack Solutions, who cooperated with us very wonderfully. And we had a very smooth process of examination, though it was a first-time experience for us for the BGC board, because National Board was already conducting such examinations earlier. I had a little experience in that earlier, but here it was, you know, coordinating so many students for the first time. It was a task, but with the help of all the team. And here I should thank Dr. Suchi Bhatt for, you know, supplying the question bank. It comes from USA, and after coming here, the team of the examination committee members here, I should thank Dr. Pragna Rao, Dr. Gayatri, and Dr. Over the years, you know, and Pavani, as well as, I cannot forget, I will not be pardoned if I don't mention Mr. Percy and his office staff, who are the main contact in between, because the examination questions, they are structured like MCQs, the multiple choice questions, and there'll be 100 questions. And for the level 1 and level 2, it is in a different structure. And they come directly to the office of Percy, and he's our treasurer, the BGCI. It goes to his office, and in his office, it's again formatted, and I go through them for checking if there are any dual answers or dubious questions or such things, or any typographical or spellings or any such thing. I'll take through that along with that team. Then once it's okay, then it goes to the, earlier it would be done here itself, but now it goes to the Meditrack Solutions, which they format into the computer system, that how it has to come in the exam paper. And it is a AI powered artificial intelligence. We have heard so much in all the talks today in the afternoon. And it also is an AI powered remote proctoring technology. So each and every candidate is so perfectly, you know, followed on their cameras, that even if they turn this side or that side, or, you know, picking up something and all, that is not possible. And that remarks are given, which are sent to us later on for them. And the marks are also by this AI RP technology, remote proctoring technology. The remote proctoring scoring also is done, which is later on sent to us. And how can I forget Dr. Lakshmi, who has cooperated so much in bringing the merit track and then going through all these techniques with them. So this system is such a totally objectively structured one regarding this written part is concerned. And it's on par with any other national examinations held or international tests, I should say. And the other part of it, which is the oral examination, the viva part of it, this is again, it is designed in such a way that each candidate is examined by a panel of external examiners, 3 of them. None of the board members or anyone will be there. And these 3 come from different specialities. One is a clinical geneticist, the other one is a genetic counselor, and the other one is a psychologist or a social counselor. So psychosocial aspects will be covered, and each examiner gives their marks independently, and these are later collected, and we have to that will be calculated against the candidate. And 50% is the pass mark for anything, and even in the MCQs and the oral vivas. Apart from this, another mark of logbooks is also added on this. This logbooks or work is the cases recorded by the candidate for their genetic counseling sessions that they have held, and their super, whichever place they are from, whichever state they are from, whichever hospital they are working from, and they have their supervisor will be reporting about their performance. Even that is taken in the last. So this is an overall coverage of the candidates' skills and knowledge and genetic counseling, and their own supervisors or mentors. Recommendations are taken into account, and finally the marks will be scored for them. And I should say that the number of candidates is increasing. Earlier it was 2008, we had about 30 candidates. 19 we had 40, 20 we had 42, and now 21, I think there are about 50 candidates who have already applied. And there is a strict eligibility criteria to apply for level 1 and level 2. And this is all there on our website, so I don't have to tell about that. And I think I should first of all thank Annie for having confidence in me in doing this, and all the team members here of BGCI have worked together in unison, and that is the reason it has come up to this level. And I hope in the future also all the genetic counselors have such a bright future, I should say. That is the only profession, and that ice barrier has to be broken, because Rajiv Sareen was saying that more than 50% of the clinicians are not aware of this. And I think he has been very modest in saying that. I would put it as a 70% at least, that they are not into it. It is so hard to break into them. And this is the greatest challenge for the genetic counselors today. Going to the patients, telling them, convincing them, counseling them, and doing all the tests and everything is okay. But what about these clinicians? I think that challenge has to be taken. It has to infiltrate into the clinical areas, GPs, everyone should be aware of whatever these genetic conditions are coming up and how we can detect them and diagnose them and give a bright future to those children. That is what I hope. And thank you very much again.
Thank you,
Annie.
Thank you so much, ma'am. It will definitely help our students prepare for the coming exam on 31st. This 31st, we have the this year's examination.
Is the exam on 31st July? Of course, yes, that is it.
Yeah. I would now request Dr. B.R. Lakshmi, Vice President of BGC, to give her remarks about the conference as well as the platform experience.
Good evening, all. It gives me great pleasure. And I feel so good, because last year the conference was planned in Coimbatore. And it was the first time we planned the online exam. So I still remember going to see the space because all the students were going to come to Coimbatore and it was going to be an online exam for the first time. But we never dreamt that the conference is going to become virtual. So in March, when the pandemic and then when we had our annual executive meeting, then it was really like, okay, exams are fine because we checked with Meritrack. They said they can still do it at home. But then coming to the conference, so it was an experience by itself. And I'm so happy this year. And as always, Annie says, every year we keep improving. And you can see in front of us the conference virtual lobby. And I think everybody messaged like how good it was. And I think a big thanks to MICE and all the organizers of this conference, because it really gives you a wonderful feel. And then the inaugural part, where Dr. Prochi kept telling there's a surprise, we're really looking forward to it. And it was wonderful. And I should say we have really set a foot. And I think year on year, we are going to make it virtual. I don't know if things are going to go a little this way. And starting from the inaugural function, day one, it was so good. And it was taken up so well, and we had the pioneers and a great inauguration. So this is just a snippet. So we just thought we'll put together with MICE just a snippet to pass through. So day one with the inaugural function, you can just keep moving, and then the workshop. Hats off to Gayatri and the whole team for putting it together. It was such a wonderful session, and it was a full half-day session. And then it was the evening choosing the right test. And I think it was a great panel. And then the genetic counseling, day 2, genetic counseling in the omics era. And again, preparing genetic counseling for global reach, day 2 again, well coordinated, wonderful. And then to know how current trends in medical genetics, gene how, again, which was on day 2. Yes, and again, we had yesterday many hats worn by genetic counselor. So it was again, each one explaining what they went through as a genetic counselor, which I'm sure our counselors would really take lots from that. And then day 3 today as such, the way forward. And it was a great session. And of course, in the afternoon, the panel discussion on patient advocacy group. As I always say, all the work we are doing now, even the starting of the BGCI, I still remember the first interaction with Annie, where something very wide, because we never knew each other, but both of us strongly felt there's not much, because the clinicians are already, they have enough. And definitely to bridge between the patient and the clinician, we need the counselors, mainly the genetic counselors. And I'm so happy we have traveled together, shared the road, and we have come so far. Again, towards today evening, tools for contemporary genetic counselor, and we have stepped up with AI and other things. And just to give a brief, the number of delegates who were there, the registered ones were 3,000 plus. Day 1, the number who logged in were 1,314, day 2, 812, and today we had 650. Of course, it's a Sunday. And all our supporters and sponsors, the Illumina, Agilent, BioNano, Thermo Fisher, MedGenome, LifeCell, Genetico, they all have helped us put things together. I would say a huge thanks to MICE, and of course, all the support groups who came in, the rare disease and others. And of course, again, with Prochi, Dr. Jaya, and the complete organizing team, I think MICE did a great job. I think not even once Kalpesh or Nirav had any extra in their tone, no irritation, nothing. Every time they were so nice. I think a big congratulations to Nirav and Kalpesh, and a big hand to Ariba. I think Ariba has done an excellent job. No words. And all the coordinators, I still remember all the Wednesday and Saturday meetings, and I know it's not easy to put together. And we know last year they were everything was online and everything was new. It was fun, but this time it was like, oh, we have understood. We should really do it very professionally, and I'm happy. Ariba, hats off, Ariba. No words. And I think you really need a holiday after this. You have worked through more than a month, and all the coordinators who have given their time. And I think all of them, I think because we are all counselors again, we understand the responsibility, and in a very nice way taking things forward, because we have been in other professional bodies again, but I think there is a big human touch when it comes to BGCI. And like Annie, it's very close to my heart, and I'm sure it's going to grow year on year. And a big congratulations to Dr. Pruchi. Again, with all her experience and age, she was like a youngster being there. And even I would say 9 o'clock call, I said, it's okay, Pruchi, we'll manage. She said, no, I'll be there. So, and all the others in the US, like Dr. Maya, it's like a family, I should say. And Dr. VG, Dr. Jaya, Dr. Pragnara, all of us. And I think it's more a sisterly bond, because generally genetic counselors, a few in the male side, but still we have we have Kunal, then we have Suraj, and again the male, again forming the team and making it very strong. And I think it's been a wonderful experience, and next year it's going to go to the next level. And I congratulate all the winners and all the participants and all the attendees. And I'm sure we are all very happy. And yes, there is always things to improve, and which we would be doing in the coming years. Thank you. And I feel privileged and honored being the Vice President of CR. And I wish everybody wonderful days ahead. Thank you.
Thank you so much, ma'am. You have made my job very easy to do the vote of thanks. Ma'am has already mentioned most of their names, but still I would like to call upon few names to thank them for their support and guidance. First and foremost, I, on the behalf of the entire organizing committee, would like to thank our patrons, Sri Kamineni Suryanarayana Garu and Professor AJS Bhavar. We owe our gratitude and to our scientific advisors, Dr. Annie Hassan, Dr. B.R. Lakshmi, Professor Shirley, Dr. Maya, Dr. Rajiv Sareen, Dr. Sucheta Bhatt, and Dr. Urvashi Sudhi. We thank them not only for the encouragement, but also for the guidance, as well as for the participation to make this into a success. I thank the organizing chairperson and our team leader, Dr. Prochi Madan, who has strived day in, day out from the inception of the conference to make sure that every loose thread has been tied, and the precision that we could achieve is all because of ma'am. Thank you, ma'am.
Everyone else, the whole team.
Yes, ma'am. I thank Dr. Jaya Vyas, a co-chairperson, who meticulously made sure that every small and big timelines that we had were met throughout the journey. Thank you, ma'am. I cannot thank my co-secretary, Ms. Ariba Khan, enough for her undying efforts, hard work, commitment to this conference. I'm sure the moderators, speakers, and chairpersons appreciate your efforts, Ariba, for the support and the hard work that you have given right from the inaugural to the validatory. You have been around in the Zoom. Whoever has logged into the Zoom must have seen you, must have been guided enough by you, prompted by you to be around. Thank you so much. I also would like to thank all my moderator colleagues. This is because of your brilliant coordination and graceful hosting of their respective sessions. I feel wonderful to be in company of such approachable counselors, Dr. Indumati, Dr. Shailesh Kumawat, Brinda, Sushma Patil, Parichay Rao, Deepa Bhatt, Yashodhara Bhattacharya, Reena Trivedi, Brinda Ramanathan, Dipanjana Datta, Prachi Inamdar, Suraj Manikantan, GK Madhavi Latha, Shruti Mathur, the name goes on. I want to thank Yashodhara for handling all her social media pages from the beginning, Parichay Rao for his tech support from the beginning. We take this opportunity also to thank our sponsors, for also not only for sponsoring but also giving their subject experts for the sessions in the Gene How. Our platinum sponsors, Illumina, Agilent, diamond sponsors, BioNano, other industry sponsors like Thermo Fisher, Genome, LifeCell, etc. I thank workshop partner IPWSO, our associate societies, ISPAD, PSDCA, ISAR, etc. Last but not the least, again, my warmest gratitude to all of you for your professionalism, hard work, execution, and seamless platform experience. The team, Mr. Rajesh Sharma, Nitesh Sharma, Neerav Shukla, Roshni Litoria, Kalpesh Pambhar, others have been extremely patient with our needs, worked on our suggestions, attended all our meetings, and have delivered an excellent output. Though we could not meet and interact in physical world, I'm glad to know that this virtual summit has got around 3,000 genetic enthusiasts under one roof. Hope to see you all in our next conference in the first week of July 2022. Signing off until then, thank you.
Gayatri, is there some video or something you need to play?
Finally, one more announcement.
Yes.
Dr. Hema Purandare has agreed to giving free copies of her book, which was released at the conference, to all the faculty members. Thank you, Dr. Annie, for planning the topics for this conference, because without that, it would not have been so good.
I just would like to take a second to say that, you know, the whole thing works with finance. And if Percy had not helped and given us the confidence that we can go ahead with this, we wouldn't have been able to do it, because Percy always says, just go ahead, don't worry about the money. So that gives us the confidence to do what we want to do without thinking of the money. So, Prochi, I hope your family is satisfied with the success of this, because they were really worried about you. So thank you all. And like Gayatri said, it's late in the day, so let's sign off.
Gayatri, ma'am, video needs to be played.
Yeah.
Yes.
So all of you just wait for the ending.